It's a pleasure and privilege to initiate the third day of the Gurukul classes. We are very happy that the students are joining with great enthusiasm and they are learning from 3 days scientific conclave. This program is designed in such a way that it is like a mock final examination. There are case presentation, there's NST, there's lecture on history taking and examination, contraception, CTG, specimen, drugs, instruments, everything. And I'm sure all the students are highly benefiting from today's scientific deliberation. I'm pleased to invite Dr. Arup Kumar Majhi. Sir is the president of ISOPARB all over India. And we all know, we all read his books on obstetrics and gynecology. He's a very passionate about teaching the students. And in every Gurukul classes, we try to involve him as much as possible because he's a very senior teacher, seasoned teacher, and he's also teacher of teachers. Sir has been professor of Shantiniketan Medical College, Bolpur, West Bengal. As I told you, he's authored so many books: bedside teaching in obstetrics, bedside teaching in gynecology, operative obstetrics. He's former professor and head RGKR Medical College, Kolkata, President Bengal OB-GYN Society, President Kolkata Chapter ISOPA, Scientific Committee Co-Chairperson in ICOG 2023 Kolkata, which we really enjoyed thoroughly. He has 30 years of experience of teaching, and he has been examiners of UG, PG, DNB with more than 100 publications in national and international journal. And of course, he had been editor of Indian Journal of Perinatology and Reproductive Biology and past national corresponding editor of Jogi. We are happy to have Sir, and we want to have some words of blessings from Dr. Arup Kumar Majhi. Over to you, sir.
Thank you. Thank you, Dr. Mala, for your nice introduction to me. And Dr. Mala is very well known for how many, I cannot remember how many decades. And I'm very happy that she always invites me for his Gurukul classes. So good morning, everyone. It is a great privilege for me to welcome you all in this very important program of Gurukul classes organized by the Institute of Obstetrics and Gynaecology, Sir Ganga Hospital, under the aegis of the ISOPARB Delhi chapter. I must appreciate the initiatives of the Dr. Mala Srivastava, our Vice President of ISOPARB in this year, and also the whole team of the Sri Gangaram Hospital. And my best wishes and blessings as a president of the ISOPARB and as a teacher also for success of this program, and hope Dr. Mala will continue this program for the coming years also. And in this opportunity, it is in this event, I only request Mala for future, as there is a program of votes for the OSCE. So I will request Mala to make such a program of the ISOPARB so that we can do in various places, and not in the form of that, but now, Dr. Mala, you can do in other places also, like Garam Hospital. You are doing not only in the Delhi, but other places of your zone you can do for our side. I will be very happy you do. There is no problem of the very good teachers in the ISOPARB. So today, 3 days, today third day program, and I have heard the program is very going on very well, and the topics they have selected actually very beneficial for the students and those who will appear the exam. Today also there is a very good topics of the contraception. Dr. Mala Gudi, who is also the chairperson of that committee, the ISOPARB, will present the contraception, and following which I will go history taking an examination of obstetric cases from 10 a.m. followed by OSCE, and dummy pelvis is a very interesting chapter, which will be presented by Dr. Aruna, and HSG, Dr. Ruma Satik, endoscopic instruments, Forceps Vacuum, Ventus, and specimen and CTG, all are very useful for the student. So my best wishes to all. I think you will learn many things from this, and I will meet again at 10 a.m. With my allocated topics of the obstetric is taking an examination. So thank you all. Long live ISOPARB. Dr. Mala, you proceed to your next program. Thank you.
Thank you, sir, for your words of encouragement. We know we all feel very enthusiastic when we have you and Dr. Hiralal Kunar in our program. But we are very unfortunate that Dr. Hiralal Kunar could not join us. But we are very happy that you still, with your busy schedule of RCOG, you accepted my invitation for the benefit of the PG students. And all my PG students are so happy to have you with us today morning. Thanks, sir. Thanks for your blessings and your dedication to teaching. That is a real teacher that we have in you. Thank you, sir.
Thank you, Dr. Mala. You are for organizing such a beautiful program.
Thanks, sir. Now
and you will spread this program. My request is you spread this program through all the India.
Yes, sir.
The ISOPARB.
Yeah,
now,
under wing of ISOPARB. Yes, sir. Yes, sir.
Okay.
Definitely, sir. Definitely, sir. Now I request a Master of Ceremony, Dr. Huma Ali. I invite her. Dr. Huma is an Associate Consultant, Institute of Obs and Gynae, Sir Gangaram Hospital. Young, dynamic, dedicated, very intelligent and very active consultant of our department. Over to you, Dr. Huma, to carry on the scientific program of the day. I hope Dr. Shobha Gudi has joined.
Not joined yet.
Not joined yet, so I'll just call her.
Okay. Kindly unmute yourself.
Not audible actually. Please unmute.
Hello, am I audible now?
Yes, now audible.
So good morning, everyone. A very happy Sunday and a knowledgeful Sunday to everybody as we move towards the third day of the interactive Gurukul classes. Today, we have very practical and very important topics for all the exam going PGs and for all the students. These are very important topics which we are going to learn today. So to begin our day with, we have our first speaker on contraception, Dr. Shobha Gudi. So we'll be starting the program soon as ma'am will start.
Yeah, she is joining.
So
you can introduce her. Madam is joining.
Dr. Shobha Gudi is a very eminent personality of Bangalore. She has been a chairperson of OSCE 2019 to 2022. She is a professor and HOD of the St. Philomena's Hospital, Bangalore. And she's also a postgraduate teacher examiner. Ma'am had been president of BSOG 2018 to 2019 and assessor of GUI product of Lakshya, board member of FPAI, peer review of Jogi, and she's GCM ICOG of 2021 to 2023, president BMS 2022 and 2023, and she had also been the chairperson of Contraception and Reproductive Health. So today, as we see, we are going to learn from the Master of Contraception. And here I welcome Dr. Shobha Gudi for the third and the first interactive section of Gurukul classes. Over to you, ma'am.
Ma'am said she's joining. I'm sure she's joining. And how many of our students have joined, Dr. Huma? I can see Nikhil only.
I think they're all enjoying Sunday, ma'am.
Because Dr. Shobha wanted 4 students to be on board.
Okay, I'll just ask the students to join ASAP.
Yeah, our own students at least. Because
it is something which is very beneficial for the students, and they will
be. Has joined. Nikhil is there, so I think Dr. Shobha will have students to interact with. Mr. Vinod, just find out Dr. Shobha is joining because she said she's joining.
Yes, ma'am. She's joining.
She's joined. So she can start straight away.
Not joined yet, ma'am, but she's joining. I got a message from her.
Yeah, yeah. Students, you want to know what other topics would you like in the next Gurukul episode? Because Dr. Ashok missed his class yesterday. At 4 p.m. today, Dr. Ashok will take his class on instruments. So we request all the students to keep joined till 4:30 p.m. because instrument is also a very important part of your Viva. And there are small questions which are asked, and it is very scoring as well. We get a lot of marks if you answer well in the instrument section. So I request all the students, and Dr. Ashok has specifically said, no recording of his session. So we are not recording any part of the session. So if all the students must be logged in, if you want to listen to Dr. Ashok instruments section, please be logged in at least between 4 to 4:30 so that you get the first-hand information about instruments from his class. And Dr. Ashok, we all know, is a very seasoned teacher. He teaches very well. In
And
fact,
it is a very important topic too, ma'am.
yes.
Instrument is a very vital topic during the Viva.
And because you score a lot of marks.
Yes, we think we know everything, but there are many questions which are still to be learned because it gets tricky during the exam.
Madam has joined. Good morning, Dr. Shobha. You have to unmute yourself.
Yes, I have joined.
Good morning. Good morning.
Good morning. Good morning.
We were waiting for you. We have introduced you. So
Oh,
you can start straight away.
I can start. I can start. You will have to give me a 2 or 3 minute break in between when I have to sign off from another exercise session of Indian Medical
Okay.
Society.
Great.
But I will start. I will start my class. I must say good morning to Arup Maji sir there. It is, I'm really happy to see sir also here. Good morning, sir.
Yeah. Thank you. Thank you, Dr. Shobha.
Yes,
I have already introduced yourself as the committee chairperson of the contraception.
Yeah, thank you, sir. Thank you, sir. Thank you. So I will just open the presentation and then share. I'm sorry, I'll have to open the presentation. Yeah. Okay, so I'll be sharing my screen now. And I encourage students to ask questions in between so that I'm able to answer. Am I audible well?
Yeah.
Yes, you're audible.
Very well.
Loud and clear.
So, yeah. Okay, I hope my screen is visible. Yeah. Is it visible? My screen is visible, Mala? Yeah. So here I go. Now the thing is, today our discussion will be more highlighted on the methods of contraception and how to prescribe them. Now, this might be a little more than what a postgraduate needs to know, but believe me, when it comes to family welfare and contraception, this is a service which is going to add to your practice on an everyday basis, and it is going to remain there because it is preventive health care, and it should remain there as a part of your overall conversation with any patient you have in the reproductive age group, because it is not only prevention of pregnancy, it is also reproductive planning. It is also doing the smart thing for the family. It's also kind of designing your life by having a good reproductive health. So this is an important message that you must give to your patients and clients who come to you seeking your guidance and advice in every reproductive need that they have. So my effort is to make you into smart gynecologists, make you into the doctors with a lot of insight into what is preventive care as well, apart from the endoscopic surgery that you are going to learn, apart from the difficult cesareans or the instrumental delivery or the high-risk pregnancy that you are going to learn. This also is an important part of your learning. So with that message, I am going to tell you that there is a good expanded basket of choice of contraceptive today. And when we talk about contraception, the elementary thing is to offer the woman a number of methods which are either category 1 or category 2 in the medical eligibility criteria. So then to build up the context and tell you that the earth is going to become highly populous in the next few years, and I have put it here 7.7 billion. It is closer to 8 billion today, the world population. And you know that very, very recently we crossed the population of China, and we have become 142 crores. Believe me, when I started my journey as a champion or at least as a worker for Family Welfare Committee, the population of India was around 135 crores. And see, in a matter of 4 years, 5 or 6 years, it has increased so exponentially. It is 142 crores today, nearly so. And it is increasing every day because you know that high number of population, it will have a self-propagatory effect, whatever is the measure for control that you put in. So if stabilization efforts fail, because they are failing right now, we will have a huge number on planet by 2100, maybe earlier. So that is why, because this prediction that India will cross China's population was for 23, was for 24, but we have already done it in 23, a year earlier. And then our country cannot afford it anymore because we are, a sea-locked continent. On 3 sides we have water, only one side there is land, and you all know that the land area we have is only about 2.5% of the entire earth. But population-wise, we are having 18% of the world's population. So India is second populous. That has changed now. India is equally populous as China, perhaps a little more so. As I told you, this slide is showing 1.36 crores, and China was 1.42. China has managed to stabilize, but we have crossed China. Okay, so this is the same thing which I repeated. And why does this happen? It happens because we do not have a control over unintended pregnancies. If only every pregnancy was intended, planned, and according to the family's wish, then this kind of reproductive wastage where women are forced to seek abortion because this pregnancy is by chance and not by choice, and therefore there is a lot of abortion which keeps happening, unintended births which keep happening, and the unplanned pregnancies are almost 50% of all pregnancies, not only in India, but in the entire world, okay? So the estimated rate is 70 pregnancies per 1,000, and in order to achieve population stabilization, this number should be just 30 pregnancies per 1,000, and that is how it will serve towards its goal of controlling the number of unintended pregnancies. Now, what is our role in all this? These demographic data, these statistics, how is it relevant to our practice? It is relevant because there is a lot of unmet need for modern contraceptives, because healthcare providers fail to highlight the need for contraceptives, fail to counsel for the choice of contraceptives, and thereby the woman's acceptance, couples' acceptance is low. So modern contraceptive prevalence rate is just 40%, and we need to increase it to 70 to 80%. And evidence so far shows that if they do adopt methods of modern contraception, then 74% of women are satisfied. And at any given time, 19% of women have an unmet need. This has been shown to be 10 to 15% in the latest National Fertility Health Survey, but still there is a long way to go. So let us quickly look at increasing the choice. Now, the more the choice, the higher the likelihood that the woman will pick up one of the methods. This is how the government basket looks, that there is a LAM method, there are permanent methods, there are barrier methods, there are hormonal methods, and there are intrauterine devices. And of course, there is some like non-hormonal contraceptives, which are which are centrochrome, and there are implants which have come into the basket now. And then the woman's autonomy has really improved with the availability of female condoms. And we should never forget that there are couples who will not adopt any method because of their cultural, social, and religious inhibitions. And for them, natural methods can be taught in a way that gives the maximum benefit and the maximum efficacy. So when we talk about efficacy to our women, it is important to have a chart like this. I think this is a chart which shows the methods with the arrow on the left side, which this is least effective to most. It's increasing efficacy, and you can see that the most effective is at the sterilizations and the LARC methods, and then we have the hormones, and then we have the barriers, the LAM method, and so on and so forth. So we know that natural methods have the least efficacy, but still can be used for some couples. So now how to make the method more effective? So this is an excellent counseling tool, and this should be there in your consultation chamber, and you should make a blow up of this and put it under the glass top table and keep the arrow away from the woman towards you, and she will be able to see that which is the most efficacious. And on the right side, there are some caveats to follow, which will make every method the highest efficacy. For example, if you talk about injections, every 3 months, she has to come for the injection. If you talk about hormones, then she has to take it regularly. The only benefit is in LARC, where it is fit it and forget it concept, and it is a one-time procedure. So that is how you have to highlight. So we talk about oral contraceptive pills very often, and you all know that a number of pills are available. You will all have them in your table viva when they keep different types of pills. So it's important to have a good understanding. It is important to know that these are the very heavily used across the globe. 25% of women in the reproductive age, they use this globally. But in India, on just under 3% of women use this. And that is because of the fear of the unknown. They feel that, there is going to be side effect, etc. And that is where we come in, and we apply the MEC criteria and give them safe contraceptives. The combined estrogen and progesterone is the best one. It has got the highest benefit in every way. Then we have progesterone only pill, and we also have a different mode of administering these pills, either COCs or POCs, as continuous or extended use pills. The mechanism of action is important to remember, because that is how you know that they are highly effective methods. Very often the PERD index is less than 0.5, etc. We know that it acts on the endometrium, it acts on suppressing the ovulation in the higher center, it acts on the ovaries, decreases the ovarian androgen secretion, and it also acts on the cervical mucus. It also acts on the liver. The estrogen component increases the sex hormone binding globulin and is hugely beneficial in women with hyperandrogenism, because that is how the symptoms, adverse effects get controlled. So apart from contraception, there's a lot of other good work that COCs can do that you all know. Now, COCs have seen an evolution over the years. And when it first started, it had higher doses of ethinyl estradiol needs to be taken per day. But gradually it was realized that you can bring down the side effects and adverse effects of COCs by bringing down the ethinyl estradiol doses to 30 micrograms per day, or even 20 micrograms per day, or even 15 micrograms per day. And the progesterone also kept changing from levonorgestrel to third generation of desogestrel, the fourth generation of drospirenone, and that is how it goes. It's important to understand the concept of what is low dose COC. We all talk about what is low dose COC. So low dose COCs has only one thing to do, and that is it is related to less than 35 micrograms of ethinyl estradiol per day, equal to or less than, but I think in our practice, we should prescribe less than 35 micrograms per day. Most of the modern contraceptive pills are like that. The different regimes of COCs, I have already spoken about the traditional regime, extended and continuous. Now, traditional regime is either 21 with a 7-day interval and 24 with a 4-day interval. Dr. Mala, can I break for 3 minutes or so, 3 or 4 minutes?
Dr. Shobha.
Yeah.
Yes,
please,
yes, you can take a break of few minutes.
Yeah,
no problem.
So I will keep the slide on, and you are welcome to deal with this slide. I will just come back.
Yeah.
Yeah. Thank you. You can also tell me and I will change the slide. Please continue.
Yeah. So we have different regimes of COCs as this slide shows. There is a combined oral contraceptive pills. Traditional regime is, we all know, 28 days, 21 day is active pills, and 7 day is a placebo or inactive pills. And you know, the 21 days contains the hormones, and 7 days are either iron or B complex. This kind of tablets can be there. The other regime is 24 and 4 regimen, the 28-day regimen with less than 7 hormone-free days. So 24 days are active, 4 days are placebo. Extended regimes can be there, where you have more than 28 days of active hormones use followed by hormone-free or decreased interval. Sometimes there are 3-month cycle or continuous regimen taken in an uninterrupted manner for 1 year or more without an hormone-free interval. In extended regime, you can have tablets like seasonal, which have 90 days active hormone, and then there is a gap of 7 days where the patients have the period, and then again they have 3 months continuous pills present. Where we can have the change of the slide. Dr. Shobha, you can change the slide. So I think she's busy. Basically, these hormones, there are of low dose hormones with different varieties of progesterones that we know of. 3rd generation, 4th generation progesterones are there. And there are also triphasic pills. That is triphasic pills that have a different period time. There are different strengths of hormones in comparison to estrogen progesterone. There are different ratios of estrogen progesterone. They are not continuous throughout the cycle. So there are also triphasic pills which are present. And sometimes we have to use them when we don't want to use the continuous higher doses of estrogen progesterone throughout the cycle. Yes, Dr. Jyoti, what is your question? Yes, Dr. Jyoti. Yeah. So WHO eligibility criteria, which is very important criteria for contraception use. So MEC criteria, this is a guideline for using the contraception. MEC 1 is a condition for which there is no restriction for the use of the contraceptive method. MEC 2 is a condition where the advantages of using the method generally outweigh the theoretical or proven risk. MEC 3 is a condition where the theoretical or proven risk usually outweigh the advantages of using the method. And MEC 4, a condition which represents an unacceptable health risk if the contraceptive method is used. Because towards a lecture that you'll find that the word MEC 1, MEC 2, MEC 3, MEC 4 will be used. So you have to remember this chart, that whenever we are talking about MEC 4 criteria, you know that this has to be very restricted. So a recommendation for combined. Yes, you're back, Dr. Shobha?
Yeah. I'll
okay, then you can carry on.
Thank you so much. Thank you. That was really smooth, Mala. Thank you. You are indeed a friend in need. So about the MEC recommendation for COCs by age group. So if you look at the WHO MEC criteria, 2015, and much of which is also inside the MOHFW or Government of India guidelines. So when it comes to family planning, please adhere to Government of India guidelines when practicing in our country, because I think that is what the government expects, and that is your safety net as well for prescriptions and for procedures and for surgeries related to family planning. So when we are talking about recommendations less than 40 years, these are only some examples. We won't be doing the entire MEC, but only to show you some examples. Less than 40 years, from menarche through 40 years, can use CHC without restriction. Okay, MEC category 1, and this includes all the combined contraceptives. And more than 40 years, if you see, that can generally use CHCs, so that becomes category 2. So category 1 and category 2 based on age alone looks like this, but of course there are other elements which have to be considered, which will come into the MEC criteria. The life situation will come, and then any other medical disorders will come, and that is how the MEC wheel will help you to prescribe. So when it comes to breastfeeding women, can we use combined hormones for them? If they are less than 6 weeks postpartum, then we should not use combined. If they are 6 weeks to 6 months, then it is category 3, so it's better to be avoided. But after 6 months postpartum, lactating women can generally use CHC, and that is MEC category 2. So such examples will take you forward. Like this is about the recommendation of CHC used among postpartum women who have no risk for venous thromboembolism. Should not use CHC within 3 weeks if they are not breastfeeding. If they are breastfeeding, it is out of the question within 3 weeks. Less than 21 days with other risk factors for CHC, it becomes actually 1 grade higher, category 4. And if you look at 42 days with no risk factors, it is still category 2 if she is not breastfeeding. And if it is more than 21 days to 42 days with risk factor, then it is category 3. And more than 42 days postpartum who are not breastfeeding, that is 6 weeks in a not breastfeeding women, which is very, very rare in our practice. CHCs can be prescribed, and that is category 1. The entire idea is that estrogen is a procoagulant, and it also interferes with the synthesis and secretion of milk, breast milk. So that is the reason all these precautions are taken. So recommendation for CHC with dyslipidemia. So this is an example for a medical disorder, because dyslipidemia also increases the risk for a woman for exposure to hormones. But if there are no other independent cardiovascular risk factor, like she's not a hypertensive, there is no obesity, etc., then it still remains category 2. All right. So I just wanted to highlight here the benefit of having MEC wheel with you when you're prescribing contraceptives. The progesterone only pill has got a better profile of prescription in the postpartum period with in a mother who is lactating, and most of it is category 2, just like the implants also, and the levonorgestrel pill and implant and etonorgestrel implant, which is currently in the market. That also is got category 2 in breastfeeding women, and so also is the progesterone only pill. When we are prescribing hormonal contraceptives, the benefits and the side effects are very, very important to always be aware of. There is sound benefit of cycle control, menstrual symptoms improve, acne hirsutism improves, there is an bone health positive effect, there is prevention of cancer, which is a very proven benefit of ovarian, endometrial, and colorectal cancers. And of course, contraception, just like other contraceptives, it reduces indirectly the maternal mortality because it prevents unsafe abortion. It prevents pregnancy related complications which come from increased number of birthing. Minor side effects are something which the woman will overcome in 3 to 4 months. Very rarely there is discontinuation due to these side effects, but it's important to inform the woman while prescription that, see, look here, you may get breakthrough bleeding, especially when you are prescribing the low dose pills, 20 microgram, 15 microgram. Some breakthrough bleeding you may have to suffer. There may be some nausea, headache, and these abdominal cramping. This is more when you are using the not low dose, when the estrogen levels are 35 microgram or 30 microgram, they have slightly higher nausea, breast tenderness, there may be an increase in vaginal discharge, but if they are very symptomatic, seek care because these methods do not protect against STIs. Sometimes women suffer from decreased libido, and sometimes there is a weight gain, which is more of water retention and which goes away once the pills are stopped and the woman has a period. So we have to ensure that they do not carry the myth forward that pills will lead to weight gain. They do not lead to weight gain. Everybody on this earth actually is concerned about thrombosis and embolism, venous thrombosis and embolism, while women are on combined oral contraceptive pills. Arterial thrombotic events are very, very rare in healthy reproductive age group women, but venous thromboembolism can happen up to 8 to 10 per 10,000 women. And as I said, MI and stroke, which are arterial events, are only 1 to 4 per 10,000 women. The risk for VTEs will be there in the first year of COC exposure, and the woman has gone through the first year. She is not amongst those 8 to 10 per 10,000. Her risk becomes even lesser than that. But it is important to remember while counseling that the risk given by pregnancy is higher than this. In pregnancy at all times, pregnancy and postpartum, the risk for venous thromboembolism is about 4 to 5 per, it is about 15 to 20 per 10,000 women. It is a higher risk. Okay. Progesterone only pills are also known as mini pills. I think they are prescribed in women where there are contraindications to estrogen, in the immediate postpartum women also, and in women who are hypertensive and have other medical problems. And progesterone only pills are effective, safe, also afford improvements in menstrual symptoms, can be used in lactating mothers, and the non-contraceptive benefits are there is a relief of dysmenorrhea, menorrhagia, and premenstrual syndrome, and they prevent anemia. Minor side effects are menstrual irregularities. So progesterone only pill will give a slightly higher side effect profile of unscheduled bleeding than the combined oral contraceptive pills. Remember, a woman who is seeking regularization of menstrual cycle, for her, it's a combined contraceptive pill which will help, not a progesterone only pill. Now, this risk associated with progesterone only pills, in the sense, these are the situations where we have to avoid POCs and also COCs incidentally. And I think these are common contraindications to all hormonal contraceptives: is current breast cancer, liver disease, liver tumors, active deep vein thrombosis, and pulmonary embolism. These are studies which support the efficacy and safety of low dose pills, and you can see a very encouraging Pearl index of less than 0.5 is the failure, and also one pregnancy occurring in 754 cycles. That's very low. And also discontinuation rate due to breakthrough bleeding is also very less. One thing that you all have to get oriented is the concept of SARC versus LARC, the short-acting reversible methods and the long-acting reversible methods. Please remember that short-acting methods like what we have been talking about now, the pills, patches, rings, are all user-dependent and will be fraught with failure if there is inconsistent use. And there is also a higher fear of negative health effect, because Indian women do not like to pop pills every day. They feel more secure with taking injections, and maybe have an occasional device inserted. So there is a more nuanced information which requires to be given, and more counseling skill which needs to be kind of nurtured in order to prescribe SARC methods with a great deal of continuation rate. But when it comes to LARC, it has got a higher protection, less user error, and a higher satisfaction rate, better efficacy, higher continuation rate, lower failure rate, and some of them have lower failure rate than also the sterilization actually. And they're all estrogen-free LARC methods, long-acting reversible contraception, and estrogen is the primary hormone associated with thromboembolic events, and also with so many other complications. So therefore, in women who have systemic disorders, LARC methods may be better. So these are the commonly available LARC methods today: the copper intrauterine device, the LNG IUS, the injectable, in which the subcutaneous version has also come, and then there is the subdermal implant. And this is a beautiful chart. It shows the efficacy of the LARC methods. You can see a slightly highlighted part here, and you can see that the typical and perfect use are almost similar because there is no user dependence, whereas in other methods, there is a lot of difference between typical and perfect use. So if you can see the implant is 0.05, see the female sterilization 0.5. So the implant appears to be at least 10 times more effective than sterilization even, which is considered a permanent method. So you can see that LARC can have very high efficacy, and the use of LARC methods are very well endorsed by NICE guidelines, ACOG practice bulletin, and even by FOXI policy. This is one product which all postgraduates should know for sure, and that is the injectable contraceptive method. It is known as Antara in the government. It is a very important method in the government basket, and it has got a lot of success in the times of pandemic. And we don't have all these different types. We have only DMPA, and that is 150 mg, and now it is available as 104 milligrams. It acts pretty much similar way: ovulation, endometrium, cervix. You all know the mechanism of action. Now, this is the contraceptive benefits of the injectable. Very convenient, very kind of a woman's private and confidential method. Nobody needs to know that she is using a contraceptive. It's a safe and highly effective, reversible, little bit delay in return of fertility, 7 to 10 months following the last injection, does not interfere with the sexual intercourse. Pelvic exam is not necessary. Suitable for women who are not, where estrogen is contraindicated. Suitable for lactating mothers after 6 weeks. Provides immediate postpartum in non-breastfeeding women, and can be used at any age. That is one thing very nice, that there is no age restriction for this. Okay, then there are non-contraceptive benefits of the injections. This menstrual cramping, etc., reduces. And one beautiful thing about injection is that there is a very minimal drug interaction. There's not much of drug interaction with antibiotics, enzyme-inducing drugs, anti-epileptics, antiretroviral, anti-tubercular, etc. So, which is a feature for the combined oral contraceptive pills and even for the implant. Injections protect against benign breast disease, maybe ovarian cyst and tumors, uterine tumors like fibroids, improves anemia, improves the symptoms of endometriosis, and reduces PID, protects against endometrial cancer and possibly ovarian cancer, and reduces sickle cell crisis and sickle cell anemia. But there are limitations to this LARC method, the injectable. It does not protect against the sexually transmitted infections, including HIV. And of course, it has to be taken very meticulously every 12 weeks, maybe up to 16 weeks. There is a little margin of error, and return of fertility is slightly delayed. And of course, the contraindications, as I've spoken, holds well. The subcutaneous version, I said, we are hoping that 104 milligram with lesser side effects, but the same efficacy will take up very well in the government sector. It has now been released in the government sector, and it has got approval 2-3 years back. This Uniject system, very apt for a single injection and throw away. The best part of it is that once trained, the woman can inject herself and maintain a record. And that is how it became popular in the pandemic. Acceptability amongst users is also very good. And we need to propagate all LARC methods, including the injections and this one, the etonorgestrel implant. I will not take much time on this. This is a rod, 4 centimeter long, 2 millimeter thick. And there is the drug inside this is 68 milligram of etonorgestrel and a radio-opaque material. And there is the efficacy lasts for 3 years as a contraceptive. Once you insert it, at the end of 3 years, it needs to be replaced. And it inhibits ovulation in a very marked way. I already spoke that the implant is highly effective. It also acts on the cervical mucus. There is, of course, some side effect profile like irregular bleeding, etc., which can be easily overcome by the woman when you counsel them treat them with a few medications like mefenamic acid, etc. in between, follow them up and reassure it is quite fine. Now the insertion or removal may cause a little bit bruising, and there may be slight paresthesia. Very, very rarely migration of the implant happens from the arm into the vessels, but that is because of faulty insertion technique. Contraindications are similar to other hormonal contraceptives like steroid sensitive malignancies, liver tumors, and undiagnosed vaginal bleeding, hypersensitivity, etc. As I have spoken earlier, in contrast to injectables, the implant will have slight interaction with anticonvulsants, with HIV medication, antiretroviral, some of the antifungals, and that is how it goes. There is a slight drug interaction because it does induce the cytochrome P450 enzymes, and that much extra care has to be taken when we are prescribing implants to such women. And very simple insertion tray, and this is the area on the inner part of the arm where it needs to be introduced with this preloaded applicator, and requires some training. It's very cost effective because it lasts for 3 years, and a huge advantage. And I think as the presentation is going on, all of you are kind of realizing that I will not be taking the videos because it will take up time. You are all realizing that when it comes to contraceptives, the advantages far outweigh the disadvantages or the risks, whatever are involved. So the wonder thing about implant is that the woman is able to feel it at all times. And if she doesn't feel, it might indicate a deeper migration and she has to report. The contraindications I have dealt with already. Follow-up also, I think I have said already, troubleshooting is important. Unscheduled bleeding should be tackled. And in case it is not palpable, then we can pick it up with an imaging technology. It is also safe in all other HIV infections, obese women, women with migraine, etc. It is possible to give them implants. There is no risk of major adverse effects in women who are prescribed according to MEC criteria. There is no risk of decrease in BMD, in bone mineral density, or increase in stroke or myocardial infarction, etc. So it's really the top choice for women, especially younger women. It's hugely popular with teenagers in the Western world, and our country has to take this up, I think. These are studies in support of implant, and I shall be moving forward because I think I have already spoken about injectable. This is the depot form of the injectable. And sometimes they say that depot medroxyprogesterone acetate, the injectable, has got an adverse effect on the bone density, but that is very reversible. And you can see that the injectable one is very versatile, and even smokers and women with hypothyroidism and women with gynec disorders and women on other medication constitute category 1 when it comes to DMPA injections. And category 2 are little younger girls and well-controlled hypertension, diabetes, etc. Category 3 is early breastfeeders, less than 6 weeks, women with acute DVT, and category 4 are current breast cancer. So that's how it goes. Women with HIV, it is a very wonderful method of contraception, the DMPA as well as the implant. So we shall just move forward because I think, see, this is how unscheduled bleeding is treated. This may come for you as an OSCE in exam, or they may ask you in the OSCE, they may give you the device in your hand, or they may give you the contraceptive pill in your hand, and they may ask you, how will you treat unscheduled bleeding? So these are the methods which have been used. Actually, even mefenamic acid is used. It's not listed here, I think. 250 milligram 3 times a day up to 5 days. Ibuprofen, another NSAID which can be used for 5 days. If this dose can be tolerated by her, which is a little rare, most women will have acidity. But COCs are also an option. If the unscheduled spotting is very troublesome, then for 21 days. But we must remember that only few women report this. Most women are able to bear with it, or most women do not manifest. They manifest more with amenorrhea. Iron supplements can help to prevent, anemia. And in women who are anemic, you must treat the anemia, but this method also helps. Steroid injection procedure, and this is the Government of India guideline which promotes that. There were a few cases which I threw in because I thought that let us bring you into the clinical perspective, and I shall be ending with these cases. There's a 19-year-old unmarried girl, and she reports that she is sexually active. I put it as 19 because less than 18 now. There is a POXO Act in our country which prohibits us from advising on sexual reproductive health matters, because sex is considered illicit and illegal, even consensual sex, before the age of 18 years. Now, this particular girl has got features of PCOS, and also she reports as being sexually active. So we must understand that adolescent girls, between 18 to 21 years, they are eligible for every method that the adult is eligible, including the intrauterine devices. So there should not be any hesitation in prescribing even intrauterine devices to the young. But of course, when it comes to PCOS, we have to prescribe a COC which contains drospirenone, because I think that is what will give them relief from hyperandrogenism symptoms. Then there is this concept of the 21/7 as against the 24/7 pill, 24/4 as against 21/7. And all of you need to understand that 24/4 has unique advantages and are tailor-made for some situations like premenstrual dysphoric disorder. They are also very good for women who have long-term intake of COCs like endometriosis and PCOS, because here you are giving the pill for extended period of time, and you're eliminating the 7-day hormone-free interval, and you'll find that symptomatically these women are better controlled and they do better with 24/4. Now, United Nations Commission on Life-Saving Commodities for Women and Children, way back in 2012, about 11 years back, they have already come across with the factor that if in maternal health, oxytocin, magnesium sulfate are life-saving. You all know that. In reproductive health, it is the contraceptive implant, it is female condom, and it is emergency contraception, which are life-saving. So that means something. That means that preventing pregnancies and preventing unsafe abortions is going to reduce maternal and also perinatal mortality. So, dear students, how dark is your country? Can you see this population density world map? Can you see this? How dark we are. And I think we are becoming darker and darker every day. So dense our population. And can you also see that we are surrounded, we are locked by sea all around, right? And kind of we have only here. And there is no friendly terrain here to go anywhere. So please see that in your journey as an obstetrician and gynecologist in future, this is not just for passing the exam. This is for your entire life that we try to give you messages. See that you prevent unintended pregnancies. Because as far as maternal death is concerned, we believe that one preventable death is one too many. And very, very often when there is a maternal mortality is because of fallout of care, because that pregnancy was something the family was not ready for. Okay. And then therefore family planning alone can bring more benefits to more people at less cost than any other single technology now available to the human race. Thank you so much, everyone. And thank you, Mala, for giving me this wonderful opportunity for connecting to your students. It was indeed a huge privilege for me. Thank you so much. Thank you.
I think Dr. Huma, you can start the next session, and any students want to have some questions, they can ask. Dr. Shobha will be very happy to solve your queries.
There is one question by Dr. Jyoti. I can see in the question answer box. Do we use POP immediately after delivery? So that's a very good question, Mala. I would like to answer that. So see, progesterone only pill can be used as early as 3 weeks after delivery in a woman who is breastfeeding. And in a woman who has unfortunately had an IUD, or she goes home POPs can even be started immediately if sexual life starts, because we all know that ovulation can return in a non-lactating mother as early as 3 to 4 weeks after delivery, as well as after abortion. So there is this concept of immediate postpartum contraception, and in which, you, of course, you have postpartum intrauterine device as one of them. You have implant as one of them. Implant also, in Australia, there's a lot of implant insertion along in the labor and delivery unit. When the women get admitted for labor and delivery, they are also fitted with the implant, so that they go home with the contraceptive. So that is very good for even our country. I hope it comes into practice. And also the progesterone only pill can be used as early as 3 weeks in a breastfeeding woman. Yeah, that was a good question.
There's another question in the chat box.
Yeah.
What is the buffer period of DMPA?
Okay, I can't see that. Okay, okay. So the DMPA is 16 weeks. Buffer period is 16, because after 16 weeks, the woman, if she is getting delayed taking the injection, she should use an alternative method. And if she has not had a period after that, a pregnancy test is recommended. But 16 weeks is the maximum in which it should be taken. There is one more question which is asking dose of COC pills for contraception in obesity. Do we need to double the dose? Please do not double the dose. Please do not double the dose, but just make it sure that woman understands that low dose oral contraceptive pills, even implants, the efficacy in obese women, we need to have, a very close follow-up with them and encourage them to have weight reducing, program also. So that should be the complete management for such a woman. But there is no recommendation for changing the dosage, and one should not do also, because it may not confer any benefit, but it may harm, because there may be more side effects. And remember, see, obesity in itself is an independent risk factor for cardiovascular accidents or events. Okay, can you explain contraceptive mech in HIV on NRTI? So I think I showed that women with ARV, antiretroviral therapy also, you can create a basket of choice. Now, this session was meant more to show you the methods rather than, the deal with contraception in special situations, but that is a very good question. So when you look at the MEC criteria for women with HIV, you will understand that it's possible to create a basket of choice, which will include the barrier methods, will also include the LARC methods, and even COCs can be given in women who are on not on antiretroviral medication, but are on ARV, which is not having ritonavir in their prescription. So it's possible to give them with a MEC category of 2, but if possible, one should choose alternatives. So LARC methods are more suitable, along with the use of barriers, which is a must for an HIV discordant couple or even concordant couple. Yes.
There was a question.
ಅದು ಬಂದೈತಿ ಆಡಿಯೋ ಬರವಲ್ತು ನೋಡು ಒಂದ್ ಸ್ವಲ್ಪ ತೋರಿಸ್ತೀನಿ ತಡಿ ಆಡಿಯೋ ಬರವಲ್ತು.
Oh, okay. All right. Okay.
There was a question that when these women use Mirena, their efficacy is also lost before 5 years. So is that a reality, Dr. Shobha?
Where
in Mirena, if you're using Mirena as a contraceptive in an obese patient.
In obese patients. Okay.
There is a concern that the efficacy may be lost before 5 years.
Okay. So that is not supported by evidence. Fortunately, that is not supported by evidence. There's nothing to say that there is a higher risk of failure. It is not quantified, at least. But yes, we can counsel women that in the 3rd and 4th year, please be on the lookout. And if you have any symptoms related to pregnancy, you can report. But actually speaking, evidence is not there that there is a higher failure rate. Once the device is put, the failure rate, which has not been categorized according to weight. So there is no evidence to that thought. It may be just a thought. And if as a clinician, you feel that your woman needs extra protection, of course, it is worth the effort, and you must go all out and alert her that because of your higher weight, the dosage may fall short. I already said in the beginning that one of the interventions in such women is putting them on a weight reducing program or encouraging them to lose weight, which should go hand in hand with their reproductive health care. There is something else, kindly enlist contraceptives.
Contraception PCOD, yeah.
COD girls, okay. So polycystic ovarian disease is a very heterogeneous condition, and there are different needs for the girls. And very often what we find are obese, hirsute girls with acne, with very low self, what is that called? Self-esteem, and slightly psychogenically disturbed, and very disturbed due to their body image, etc. Because at a time when they should be having smooth, radiant skins, and they should be, kind of feeling so confident about their looks, they are suffering from this. So there is a lot of feeling of poor body image in their minds. So these are girls, for him, you have to go all out, and only prescribing contraceptives will not help. So our message is that you must give them protection from pregnancy. You should also give them protection from STIs. So encourage dual method. Encourage them to have a cosmetologist opinion, or at least some measures to reduce the hair growth and relief of acne. And also, of course, the most important intervention is the weight reducing program. They have to see that they optimize the BMI. Now, to enlist contraceptives, of course, you can make a basket of choice in these girls, but you would want to put them on combined oral contraceptive pills, because that is what will bring down the features of hyperandrogenism. So now today what is available very effective is the drospirenone containing oral contraceptives. So many of you will have a question, why not cyproterone containing? So if, as I said, it's a heterogeneous disorder, and if the girl presents predominantly with hirsutism, then of course you go ahead and prescribe cyproterone containing, and you manage them for 6 to 9 months on that. But remember that cyproterone containing COCs are not approved for contraception. They are approved for treatment of hyperandrogenism. They are not approved for prescribing as contraceptives, and their efficacy as contraceptives is not known. So prescribe another method of contraception in sexually active girls if you are giving them cyproterone. However, equivalent results are for hirsutism and acne are also seen with drospirenone COCs. So you can prescribe them drospirenone containing COCs, even 30 microgram or 20 microgram ethinyl estradiol containing pills can be used for 6 to 9 months, and you can check the Ferriman-Galloway score and see. So a list of contraceptives are combined oral contraceptive pills for PCOD girls with different combinations, maybe different generation of progesterone also works for them, but drospirenone acts best because it effectively increases the SHBG levels, and it functions also as an anti-androgen and reduces the free androgen levels, and also it improves their skin quality, etc. And it also gives them contraception and regular cycles, which is very important for these girls. I hope that has answered your question. Yes. Yeah.
I think we have had a very nice session.
Yeah.
On contraception in the morning.
3 more questions.
Okay. I think we can.
Perimenopausal women, all methods are suitable for them. There is no contraindication. Only thing is you have to assess the risk of other medical disorders. Are they hypertensive, diabetic, and then accordingly you have to prescribe. But in case they have no other medical comorbidities, then all methods are good for them. One word of special benefit of low dose contraceptives in them is that we utilize this window of opportunity to prescribe an early HRT, especially in those women who are having symptoms of hot flushes. And in them, it will also have a positive effect on bone health. But remember that all methods are of good use in perimenopausal. You have to do some fine tuning and also give them the basket of choice. What is the side effect of emergency eye pill? That is the other question. Now, IPL should be used as an emergency contraceptive, then there is not much of side effect. But if women take IPL for every act of intercourse, then they get into refractory menstrual disorders, because after all, it is a progesterone which is taken in a slightly higher dose. And when it is kind of, the withdrawal effect is there, the endometrium will shed. So it does develop into a kind of very irregular period, which is slightly hard to tackle, and you may have to again give her exogenous hormones to overcome that endometrial instability which has been caused. So that is the side effect. Otherwise, there is no documented harm from taking more number of emergency pills, but this is one problem which happens. There is another caveat to be said, that emergency is just emergency pill. They have to go on to a regular method. If what happens if they take it too often, sooner or later there can be a failure. Sooner or later there can be a failure. So they are not as effective if they are used as the sole method also. Then why COC is not used immediate postpartum if breastfeeding? So there are, I think I dealt with this extensively, Pallavi, but I am ready to tell you again that immediate postpartum, the changes in the coagulation factors would not have kind of come down to normal so fast. It usually takes 3 to 6 weeks of the pregnancy change on procoagulants, which are synthesized in the liver. And if we give them estrogens, there is a slight risk of thrombosis and thromboembolism. Also, estrogen has got effect on the hypothalamus and pituitary, whereby it might reduce the prolactin secretion, and whereby the synthesis of milk is interfered with. So the quality of breast milk may come down if it is given early. So for 3 to 4 weeks, for reasons of procoagulant effect, and for 6 months for reasons of inhibition with lactation. That is why postpartum COCs are not recommended. They are category 2 after 6 months. Do we need to follow up with lipid profile and LFT after 1 year of use? Yes, in women with dyslipidemia, or women with known liver disorders. Otherwise, there is no recommendation unless there is some new factor which comes up, sudden increase in weight, or the woman becoming hypertension, or developing some other problem. Then you can becoming a diabetic, then of course you can assess them. Another factor is family history of dyslipidemia. Dyslipidemia has got a hereditary tendency. Family history, if it is there, then of course you have to screen such women. Then what is the effect of POP and estrogen on breast milk? So this is, I think, something that all you guys should read up more and more. It will be difficult to tell in the short span that we have. Progesterone only pills have not been shown to affect lactation in any way, and they can be prescribed. But the estrogen has got a suppressive effect on the quality and quantity of milk, and that is why we feel a little concerned and we do not prescribe them early. Once the lactation is very well established and the baby also goes on to top feed a little bit of family diet after 6 months, then COCs are all right. I think that was a good interaction, Mala, and I think we can,
Thank Dr. Shobha for nice, very interactive and comprehensive session on contraception. And Dr. Huma, I think we can move on to the next session. Dr. Maji is waiting for his scientific deliberation.
Yes, ma'am. So a very thank you, ma'am. Shobha Gudi, ma'am. It was a very wonderful and interactive session. And we are all popping up with knowledge about contraception. You made our concept clearer and clearer. So now we move on to the next speaker on the next session, that is on history taking by Dr. Arup Machi, sir. Sir needs no introduction. He has been teachers of teachers. We all read sir's book during our practical exam, and he's been like savior for almost everybody who has passed the exam recently. So welcome, sir. Welcome to the session of the history taking. And I would now ask you to begin the session, sir. Thank you.
Very good morning, everybody. There is a very good session by Dr. Shubha Gudi on contraception. Many informations all of you got that session, and I think she is also the chairperson of the ISOPARB Contraceptive Committee, and really ISOPARB is very lucky to get Dr. Shubha Gudi. Now I am sharing the session. Sharing my slide. Just help me. Is it visible? Is it okay?
Yes, sir, it is okay. Can you do the full view mode?
Full now, huh? Full.
So the slides only. Can you do the full mode?
Yes. Is it now?
Yeah, it's now.
Okay. So without going into much of other discussions, I am directly going to these important topics, and that history taking and examination in obstetrics. Of all the topics in exam, the most important thing is the long cases, both in the MS and MD. So you will have to prepare yourself how to take the history and how to examine the patient. And not only that, you will have to present that after writing with the stipulated period of time. Sometimes it is given 30 minutes, sometimes it's 40 minutes, usually 40 to 40 minutes you will get in average. So you must, every postgraduates must be prepared to write history of obstetric case and gynec case. My best advice is to you write yourself 2 cases before the exam, and particularly you make a summary. There are many things here, but you do not need to write everything. It is not possible actually practically. So you give the summary, that is very important. You must touch all the points, and the cases history differs from one case to another. Like in diabetes case, you'll have to elaborate the management and the progression of diabetes is like that. Then a PIH case, induced hypertension, will have to stress. But all points you must mention that. That is my purpose, is to for this club. All points you must mention in the history. You may not elaborate it, but during crossing you will say. And so usually the exam in obstetric cases, 2 cases are given: antenatal case and puerperium case. And when the puerperium case is given, there are the 2 patients actually. One is the mother and the baby. And you will have to write separately. I am not going to discuss the puerperium today. And that will be written like that: history of the mother, history of the baby, examination of the mother, and examination of the baby. So, you will have to write separately, little different from the antenatal. So today I will discuss about the antenatal cases. First, you will see patient's particulars. You write down a long case. The broad headings are like these: the patient's particulars, history, physical examinations including cystic examinations, obstetrical examination, investigations supplied and required. Sometimes investigations giving, particularly known investigation, diabetes, Rh negative, all investigation, and also the ultrasonography. If it is not given, you ask for that. Write a summary of the case. That is very important. Provisional diagnosis is one sentence you write. I will show how to write. And differential diagnosis is usually not needed in obstetrics, except like the polyarbenous multiple pregnancy. If you have any confusion about it, otherwise it is not needed. And before going to showing all the slides, I want to state that actually all the pictures in my book and all the pictures have the copyright, so it's already used in only for the students' benefit. I am presenting here how to examine everything else. Now, the details of the patient's particular. Now, this is the broad heading, patient particular. Details. You write down the name of the patient. You write down the age of the patient. You note down the address. If address is not available in details from the patient, actually, you write the rural area, urban area. And most important thing is the distance from the hospital. Because an antenatal patient, when you will come for the delivery in your institution, so you must have to know the distance from the hospital. Next is the occupation of the patient is the very important occupation, how much she has to spend for the daily work. Duration of the marriage, particularly in the history of infertility, because if there is a support 6 years, 7 years after marriage, the patient is having the conception. But these cases, they will have to treat as the very high risk cases. And husband's occupation, particularly our socioeconomic status, their socioeconomic status, religion, parity, and gravida. I will go into detail what is parity and gravida. You can write also later, but here you mention parity and gravida, just at a glance. And bed number of the patient, date of admission, residence. This is the patient's particular. Next, according to the age, what is the importance of the age? If you go to the age, there are some importance of the age is the teenage pregnancy and the elderly patient. Teenage pregnancy, particularly when it is the 17 years of age, they are the high risk pregnancy due to the more chances of the preeclampsia, more chances of the anemia, more chances of the liver dystocia, and more chances of the after delivery there is the lactational failure or like that. So the teenage pregnancy, you will face the questions, what is the importance of the teenage pregnancy? And also the importance of the elderly patient, elderly called actually elderly private after 35 years of age concept. But in true sense, when the age of the woman more than the 30 years, there is a chance of all the abnormalities, particularly the medical disorder in pregnancy, the diabetes, and also the pregnancy specific disease, preeclampsia, toxemia, and other the hypertension. There is a more chance. And uterine fibroid, and during the delivery, there is the abnormal uterine action and prolonged labor. There is a more chance of the operative delivery and the cesarean section. And also that is also true for the teenage pregnancy. There may be injury of the genital tract. And after the delivery in elderly patient, there is also the problem of the lactation. So you must know these are the questions. What are the importance of the teenage pregnancy? And what are the importance of the elderly pregnancy? And according to the recent NFHS, National Family Health Survey, now the 5 is going on, just released into last year. The 23% of the women and got married for attaining the legal age of the 18. This is the most important problem in India. And teenage pregnancies has come down from 7.9% to below in the last NFHS criteria. It has come down. Now, what is about the other thing? The chief complaints. How do you write it? The history. The chief complaint and complaints and history of the present illness, menstrual history, present obstetric history, past obstetric history, past history. You make this line, these points important. Family history, functional history, personal history, medical history, and history of allergy, contraceptive history, social history, and birth preparedness. Chief complaint or complaint. Usually the patient who has admitted, she has some complaint, usually, but there may not be. So if you do not get any complaint, she has no complaint, you write that she has been admitted for the self-delivery in the hospital, you can write. Or if there is a chief complaint like the pain abdomen, and like a chief complaint like the she has been diagnosed as the hypertension for which she has been admitted. So you like that, and you can write also the amenorrhea for like 9 months or like that. You can write. But it is the amenorrhea is not the chief complaint. You'll have to write something. And I have already said, if you know nothing is chief complaint, you write that she has been admitted for the vaginal delivery. She has been admitted for the delivery in the hospital. Now, history of present illness. You see, number 2 point and number 4 point. History of present illness and history of present obstetric. History of present illness means you elaborate the chief complaints. Suppose the patient has come with the pain abdomen, and you elaborate what is the nature of the pain, whether the pain has been subsided now, and what the frequency of the pain, or what the site of the pain. And naturally, you will be asked in exam, what are the causes of the pain in the last trimester? You will be prepared for that. Like the commonest is actually the round ligament pain, and sometimes there may be pain due to the false labor pain. So you will have to be asked what is the difference between the false labor pain and the true labor pain. False labor pain is usually subsides, there is no progressive and not consistent with the uterine contraction, and there may not be other findings of the onset of the labor, like the dilatation, cervical effacement, and the formation of the bag of water in the soup. So you have to differentiate it, the character of the pain. How will you differentiate? This is an important question. One is the how will you differentiate with the false labor pain and second labor pain, and another is the what are the causes of the lower abdominal pain during the pregnancy. And this is the elaborate the present illness means. Suppose if there is a pain, and suppose it's the bleeding. Second point. Now bleeding. A patient has been admitted with the bleeding PV at the last trimester, the antepartum hemorrhage. So you will have to take some also, other than the clarification of the details of the bleeding pattern, you will have to whether it is the associated with pain or not. Because bleeding of the due to the abrupt placental or accidental hemorrhage is usually associated with the pain abdomen. And also, if there is a abrupt placental, there is a chance of the hypertension. So there is at this point you have a scope to take. You ask whether she has been suffering from the. So this is like that. And if there is a preeclamptic toxemia, you'll have to take also the history or the past history of the hypertension like that. Now, menstrual history. I will go into the details in the menstrual history. The patient obstetric will say I will go. So you will write down like this, and menstrual history in the detail. Now LMP. If the correct LMP you will have to take first day of the last menstrual period and expected date of delivery count by the Aegis formula, and you also count what is the period of amenorrhea, because it is best to present the cases. What is the period of amenorrhea of the cases? The examiner wants what is the period of amenorrhea from the LMP and ED. And you write down the age of merarchy, duration of the marriage, interval in days, regularity of the cycle, pain during period, amount of bleeding. But you do not get so much of time for writing. But you remember this is abnormality, write this. Now, the calculation of the EGG is very important, and is like that calculation of the EGD. The pregnancy is dated from the last menstrual period, and the last menstrual period, and total duration is considered is the 280 days. Expected delivery it is calculated from the Negli rule, and the estimated depth of delivery is obtained by adding 9 months 7 days to the date of first day of the last menstrual period LMP. And Negli rule is based on that 28 days regular cycle and ovulation assumed to occur on 14th day of the 28 days cycle. But one thing is remembered, if there is a problem, sometimes the pregnancy is not regular. Suppose she has the 35 days interval or 40 days interval. So actually the pregnancy gestational age is actually from the date of the ovulation up to the expected date of delivery, up to the date of delivery. This is and the in a ovarian phase, you see the last phase, that is the follicular phase, and also the luteal phase. The luteal phase is almost constant of the 14 days, but the follicular, if the pregnancy, if the menstrual cycle is lengthened than the normal, so additionally, suppose it is the 35 days, so additionally 7 days is added. So you'll have to reach the EDD will be plus 7 days. And if it is a 28 days, you will have to minus the expected delivery, 7 days from the expected delivery. So you will have to calculate. And you may be asked in the questions, how would you calculate? There will be whether how to calculate if the menstruation is irregular. That is, I am telling you. Now the antenatal care, the history of the present pregnancy, or present obstetric history. So you will have to take in details. Number one, how many antenatal care is, and what is the first antenatal visit, and what is any important event in the first trimester, like the diagnosis, date of diagnosis of the pregnancy is noted, history of threatened abortion, hyperemesis gravidarum, folic acid supplementation, history of any fever, urinary tract infection, and because there is a urinary tract infection, you will have to treat. Otherwise, there will be chance of prematurity, chance of preeclampsia also, and any USG scan at that time available, particularly the date is scanned. The second trimester, a patient usually cannot tell the exact date of quickening. That is very important, but he can say it was on 5th month or 6th month. Third trimester, important parameter, you will need to know anemia, antepartum hemorrhage, and preeclampsia, which happen at that time, and fetal growth restriction, and preterm labor or any fever. History of iron, calcium intake, injection tetanus toxoid, and now it is the not the tetanus toxoid, it is given the TD, T injection is given, and also in private sector TDAP also, it is also given. Government sector TD is given, tetanus as diphtheria, in the same schedule like the tetanus toxoid. And detection of the diabetes, hypertension, and any other disease during the antenatal period, what are the time of the diagnosis, and what drug is taken, and what frequency, and then the changing of drug. That is very important. History of present pregnancy. Relevant investigations on the management for this particular disease. If there is a heart disease, if there is a renal disease, if there is a diabetes, if there is an anemia, what are the treatment is given, and the history of iron intake. The government of India, that is the Anemia Mukt Bharat. It is that iron intake should be as early as possible iron, not the 100 tablets, now, and it will continue after the delivery of 3 months. And calcium is the routine supplementation in India pregnant mother, because India is a country of the calcium deficiency woman, but not in case of the European country. They do not give the calcium routine. The advantage of the calcium is that if there is a deficiency that may preeclampsia or they may cause, that is the calcium you must give in the usually in the second trimester, 4 months or more. And USG finding is detailed, including the early scan, NT scan, anomaly scan. These are now routinely done. And if say the dating scan, you must examine dating scan. You see NT scan or there is an anomaly scan. Now, what do you mean by parity? What do you mean by gravidia? Parity means gravidia means a pregnancy state of both present and past, irrespectively of the period of gestation. Gravidia, that is a present state, pregnancy state, both present and past, irrespective of the period of gestation. And parity means only previous pregnancy or pregnancies reaching beyond the age of viability. Now the age of viability is considered, it is after 24 weeks, in contrast to the previous concept of the 28 weeks. So what is the number of children after 24 weeks, previous children, previous birth, after 24 weeks, whether she is living, that baby is living or dead. That is the parity. And you can express 2 ways. X plus Y. X means the previous viable pregnancies, and or pregnancy. Y means the pregnancy before the age of viability. And another best method is the F-fall. F-fall, that is a mnemonic, is F-fall. And the living issue, if the patient is living issue, right knee, if the patient is 5B, last childbirth, what is the duration of the last childbirth? You just write the ST of the previous pregnancy. And mnemonic of the F4 is the first digit refers to the number of the term infants, F. The second digit to the number of the preterm infants, P. And third to the number of the abortions, and fourth to the number of the living children, L. You do not say this mnemonic to the examiner definitely, but it is really helpful to remember you. P4132 means woman had 4 term deliveries, 1 preterm delivery, 3 abortions, has 2 living children and alive. So you write down this. When you present the case, it's better to like in this manner. The C has 4 term delivery, 1 preterm delivery, 3 abortion, has 2 live children. Now, past obstetric history, how will you write the past obstetric? You make the table. It is very easier table, not at all difficult. The serial number, including all the pregnancies, the abortion, ectopic, the preterm delivery, serial number, year and month, and pregnancy event, the term pregnancy, preterm pregnancy, also the abortion. You write the pregnancy, but it is abortion. You do the abortion and is like 8 weeks or 10 weeks, like that. And pregnancy event, there's the hypertension, blood pressure, diabetes is like that in the antepartum hemorrhage. And labor events means you write down the duration of the labor, when the labor started, it is on the term or not, and what is the, if there is a prolonged labor, and what is there is a particularly during the labor there is a convulsion, or during the there is a retained placenta or like that, and the postpartum hemorrhage, and there is the infusion at that time. You must write there labor event and mode of delivery, whether it's the spontaneous vaginal delivery, the vaginal delivery, normal vaginal delivery with episiotomy, without episiotomy, or you can write the instrumental delivery, the forceps or the ventricles, or cesarean delivery. So if there is the abortion, the post-abortal, whether there is dilatation, evacuation, or dilatation, equilibrium. And regarding the baby, you have the baby at present of the living or not. Maybe if there is the baby is immunized, what is the condition of the baby. So past obstetric history you write down like this. Now, risk of the pregnancy which has effect in this pregnancy by the previous obstetrics. Risk of this pregnancy. Unexplained stillbirth. Unexplained stillbirth is the common question of the examiner. What are tell me 2 causes of the apparently unexplained stillbirth. One important thing is the undiagnosed gestational diabetes. They are not diagnosed properly, and it happens actually in reality. It is not diagnosed, it is not properly investigations are done. And another is the cholestasis pregnancy. The time of intermittent death of the fetus is considered for delivering this pregnancy, because when the death occurs at that time, so that is also critical time, may be critical at this pregnancy. And in the cholestasis of pregnancy, and now it is very important that one of the important causes of the pregnancy complications of the cholestasis is the fetal death, particularly after 37 weeks of pregnancy. And now the parameter has come, the bile acid. It is the itching and mild jaundice in a mother. You must do the LFT, that may be increased, and bilirubin not present, and you do the specific marker, that is the bile acid, whether the bilic acid is dangerous to the fetal death. But particularly the standard dictum is to don't continue the pregnancy after 38 completed days, as early 37, 30 days to terminate the pregnancy in case of cholestasis. The mode of delivery, particularly previous cesarean section, instrumental vaginal delivery, previous pregnancy, needs special planning for this pregnancy. History of prolonged labor and difficult vaginal delivery, birth of the asphyxiated baby, trauma, PPH should be kept in mind during the delivery of the current pregnancy. And there is increased chance of fetal growth restriction with previous delivery of the growth restricted fetus. And previous birth of the macrosomic baby may be related with the gestational diabetes or undiagnosed diabetes. And there may cause the shoulder dystocia. There is chance of recurrence if there is a delivery of the congenital abnormal baby in the previous pregnancy. That is, family history is also important here. Now, past history, medical, gynecological, and in any anesthetic difficulties, medical, gynecological, surgical, and anesthetic. That is very important. If there is any anesthetic difficulty in the last any surgical event, there may be the problem of the intubation or like that. The medical disease, these are the routine you will say, take the diabetes, hypertension, bronchial thyroid disorder, tuberculosis, renal disease, heart disease, epilepsy, rheumatic fever, HIV, thromboembolic disorder, ricket, myasthenia gravis, neurological disorder, psychiatric history, multiple disease, history. But you do not need directly, you do not ask that. It is not possible, all in detail. But you first ask the mother, if there is any problem, any disease like that, she will tell. And particularly, you will ask some of the diseases, like hypertension, diabetes, like that. And if there is, but not other disease, she will tell you. She will tell you, this, I am suffering from this and I am taking the drug. And gynecological history, PCOD, this patient suffer from the PCOD, there is a chance of the preterm labor and the high risk pregnancy. And ectopic and PID is a BVA-BPR, CPDPR, and prolapse DPR. CPT-DPR, prolapse DPR, you have to think of the mode of delivery, change the mode of delivery, vaginal to the other, the abdominal method. Family history, that is very important, particularly some of the history, diabetes, hypertension, thromboembolic disorder, and the history of birth of the baby with congenital anomaly increases the chance. Tuberculosis, blood dyschizia, severe psychotic disorder. If there is cervical psychiatric disorder in the pregnancy, in the family, so there is maybe a chance of the prepubertal psychosis. So these are the very important. But you will remember, and patient will say about that. Now the social history and diet history. Social history is very important. How much family member, whether the support will be available at the time of the when patient will be in the labor, and so if the person is available at that places to bring her in the hospital, or you'll have to admit the patient prior, if possible. And birth preparedness. Birth preparedness means this is a new terminology, not very new, over 10 years is going on. Sometimes the short note comes in the birth preparedness, preparedness for the family, preparedness of the patient herself, and preparedness for the transport available, and preparedness for the where she will be delivered. All these things are the birth preparedness, and also the financial. Now the government of India has almost given all free of cost, but they will have to think whether they know of all the things of the thing. And in the you'll have to take up the history of the how many people live in one room, so 5%, so like that. You have to take the history details. And contraceptive history is very important. Contraceptive important is that the before pregnancy, what contraceptive is used or not used or not. Duration, times, and last use of the contraceptive. Sometimes after the withdrawal of the contraceptive, there may be some false amenorrhea, and patient conceives during the amenorrhea. So 1 or 2 months there will be amenorrhea without any pregnancy. That is the expected date of delivery. Maybe change. The most important point of the today is the dating scan. Dating scan is the more specific point to diagnose the duration of the gestation and the duration of and the medication. And in the drug allergy or the history of corticosteroid or any drug allergy like the sulfur drug, penicillin drug, or any drug. Now, physical examination. Physical examination is these are the points you must mention. You must write the point. You must write for the broad heading, all the history. And you must rest of the physical examination, build, nutrition, height, weight, anemia, cyanosis, jaundice, and also the mouth, the tongue, teeth, gum, tonsil, neck veins, so the neck veins, neck glands, if there is any, and that may be thyroid or the lymph nodes there, leg veins, and the pulse, respiration, temperature, BP, and few systemic examination. Because in postgraduate, the examiner expects you have examined the stetho, you put on the stetho, you put on the particularly on the heart area, the fecal area, put on the respiratory system, just use the sound.
And GI system, in obstetric examination, you must examine the liver and spleen, must. Because if your case given in a case of anemia, you have to exclude the thalassemia, hepatosplenomegaly. That is almost many patients suffer from the anemia. And you will have to palpate the liver spleen. Write down the liver spleen not palpable or enlarged if there is anemia. Examination of the other system, the skeletal system, neurological system, ophthalmic system, urinary system. This is the patient's complaint. And if there is a patient suffer from the preeclampsia eczema, in your case, you must have to see whether there is ophthalmic examination is finding is given or not. And then naturally you will be asked what are the problems of the eyes during the severe preeclampsia and the eclampsia. Build means actually the average, the skeletal femur. Build. You write down the average build or like that. Nutrition. How to assess the nutrition? The skin thickness, that's the most important. And mid-arm circumference, how to assess? And you write the poor nutrition or good nutrition or obese, you can write also. And if there is a vitamin deficiency, malnourished, particularly if there is a glossitis, nutrition. And height, you measure mass, where you take the exam, and edema, I will see how. Height, short stature, what is the significance of the height? Significance of the height. Suppose in exam, how to measure the height? You bring the college, keep a tape, large tape, You bring the patient, there is no way of the examination hall. You bring the patient to the wall of the examination hall and mark the upper height, and then you measure the tape, And what is the significance of the short height? Short stature woman is usually associated with small pelvis and low birth weight baby. There is no consensus on upper limit of the short stature, but normally 140 centimeter, that is the 4 feet 7 inches or below, is considered the short stature. In some populations, short stature means below 145 centimeter, 4 feet 9 inches. This is asked in the exam. Now the weight, write in kg, assess overweight or thin or underweight. And body mass, BMI, you must calculate the BMI. BMI less than 18.5 is the underweight, 18.5 to 24 9 healthy, 25 to 29 9 is overweight, and more than 30 is the obese. So this you must be prepared for that, to face the questions. BMI. Weight should be taken in the first visit and subsequent visit. For measurement of the BMI, actually, the woman with BMI before the delivery, that is the most important. Before the pregnancy. Otherwise, you take the in the first contact, take the weight. That will be calculated for the BMI. And women with BMI, women with the BMI, where there is a BMI is less than 18.5, there is a risk of the low BMI. There is a FGR, a high perinatal mortality. Whereas there is more than 30, there is a rise of the macrosomia and hypertension, GDM, and macrosomia, high perinatal mortality. And incidence of the overweight and obesity among the Indian women, according to the new NFHS data 5, is the 24%. You can imagine India, 1/4 of the mother is already the overweight and the obese, and it is really maybe the epidemic. The obesity may be the epidemic. Now edema is very important. You know where you see the edema. Just above that. This is very important, edema. Where you show the edema. Where you will see just above the medial malleolus, elicited by the pressing with the tip of the right thumb, at least for 15 seconds. You say 15 to 30 seconds. You see the place you see. This is the medial malleolus. This is the malleolus just above and medial. The medial malleolus. Many students show here. My experience. They show here. Many students is here. Not like this. Medial malleolus is just above the medial malleolus. And 15 to there. And you see the tip pitting edema. Also the tipping edema. The pitting edema. The non-fitting is due to the hypothyroidism. You say. So this is the fitting edema. And then obviously the question will come: what are the other causes of the edema? And what are the sites of the edema? This question. Sites of the edema are the anterior surface of the lower third of the shin bone, torsion of the foot, and over the racrum and parietes and over the vulva. You see the dorsum of the foot here, also can see. But primary place is here. And also the shin bone, here you can see the shin bone, and sacrum, and also the parietes is the shin bone, and over the vulva, you can see the vulval edema. Now, anemia and fallow. And what are the causes of the edema? If you are asked in the exam, you face this is the physiological edema. And you say there is some pathological edema, is like what is the first say is the hypoproteinemia and the malnutrition, hypoproteinemia. And second is the heart disease and the kidney disorder, like the other thing. But you say the physiological and some important pathological. Now, anemia and fallow. Anemia will show the lower palpebral conjunctiva. You ask the patient to look upwards and see the lower conjunctiva. And dorsum and tip of the tongue. Other side is the dorsum and the tip of the tongue. Short palate and nail beds, palms and the throat. So one important point is the anemia. These basic things you must know. Yeah, these are the basic things, very basic things. I have seen many students cannot answer. That is I stress on this thing. And this is the demonstration. Preferably with the sunlight, but anemia is not necessarily sunlight. Jaundice is always sunlight. But you show the anemia like this, lower palpebral conjunctiva. And naturally, you will be asked what is the incidence of the anemia. A pregnant woman and 15 to 49 years in the recent NHS is more than 50%. Can you imagine? Anemia, the 11 gram percent. If you consider the anemia less than 11 gram percent, the India suffering from anemia more than 50% cases. Then in the classification of the anemia, what is the mild, what is the moderate, what is the severe, and what is the very severe. Mild is that below the 10 to 10.9%. Moderate is the 7 and less than 9.9 gram percent. Severe is 5 to less than 7%. Very severe, the 5 gram. So there is the anemia Mukt Bharat guideline. How will you manage the anemia in which pregnancy, in which period of pregnancy, and what will be the when with the indications of the oral, only oral, or the indication of the injectable, and what is the indication of the blood transfusion. You must be prepared for that. There is a anemia Mukt Bharat guideline. This is the anemia. And recently, not very recently, the other than the iron tablet, the India government guideline is the anemia Mukt Bharat. He gave the helminthic 1 dose albendazole 400 at the second trimester, not in the first trimester. Definitely no drug is safe in the first trimester until and unless known. So second trimester, you give the one type of the helminthic. This is the principles of prevention, the prophylactic management of the anemia. Now, naturally, in as the almost every patient you may suffer from the anemia, and if you leak the anemia one plus like that, so you will have to do what is the commonest cause of the anemia? There are iron deficiency anemia, and is the iron deficiency anemia, and other of the hemolytic anemia and hemorrhagic anemia, particularly the chronic bleeding in case of antepartum hemorrhage, and hemolytic that may be due to the RBC disorder, and also the malaria, Now, the characteristics of the iron deficiency anemia it must be examined here. The hemoglobin at the 11 gram percent, and total RBC count less than 4 million, fat cell volume 30%, MCB 75 cubic millimeter cube less than, and MCA is 25 picogram, MCA is less than 30%. And RDW, red cell distribution, will be high. And serum iron is the less than 30 microgram. And serum ferritin is the 15 less than 15 microgram. And total iron will be. But the gold standard for iron deficiency is the serum ferritin. So next question will be, if the serum ferritin is not available, how do tell one important point, one important parameter, that is the RDW. That will be high, red chill distribution wide. That is the RDW will be high. But the gold standard for viral deficiency anemia is the ferritin level, which is less than 15. Now peripheral, but we are in the IDA, microcytosis, anisocytosis, fibrinocytosis, hypochromia, slight increase of the disease. This is the very common question asked. Recent investigations to the diagnose IDA, free erythrocytin, protofirin, serum transferrin receptor. Now, sites to detect the cyanosis. How will you detect the cyanosis? Peripheral is the tip of the nose, ear lobule, outer surface of the lips, cheek and chin, tips of the fingers and the nose, and nail beds. The central cyanosis is the tongue, inner surface of the lip, gum, soft palate, all sides of the peripheral. Usually, the patient suffering from the cyanosis is not even in the exam, but you may be asked in the exam, what are the peripheral cyanosis, what are the central cyanosis, how to diagnose. Now, jaundice, this is very important thing in exam, and usually if there is a patient available, you must be giving the patient of the jaundice. This is the upper bulbal conjunctiva. Always bring the patient to the sunlight, and other places is the undersurface of the tongue, soft palate, sole and palm, and the skin. You bring the patient to the sunlight and ask the patient to look downwards. So the upper bulbal conjunctiva, and you also see the undersurface of the diaphragm. Anemia is in the superior portion, and also the soft palate. The patient asked to show the soft palate by depressing the tongue. This is the ideal. So this is the window. My postgraduate training is seeing in front of the window, always in the sunlight. And now some causes are the common causes of the jaundice. One thing is the common is the viral hepatitis. Hepatitis is the common, hepatitis B, hepatitis J, and most dangerous is the hepatitis E, hepatitis Z, and maybe hepatitis C. And other is the hemolytic jaundice, and other is the obstructive jaundice. But some cases, in pregnancy specific cases, is the acute fatty liver, imperfecting cholestasis, and HELP, and infective baptism, pregnancy, and the differentiating feature. You will see that differentiating feature of the fourth thing, the transaminase is more in case of the infective hepatitis, but less in case of the intrahepatic disease, and acute fatty liver and HELP is the less than 500, HELP more than 500. And bilirubin is variable in infected, they may be very high. Acute fatty liver more than 5, intrahepatic cholestasis less than 5, HELP is also 5. So these are the important differentiating features of the four things that are specific for the diagnosis of the jaundice. Now, measurement of the BP is very important. Blood pressure is measured in either in sitting posture or in a semi-recumbent position, and angle of the 15-degree relaxed attitude with a slight left lateral angle of the 30-degree, and with a light left lateral tilt. Now, measurement of the BP, the sitting posture, you can see the mother is, the examiner is, the obstetrician is talking, and also she is smiling face. That should be the desire. That should be desire. If it is relaxed, I did half an hour, take rest. She should be calm, no strain, no anxiety, comfortable, and bladder empty, no smoking, and no nasal congestion. Position of the cuff should be wrapped 2 to 3 centimeters above the elbow and should be applied firmly but not tightly. And while you just introduce your finger over the cuff, so the 2 fingers introduced. If the 2 fingers introduced, that is the cuff is not too tight. It is immaterial whether the tubes are above or below. The keeping the connection upwards has the advantage of making active anticubital fossa free. So these are the mercury sphygmometer, calibrated aneroid, automatic BP. Mercury sphygmomanometer, although gold standard, is banned due to the presence of the mercury because of the pollution control board structure. Android need frequent maintenance and standardization. And oscillometer have been already accepted as a very good. It does not need maintenance and training. The only problem is that sometimes it underestimates the BP in the preeclamptic mother. Obstetric examination, that is important. Examination of the breasts, and to note the pregnancy changes, nipple, areola, and the discharge. Nipple, areola, and the discharge. Examination of the breast You ask the patient, particularly when is the male student, always in front of the female. It is not mandatory, but if the patient particularly says she has some problem of the breast, you ask her. And obstetric examination, abdominal examination, inspection, palpation, auscultation, and vaginal examination, only inspection is needed in case of antepartum hemorrhage, PROM, not the bimanual examination routinely done in case of obstetric examination. Now, the criteria you will see, you will stand on the right side of the patient and with a female attendant, right side of the patient, female attendant, and talk with the mother, relaxedly, and you will ask her, I will see you and take consent for me. And then the abdomen is exposed and thigh flexed and knee flexed. Ask the patient to evacuate the bladder. Always keep one female attendant. Stand on the right side to the patient. Explain the patient what are you going to do. Make dorsal position. Thighs and knees both partially flexed. Abdomen is exposed fully and other parts are covered well. Now, inspection, palpation, auscultation of the fetal heart. Very, very important point. The inspection, I am not going into the detail. You see the inspection, you will say uterus is, the abdomen is uniformly enlarged. Inspection. The ovoid, funda, suprapubic region, whether there is a full or not. Condition of the skin, if there is any scar mark. Condition of the umbilical, and the stria gavidarum. This is the stria gavidarum. And linea nigra this is the linea nigra. This is the linea nigra, and this is the stria gavidarum. If there is a scar, and whether the character, whether the transverse or in the longitudinal, and whether it's healthy or unhealthy, that may be scar not only the cesarean section, but also the appendix, and also the previous history of the open cholecystectomy, and also the laparoscopy. Laparoscopy scar. So palpation, height of the fundus. The four things you remember. The height of the fundus, one, symphyso-fundal height by clinical examination, also by the tape, and abdominal circumference, and the four grooves. Four Leopold, first Leopold, second Leopold, third Leopold, and height of the fundus. Height of the fundus, how to measure, and what to see in the abdominal pelvis. What will be the conclusion? If from the abdominal palpation you get the lie of the fetus, the presentation of the fetus, lie with the longitudinal or transverse, presentation is the vertex presentation, cephalic or vertex presentation, or beach presentation, whether it is head, it is engaged or not, attitude of the head, and also the size of the baby, and amniotic fluid average. It is assessment, a clinical assessment. Amniotic treatment, it may be less, it may be average, or the maybe the excessive. The clinical assessment. Not it can be done actually the ultrasonography. Now height of the fundus, you can see right side of the patient, and keep your hand like that up to the GP sternum, and then come below and make the uterus central, and the measurement, and it is the keep here, that is resistant phosphor height of the fundus you see. The 36th week of gestation at the level of the ensiform cartilage, 32nd week, it is a junction of the middle third and the upper third, 38th week junction of the middle third and the lower third, and 24th week at the level of the umbilical. So 24 week the level of the umbilical, divide into 3 and say accordingly. At 14th week fundal height drops down again to the level of the 32nd week, because there may be the lichen may be less at the top, and the head may be engaged, and the shape of the uterus changed. Strength of the uterus changed from the pyriform to the globular shape. That is the 34th and 40th week at the same level. Now the symphyso-fundal height, you can say. In this condition, usually there is a main controversy, but the patient should be extended, thigh extended, and knee extended at that time. That will be exact measurement you take. And bladder should be in. And 0 mark of the tape is placed at the symphysis, which is a fixed point, and the fixed point, and other end it's not the fixed point, because you have to centralize the uterus and then you'll put it. And the one rule is that after 20 weeks of gestation, the normal height of the fundus in centimeter approximates the fetal gestation age until 36 weeks of pregnancy. That is 20 centimeter in 20 weeks and 1 centimeter per week. And abdominal circumference is like that. You can see the abdominal circumference is seen usually at the lower border of the umbilical, not the upper. It is the lower border of the umbilical. The standard measurement. And this is the one important, the abdominal guard. Now the grifts, the fundal gift, first Leopold maneuver, second Leopold maneuver, the lateral gift, and first pelvic gift, the polyp gift, the third Leopold, and second pelvic gift, the full. All the gifts are shown facing toward the mother's face, except the fourth Leopold maneuver, the second pelvic grip. And this is the fundal grip. This is the fundal grip. You can see. You keep the hand like at the funda, centralize the uterus, and one hand like this and one hand like this. Keep the. So this is the fundal grip. You can see fundal grip. And lateral grip, you first palpate one grip right side and then on the left side. You identify in the fundal grip. You identify what is the content, whether it is the fetal head or it is the podal ligament. Fetal head, the heart and globular and ballotable. And here you can see which side is the spine and which is the limbs. The spine looks like feels like hard and convex and smooth, but the limbs are the knobby-like structure. And it is the third Leopold. You can see the third Leopold or the first pelvic gift. Previously, it was said the second pelvic gift, but it's better to say the first pelvic gift. And is the second pelvic grip or the fourth Leopold. You make the hands parallel to the inguinal ligament and try to get below the presenting part. And what will you see in that is very important. What will you see in the pelvic grip? You see what is the presentation and the presenting part. What is the what is it engaged or not, and what is the position? That is the attitude. What is the attitude? What is the flex and deflex attitude? Presentation is said to be engaged. Presentation, how will you say the presentation? The hard globular mass, that is usually the cephalic gate. And whether they engaged or not, both poles are not palpable, only single pole may be palpable or no pole palpable. And the fifth formula in case of the labor. And how will you assess the another thing is the attitude of the head by seeing the level of the sinciput and occiput. Sinciput toward the limb determined by the lateral gift. Sinciput and occiput, relative position of the sinciput and the occiput. So investigations, now come to the investigation. What investigation you will do or supply? This is the routine antenatal. This is another question, and the examination may wound this question. Blood hemoglobin, complete blood count. Previously it was said only hemoglobin, but now the recommended is the complete blood count. ABO grouping and RH factor, blood VDRL, urine examinations of protein, sugar, and fat cells, blood glucose estimations. In India, universal screening suggested at first antenatal visit due to high prevalence after 75 gram of the glucose. And HIV testing, PPT-CT, it is must. Hepatitis B surface antigen mark. And naturally the question will be, what is the utility of the hepatitis B surface antigen? Because you can prevent the transmission to the baby by giving the active immunization and the passive immunization and taking care during the delivery. And HIV also is a good question. There are so many questions. Cervical smear for papa-Nicolau stage, stool for routine examination, USG for future profile and amniotic fluid index. Now, and other optional, but sometimes it is done, particularly the thalassemia screening is not universal screening, but it is now very important. If there is anemia, the thalassemia screening is very important, or also the thalassemia screening for the husband. Rubella antibody, to detect rubella antibody, thyroid screening, TSH, T34. If you know, the baby's thyroid is completely formed at the 20 weeks of pregnancy and starts to form at the 12 weeks, baby's thyroid. So if there is the first trimester, the deficiency of the thyroid, the baby, there will be some problem, particularly the IQ and the mental retardation. And combined test is must. and the ultrasound combined with biochemical ESG as 11 to 13 weeks of pregnancy. And trisomy 18 Down syndrome and trisomy 13. And if there is a detail, if all the reports of the ultrasonography, anomaly scan, and the growth profile. Now the summary, I will write the summary. That is very important. You will have to present this. Patient's profile and complaints, LEB, EDD, and period of amenorrhea. Present obstetric history in past obstetric history. Just very small. What is the relevant? Significant other history, positive and relevant negative. Like the antepartum hemorrhage, the pain was not there. Important physical findings, including the vital signs. Always write vital sign. Write vital sign, even they may be normal. So that is the vital sign, BP and pulse. Normotensive we can't take, but you also do the exact BP, pulse. Obstetric examination finding, investigation supplied or required. Now, example of writing a summary. Mrs. PR, aged 20 years, gravided 2, parity 1, living is 1, male, alive, well, and immunized. LCB 3 years back, belonging to a low socioeconomic status, and her residence is about 20 kilometers from the hospital, was admitted with complaint of swelling of the leg, along with the Muriapatha. So this is the first part of the summary. Now, her LMP was also EDD is also, you can clarify the period of the LMP EDD and period of amenorrhea. Now, the she has received the regular antenatal care in this pregnancy. She has taken her iron folic acid, prophylactic tetanus toxoid, TD immunization, and she had developed hypertension for 8 months. Now it is controlled with labetalol 200 mg. This is just example. And also if the diabetes or the level of the insulin or any thing medical. Her previous pregnancy was unable with full-term normal delivery. He had history of appendectomy. So that is the past history. Her father is hypertensive and mother is a normal, healthy. And on general examination, the height, weight, BMI, pallor, edema, you must mention there. And also pulse, BP. No abnormality detected or systemic examination. Breasts are normal. On obstetrical examination, height of the fundus, which corresponds with the period of amenorrhea, single fetus, longitudinal lie, presentation is cephalic, and deflex fatigue, head is not engaged. There is average amount of liquor and no painful contraction. Fetal movement is present. FHs is 140 per minute. When you will see the FHs, you must put your stetho over the one spinal on the spinal umbilical line and try to get the fetal ultrasound. The record it is the present or prominent or is the number of the fetal ultrasound and whether there is the abnormality or not. And also if you palpate the radial pulse on the other hand, what the mother, whether it coincides with the fetal or the coincides with the mother pulsation. Because sometimes the somebody the uterine artery supple may be a heart, maybe a heart, and uterine artery supple or umbilical supple. Usually umbilical supple corresponds with the fetal heart artery. This is an investigation report are like that, hemoglobin, A positive, hepatitis B, HIV, like that, ESG findings are like this. So your provisional diagnosis is the simple line, 25 years, primary gravida at 37 weeks of pregnancy with complication, the vertex presentation with the fetal ultrasound on 40 per minute, which is regular. This is these points, or you will write the diabetes of antepartum hemorrhage. So with best wishes to all of you, thank you. Thank you all for your presence of the day. All photos are copyright from my book, The Bedside Clinics and Obstetrics, published by the academic publisher. So if any questions you can give, even there is chat questions. If there are any questions, and this is the actually you see the fetal ultrasound, and the examiner's accoucher's hand is on the radial fall. So when you show the fetal ultrasound, you keep your other hand the maternal radial fall, and you auscultate, and then you tell this is situated in the right. Prominent is the right spinal umbilical line, 140 per minute, and regular. So you will see. So thank you all. Now, any questions? Any chart? Okay.
Dr. Maji, thank you very much. I am Dr. Geeta. Really very brilliant presentation. My only query is that, sometimes the patients, the candidates carry a Doppler to the hall. Is it allowed, or do we insist on them hearing?
Till the examination stage, I have not seen whether Doppler is allowed. I have not seen Doppler. Till I do not know whether probably there will be at the Doppler is by many places, but till so far as the recent examination also, an NMC guideline have should the Doppler is allowed or not. Probably better not to enter with the Doppler. He can carry when the examiner says she can show, but till with the examining must be accustomed with the stethoscope.
Right. Because when we go as examiners, I was thinking, you being a premium examiner, I should ask you this question, whether we can allow them or no allow.
Yeah. Do not usually not allow. Till recent day, not allowed.
Thank you. Thank you,
she
sir.
She can say that there is a better audible by the Doppler.
Thank you, sir. Thank you.
Yeah, thank you, Dr. Geeta. Any other
Thank
question?
you so much, sir. So we do have few questions in the question box. Dr. Jyoti has put a question. What is functional history?
Ma'am, do you
What is functional history?
Personal history, yes. Personal history is the maintenance of the hygiene. It is the maintenance of the hygiene, and also is the many things are included in that. Particularly the maintenance of the hygiene and his diet history, and also occupation and diet, occupation, and the hygiene. These are the personal history actually.
And another question is, sir, do we have to categorize the BMI according to Asian scale?
Definitely, you will have to write the BMI, height and weight unit. I have already mentioned that the different BMI you must write there. BMI definitely you will have to write. The postgraduate examination you must have to write the BMI and the categories. And
okay,
if you know the BMI, there is no problem. Then
is it mandatory to do second pelvic grip if head is not engaged?
Mandatory. You always write all the grips. You always all the write the grip. First Leopold, second Leopold, third Leopold, and fourth Leopold. It is into the international standard. First, second, third, and actually the that is the fourth Leopold, which is by the fingers, which is very useful for the one is the presentation and presenting part. Second is what is the engaged or not, and third is the attitude. And because in case of third Leopold, that is the first pelvic grip, is not so well understood. It should be done by the obstetric, by the experience. It is done by the experienced obstetrician. She can assist. But for the beginners and the juniors, you must have to know the fourth pelvic. That is the fourth Leopold. All Leopold will have to say. But to come into the inference of the Leopold of the pelvic grip, you must have to know whether the lateral grip, which side is the back, and which side is the limbs. And other questions?
Another question we have, why, sir, we have to feel the mother's radial pulse while auscultating the fetal heart rate?
Yeah. Mother, you are seeing the radial pulse. Not to write there. Not to write, you write in the maternal pulse, that's the physical examination. But when examiner is asking to show you the fetal heart rate, you must keep your left hand in the radial pulse. And you don't say that I am seeing like that. But you say the fetal heart sound is located there, it is regular, present, and intensity is high and at that region. Because to get the fetal heart rate, there sometimes in case of intrauterine fetal death is found the fetal heart rate where there is a prominent, there is also the uterine artery and uterine support. That is why the importance of seeing the fetal, the radial pulse. You must see the radial pulse along with it. Not right there, definitely not right there. Only the fetal heart. only by clinical demonstration.
Okay, sir.
Any other
The
question? Next question is a chat box.
It is in the question and answer box.
Yeah.
You have to say all the four. We just say multiple parts.
And it is mandated to do second pelvic rib negative. We have to feel for mothers. It helps us while oscillating. Why we have to feel for mothers? It must. So whether it is the maternal pulse or the fetal pulse. And next is the, in case of multiple gestations, do you have to say all 4 grieves or just say multiple fetal pulse? Very good question actually. This is the very good questions. And it is a special palpation. With a special palpation, because you will have to routinely all things is that. If suppose the head is on the left iliac fossa or the left lumbar region, I would say serve that to me. Because in I have shown you the what is the lie, what is the present number of fetus is like that. If you can get the 3 poles at least, you can say this is the multiple pregnancy. 3 poles on the 2 fetal head and all the total head. You can say they only the multiple pregnancy. It has been written in details in my book how in multiple pregnancy is the palpatory findings you will express. That is very, very good question. My question is multiple gestation, do will have to say all 4 grieves. You write the 4 grieves. Definitely you write to say 2. But just say multiple fetal parts are not enough. Only to say the multiple fetal parts are not enough. You write have to give the grieves. Write up to the grief. Another question, you are allowed to check the investigation of the, definitely in postgraduate examination, you are allowed to check the investigations of the patient. I have these. What are they? Usually they give in. Suppose the patient is the RH negative. That is a question will be that. Or otherwise, I have at the very beginning I have said, you see what investigation they give. If you want more investigation, you ask for that. And if the examiner says, sir, madam, I asked for that, but there is not available like that. The further the blood sugar monitor. Now, another question is kindly tell how to say it is second pelvic grip, 5/5 palpable, 3/5 as it is. Little confusion. Not the second pelvic. It is not the second pelvic grip. Good question. The 5th pelvic, that is not a maneuver. That is the 5th method. 5th method I have not shown here. It is applicable in case of labor. More application in case of labor. First pelvic grip, self-pelvic, not confused with the 5th palpable. 5th palpable means you keep your 5 fingers above the simple ribs and then measure. If the head is palpable 5 finger, that is not at all engaged. If it's 4/5, that is also not engaged. The 3 fingers palpable head, that is going to be engaged, and 1/5 palpable or no 5th palpable, that is already engaged. So that is the separate, not the second pelvic. Don't confuse with the pelvic grip and the 5/5 palpable. You see clearly it has been written. And next question, and so many questions. Thank you. And in PIH patient, what neurological examination we should do on patient routinely or neurological patient? If there is a complaint, then you should. If there is a complaint, not the PIH. Sometimes there is if a eclampsia patient, you must see whether there is a CVA, whether the CVA, and if it is getting the maxal, you examine the jerk, and also ask the patient to raise both the legs, but there is the CVA, and there is a paraplegia. This is definite, there is a paraplegia and the CVA, and also that is the jerk is important. Jerk, neurological examination, jerk is important. And next question, what is functional history? Yes, functional history is actually the bladder, bowel, appetite. The functional history means the bladder, bowel, appetite. That is, I have not said elaborately. Bowel, bladder heavy, and appetite. And sir, are there 2 ways of calculating SFH? One you told us, what's the other one? As SFH is the fundal height, actually. The fundal height you by the clinically, and also another is the by tape in centimeter. By clinically, it is the 32 weeks, 34 weeks. So there is the 2 methods. One is by clinical method, by keeping the hands on the on the upper end of the, so whether and divide from the umbilicus to GP sternum 3, and with the level of the GP sternum that the 6 weeks at the umbilicus 24. And another is the with the standard measuring tape, what is the centimeter. And there are 2 ways. So I think all questions are complete. Very good questions actually. They are very all are very attentive to hear.
So
Thank
there
you
is
all.
one more question in the chat box. So you have mentioned about the ophthalmological examination, how to do that?
Which one?
Ophthalmological examination and how to do that?
Ophthalmological examination. Ophthalmology, I have already mentioned there. Ophthalmoscopy examination, you would write there, it's not done. But in case of preeclampsia, you write there, the ophthalmological examinations are not done. If there is a report of the ophthalmoscopy, I have already told, you ask for the any ophthalmology examination finding is supplied to ophthalmological. Ophthalmoscopy, it is no means of not routine done, not at all done. Ophthalmoscopy, but you mentioned the eye examination. How to elicit scar tenderness, and this is very important. Actually, the examination is differs from one case to another. Scar tenderness, how you see. The scar tenderness means the tenderness of the uterus. It is not on the skin. The skin scar may be longitudinal. Skin scar may be longitudinal. And but in scar tenderness, always usually the lower uterine segment scar. You keep your hand over the lower uterine segment transverse on the transverse position and see the look the patient's eye. That is very important. Keep your hand over the scar, you just palpate and see the patient's heart, patient's eyes, see the patient's face. That is the basic technique. To see the patient's eye, the whether she is feeling any change of expression. And then you ask whether you are feeling any pain there. Then you can ask. And if she feels there is a pain, so you keep your hand in another place. Is there any pain? This is very common thing. Sir, can we get diet chart to calculate the total calories and protein? Sir, can we get diet chart to dietary history? Yes, the dietary history has been actually, if you see, consult my book, what should be the standard dietary chart from the normal pregnant mother and for the diabetic beta that has been given. That has been clearly given. Not that you take like calorie is like that. You divide with the food materials, with the how much cereal, how much egg, how much milk is like that. Is like that. Like one egg contains the 70 calories. 1 glass of 100 milk is the 100 calories. It is like that. It has been divided. You keep the diet chart. Definitely, there is a very good diet chart that has been written. And particularly, one important question, as you have asked, about the diet chart. Suppose the patient you will have to increase the diet quickly. How do you do? You fried it. Because the value of the lipid, the fat is 9, but in case of protein or carbohydrate is near 4. So you will have to fry that chapati. So that will increase the calorie more. And if you don't restrict the calorie, you do not the fried thing. And any questions? There's a good question. What is the buffer period of day? That is the questions of the. Thank you. Any questions? There are so many questions really in the antenatal checkup, but also the investigation. There are so many questions. Every student must be cleared. If you don't mind, I am saying in my book I have given which part important in the history taking. You will read from there. In this page number this. Suppose the diabetic, the screening, how to do the screening. This page number this. Hepatitis B examination is page number this. That is the questions asked actually exam.
So I have answered all the questions, sir. Thank you for such a wonderful session. All of us are elated and delighted to hear you today, sir. I'm very much sure that all the participants and all the PG students, they have learned a lot from your lecture today, and I'm sure they will go back and read the book of yours for a clearer and better picture.
No, not necessarily. There are so many
Thank you,
books in
sir.
the market. There are so many books.
Yes, sir. There are many books and they have to read. But for sure, sir. Thank you. Thank you so much, sir, for today's lecture. So I think we should move on to the next session, what we have over here. So the next session we have
Dr.
is
Mala,
OSCE examining.
and your institute
Thank
for
you. Thank
conducting.
you so much.
Thank you. Thank you all. I am leaving now.
Thank you, sir.
RCG conference is done. I have to there. Very sorry not to stay
Thank you,
with
sir. So for the next session of OSCE, I would like to call upon the panelists who are my own teacher, Dr. Geeta Mediratta. Ma'am is a senior consultant at Institute of Obstetric and Gynaecology, and she's also the vice chairperson. She has got special interest in urogynecology. Ma'am is chairperson of the urogynecology subcommittee of AOGD from 21 to 23, vice president of ISOPARB Delhi chapter. She is a recipient of APJ Abdul Kalam Award in 2022, ex-editor-in-chief of AOGD Bulletin. She has been ex-secretary of Delhi chapter of Indian Menopausal Society from 2016 to 2018, ex-vice president of ISOPARB Delhi chapter, and she is the organizing secretary of the 11th World Congress of Conference of Reproductive and Child Health in 2012.
I think Huma,
So
we can
welcome,
skip. We can skip and just get on.
Okay, ma'am. The next panelist we have over here is Dr. Chandra Mansur, senior consultant, gynecology and endoscopic surgeon, robotic surgeon, and she has got special interest in adolescent health. And she is in charge of the adolescent clinic at Ganga Ram Hospital, treasurer of NACHI. She is treasurer of IMS Delhi chapter, joint secretary of AOGD in 2008 to 2009. And she is secretary of NACHI, and she is president of ISOPARB Delhi chapter from 2021 till date. So welcome, ma'am. The third speaker we have today is Dr. Mamta Dagar. Ma'am is a senior consultant in Obs and Gynae and professor of Gripma Institute in Ganga Ram Hospital. A special area of interest.
I think we can skip the introduction. We are running behind schedule. I think.
Ma'am. So we begin the session, ma'am.
So I know we are a very good morning to all of you and welcome all of you to this teaching program of Gurukul, a very good initiative. I will soon start sharing my screen. We will take you through the OSCE case scenarios, which are still a part of our DNB final practical examination. And these scenarios have been prepared by me, Dr. Chandra, and Dr. Geeta. And Dr. Chandra will not be joining today. She is busy in a meeting. So we will take you through this few OSCE case scenarios and discussions. So you can see my screen, Huma?
Yes, yes, Mamta.
Yeah, so we will move. Like in OSCE, we probably make you go through a few photographs, pictures, images, and interpretations, case scenarios, and then we ask questions. So just see this image. You all, in fact, can make out these are the images of colposcopy of a cervix, and after application of normal saline acetic acid under green filter, and after application of Lugol's iodine. So the question which is asked is, you need to identify and label the arrows in image, and what is the tissue basis of aceto whiteness after acetic acid application and iodine negative uptake after Lugol's iodine application. So I will once again make you go through these images, which you can see. This is a colposcopic image of a cervix after application of a normal saline. This is under green filter, in fact, and this is after acetic acid with green filter. And these are the marks, the yellow arrow and the blue arrow and the dark blue line, which we would like you to identify. And we have also asked you the basis of this iodine negative area. So having said that, let's come down to the answer. If I make you see what you can see in this yellow arrow and in the blue arrow. I know you are all on mute, but this is a picture of a Nabatean cyst And it depicts a normal colposcopic findings here, Nabothian cyst, and this is the islands of blood vessels, which is marked by the light blue arrow. And you can also see in the whole of this cervix that they are the reticular kind of vessels, which are normal blood vessels. And this dark blue line is, of course, the squamocolumnar junction. So it is showing a normal colposcopic findings. And the basis of acetowhiteness, you all know that the tissue basis is that the acetowhiteness is because of because the light is reflected back and it appears white. And the basis is that these malignant cells, this is the immature squamous metaplasia, and they have the increased nuclear proteins or the CIN cells. And this nuclear proteins, they coagulate the proteins. There is increased nucleocytoplasmic ratio, and this coagulated proteins, they reflect the light back and it appears aceto-white. And this is the basis of aceto-whiteness. The basis of iodine negative is that you know that the squamous cells contains glycogen, and due to the glycogen, there is the staining of the cervix as mahogany brown. But when there is a lack of glycogen, as in the columnar cells, in the malignant cells, and in the CIN cells, there is no iodine uptake by these cells, and they appear as villi negative. And as you could see here, it is villi negative, but this villi negative is now a very non-specific finding, and you cannot just say that villi negative absolutely means something till you have biopsied this area. So it doesn't come now as per the IFCPC nomenclature, neither into the any of the normal or in the major or minor colposcopic findings. So it's a non-specific finding. Next is this picture. You all must be knowing this. You must be practicing in your labor ward. That this is the image of what you can make out. The question is identify and enumerated components, and when does the active stage of labor start? So we all know this is a WHO labor care guide, and this is in fact a tool which WHO has devised, which aims to support the good quality, evidence-based, respectful maternity care during labor and childbirth, irrespective of setting and level of healthcare. And it has 7 components. As you can make out, you must have practiced and filled in your labor wards also. And section 1 is giving the information, identifying the information and labor characteristics at admission. Section 2 is talks about the supportive care, like you have, excuse me. Section 2 talks about the supportive care, like you basically have supported the woman with the pain relief, or have given any, taken care of the hydration, taken care of, given her fluids, given her, have provided the support of companion or not, and about her posture. The section 3 is about the care of the baby. And this care of the baby includes the baseline characteristics of the fetal heart rate, and mention of any, besides the baseline between 110, less than 110 or more than 160, mention of the fetal heart rate decelerations, about the amniotic fluid color, and about the fetal position, and mention of any catheter molding. While the section 4 mentions the woman characteristics, which takes into account the pulse, blood pressure, systolic and diastolic, the temperature, and the urine proteins or presence of any acetones. And it is the section 5, which basically mentions the labor progress here, which basically, in which you mention about the contractions per 10 minutes, whether it is less than 2 or more than 5, or less than or equal to 2, and duration of contractions, whether they are lasting for less than 20 or more than 60 seconds. There are very absolute, features which are there in the labor care guide, which you have to start feeling once the woman is 5 centimeters dilated, meaning thereby that actually your paperwork starts at that time, but it doesn't imply, the WHO labor care guide, that you're not going to basically do anything or mention in your records before 5 centimeters dilatation. You have to basically support the woman throughout the labor and do the documentation. But this paperwork in the WHO LCG will start at 5 centimeters dilatation. Another in the labor progress is the mention of the cervix, whether the cervix is 5 centimeters, 6, 7, 9, up to the 10 centimeters dilatation, and how long it has taken for the dilatation to reach. And it is plotted as plot X, and descent is 0, 1, 2, 3, 4, 5, not -1, -2, -3 station. And also you basically have to imply once the woman starts pushing, and in active first stage, plot X to record the cervical dilatation, and alert is triggered when there is a lag time for current cervical dilatation is exceeded with no progress. In the second stage, you have to insert P to indicate when the pushing begins. Next section is section 6. I'm taking a bit long time to basically make you understand this WHO LCG, so that you basically incorporate, if you have not incorporated into your practice. We are hammering again and again to our DNB students also to kindly go through, and it is a NABH mandate. They ask for WHO labor care guide, how you have monitored the progress. So it is universal. Next section is section 6, which talks about the medications, which includes the oxytocin in units per liter, drops per minute you have given, about other medications, and IV fluids, whether you have given to the patient. And section 7 is the shared decision making about the patient assessment and the plan. So this is what the whole WHO labor care guide, the LCG 7 sections, you must memorize and must practice. And as the latest WHO LCG and the guideline states is the cervical dilatation, the active, it starts at, which was the part of my question B, that when does the active stage of labor start? It starts at 5 centimeters dilatation onwards. We come to the next image. You see very carefully, you know, you all can make out it is a CTG trace of a woman in labor, because in the upper part you can see the variations in the fetal heart rate patterns. You could see, though not very clear, that, but I can make out and tell you that it is this is a 90. The fetal heart rate is 90 and this is 120. So it is somewhere between 90 to, this is 100, 110, 120. So 90 to 120 to 130, and this fetal heart rate is varying. And I know you can make out the pattern, and this is also basically, you can, topo is applied and the woman is contracting. So this patient is in labor. So the question is, you need to identify the type of CTG trace and whether it is pathological and cause. So again, going back, you can easily make out that she is regularly contracting, and I hope you can make out that the nadir of every this deceleration which woman is having is coinciding with the peak of the contractions. See this, see this, this. So what is it? The nadir is coinciding in more than 50% of the contractions with the peak. The nadir of the deceleration is coinciding with the peak of the contractions, and it's very right that we are dealing with a early deceleration in labor, which is definitely not pathological, and cause is head compression in labor. So this is how the questions are asked to you in the exam, and in the OSCE exam, and maybe the part of your practical case vivas also. Next image is, you all know, Dr. Maji was also talking about the Anemia Mukt Bharat. This injection is, just see this injection first, and then let me throw the question. What is the indication for its use in pregnancy, and how it is given, and what is Genzoni's formula? So this injection is, for sure, it is, the name implies it is ferric carboxy maltose injection, that is FCM injection or oro for FCM. And it comes as a 20 ml vial, which contains 1 gram of FCM. And it is for definitely IV injection, IV infusion in pregnancy. You do not need to refrigerate it. But now, the thing is key, what is the indication for its use in pregnancy and how it is given, and what is Genzoni's formula. So Ferric carboxymaltose injection IV formulation is indicated in pregnancy. Definitely moderate to severe anemia in pregnancy, and it is given as a 1 gram mixed. This is mixed with 250 ml of normal saline, this whole, and then it is to be given over an interval of 15 minutes. And the dose is not to be exceeded in one shot of more than 1 gram. So it is not only in moderate to severe anemia in pregnancy that we are giving IV iron. Our aim is that it should be anemia free. Our woman should be anemia free. Not all the women are tolerating oral iron. Not all the women are compliant. So IV iron should be considered from second trimester onwards in pregnant women with iron deficiency anemia, which cannot tolerate and do not respond to oral iron therapy. And there is enough published evidence that IV iron is safe and effective in second and third trimester of pregnancy. And IV iron is the preferred route when there is oral iron intolerance or in situations where oral iron is inefficient or it is harmful. And of course, in situations of moderate to severe anemia in second to third trimester of the pregnancy, besides increasing the iron stores, it helps in improving the anemia. It helps in building the iron stores of the baby, which are beneficial to the baby. So I will not talk about this beyond this. We will move down to the next part, which is Ganzoni's formula. How do you calculate how much iron is to be given? There are several formulas, and that how will you calculate the total iron body deficit? So one of this formula is a Ganzoni's formula, which takes into account when you are basically calculating the total iron deficit, and the cumulative iron dose in milligram is you are multiplying the body weight in kilogram into the target hemoglobin minus actual hemoglobin into 0.24, which is a factor. How this factor is derived, I will just come down to that, plus iron depot in milligrams. So basically, how this factor 0.24 is derived is that you basically have to use the ideal body weight in overweight patients. If it is underweight, you have to take the actual body weight. So for this calculation, the iron content of the hemoglobin is 0.34%. And the blood volume is 7% of the body weight, and 1000 is for the conversion from gram to milligram. So how we are going to calculate the iron depot is that in a less than 35 kg body weight, iron depot is 15 milligram per kg body weight, and more than 35 kilogram body weight is 500 milligram. So coming down to how in a 70 kg female with a hemogram of like 8, it is not mentioned. We have calculated the iron deficit is at 70 multiplied by, here they have taken standard as 15. This is a Western standard, but yeah, we basically probably may take it as a 12.5 or 13, whatever standard is with us, minus 80 into 0.24, how this factor is taken from here and how this factor is calculated. You just, multiplied it with 0.24 and plus 500 milligram for the deficit, and it has come down to be 16766 milligram or approximately 700 milligram of iron in milligram, which is to be transfused. But as I said, do not transfuse more than 1 gram in one go. So it has to be a second stage IV infusion, not in one go, because we should not be transfusing more than 1 gram. Next question is, in a pregnant woman who is suffering from rheumatic heart disease with mitral stenosis, when vaginal delivery should be allowed? And when is infective endocarditis prophylaxis indicated? So when vaginal delivery should not be allowed. We know that all cases of rheumatic heart diseases are not the contraindications to have a vaginal delivery. Vaginal delivery is possible, but yeah, definitely in situations of critical MS, in NYHA class 3 and 4, and in pulmonary edema, these cases of rheumatic heart disease, vaginal delivery should not be considered. And when infective endocarditis prophylaxis should be given, again, as per the recent this ACC and AHA, it is infective endocarditis prophylaxis is not to be given in all cases of heart diseases. in high-risk situations, it should be given. We shall not be talking about it in detail, but just to mention here that it is not indicated for low-risk situations of cardiac diseases like in cases of PDA, mitral valve prolapse, in cases of small ASD, VSD, in cases of corrected cardiac defects and TOF and all. This is what the guideline states, the American Heart Association and ACC, that it should be given for high-risk situations. But definitely we need to extrapolate to our scenarios, but we need to talk the evidence in the exam. We will take you through certain other case scenarios which were prepared by Dr. Chandra. Unfortunately, she couldn't join in. She is busy in another audit meeting today. So I will be taking you through these case scenarios. This is a primary gravida with 10 weeks pregnancy, which was diagnosed to be HIV positive on routine blood investigations. And important, the questions are, which will be and may be asked is, what are the important points in counseling of couple? Enumerate 3 maternal risk factors which could increase the risk of PTCT, and how frequently would you like to do RNA copies and CD4 count during pregnancy? So she is at 10 weeks of pregnancy with diagnosed HIV positive on booking. So the important points in counseling includes that she need to be explained that there is a need of ART to be, which is good for her health and for the baby. And there's a risk of infection to baby with or without ART, which is to be discussed, that what is the risk with the ART treatment and what is the risk without ART treatment. She needs to be told that HIV per se diagnosis is not an indication for termination of pregnancy, and there is a need of regular antenatal checkups. And of course, the institutional delivery, which needs to be discussed with the couple. And of course, the need of exclusive breastfeeding, it should be discussed. And the maternal, another question was enumerate the important maternal risk factors which would increase the risk of PTCT. These are the high viral load, advanced clinical stage of disease, concurrent STIs, presence of malnutrition, and viral, bacterial, and parasitic infections. The third question was, how frequently would you like to do RNA copies and CD4 count during pregnancy? Yes, definitely before starting ART and after the change of ART, but the NACO guidelines suggest that you should not withhold the giving of ART, and you should not wait for the results of CD4 count and RNA copies. It should be commenced as soon as your test has come positive without the result of CD4. But yeah, definitely as a baseline, you should do it before starting ART and after the change of ART. Then of course in every trimester, and then at 36 to 37 weeks to decide the mode of delivery. Next case scenario is a G2P1, 37 weeks pregnancy, admitted with labor, with previous normal vaginal delivery, diagnosed HIV on ART, and on per vaginum examination, she's 2 centimeters dilated, 60-70% effaced, vertex is at -2 station, and bag of membrane is positive, present, and the pelvis is adequate. So what are the NACO recommended ART regime for this lady who is in labor and has tested HIV positive, diagnosed HIV positive? What are the important precautions during labor and guidelines for breastfeeding in low resource countries? So definitely NACO recommends recommendation of commencement of lifelong ART in all pregnant women with confirmed HIV infection. And the first line ART which is recommended is a combination of, which is a once a day fixed dose oral therapy of tenofovir 300 mg, lamivudine 300 mg, and efavirenz 600 milligram. So, which is basically also the tenofovir TDF is the same, and lamivudine is 3TC, and efavirenz, it is once and the same thing, which is the regime which is recommended for pregnant and breastfeeding women. This is to improve the maternal health as well as to reduce the mother to child transmission to the baby. The precautions which needs to be taken during labor is you avoid, of course, the multiple per vaginum examination, prolonged labor, and premature rupture of membranes, and continue same ART if she is already on ART, or if she is not on ART, then 3 dux ART should be started immediately, and this is lifelong. as I said. About the breastfeeding, the WHO recommends exclusive breastfeeding with ART prophylaxis, which is preferred in low-resource countries. And of course, you need to give nevirapine NVP to the baby for 6 weeks minimum. And you need to evaluate the baby. The next scenario is a primigravida at 35 weeks pregnancy with gestational hypertension, which is well controlled on 2 antihypertensive medicines. And ultrasound shows an AGA fetus with a normal ABI, and CPR is, of course, more than 1. So what is the questions are incidence of PET in primi and multiparous women, enumerate 4 risk factors for preeclampsia, and at what gestational age this patient needs to be delivered or should be delivered. So to the first part of the question, the answers are the incidence of PET in primi is 2 to 7%, in multiparous is a bit less, up to 5%, and the incidence is of course higher in twin pregnancy to the tune of 14% and 18% in women who has a previous history of preeclampsia in her previous pregnancy. And other risk factors for preeclampsia are nulliparity, obesity, chronic hypertension, autoimmune disorders such as SLE, any inherited thrombophilias, and of course the maternal illnesses such as diabetes mellitus, be it type 1 or 2, renal diseases, and of course the family history of preeclampsia. When this lady needs to be delivered is of course at 37 weeks of pregnancy, if she's gestational hypertension or developing preeclampsia, and or if she has chronic hypertension. So any hypertensive disorder of pregnancy, we need to basically deliver by 37 weeks. And of course, you need to assess the bishops, and you will do the induction first. If there are no contraindications for vaginal delivery, you will deliver her vaginally, and if there are indications for cesarean, then consider cesarean. And a close monitoring in this lady with till 37 weeks of gestation is recommended. And the problems which may arise, that her hypertension may worsen, her preeclampsia may develop, and of course may develop fetal growth restriction. Look at this case. You all can have a spot diagnosis. I know in the images 1 and 2, one looks up. You can easily make out what is this. So we will go to the question, identify the conditions, etiology and treatment of both conditions. Of course, the A is a very subtle, the swelling, and which is Bartholin cyst, and B is inflamed, looks red, edematous, maybe. Of course, you cannot make out tenderness. Tenderness is also one of the features. So B is Bartholin's abscess. And etiology is Bartholin cyst is a vestibular gland which is lined by transitional epithelium, and it is prone to obstruction. That is why the cyst formation, Bartholin cyst, occurs. And the abscesses develop due to the superinfection in an abscess, which is usually polymicrobial in nature, and 10% of the abscesses may be caused by Neisseria gonorrhoeae. And the treatment in case of simple Bartholin cyst, which is not symptomatic, may just need a follow-up. And however, those abscesses, the treatment is, of course, IND, marsupialization, and dissection of the gland in case of recurrence. The large Bartholin cyst or symptomatic and causing pressure symptoms also needs treatment by excision. I just need to add here. So I would now give over to Dr. Geeta Mediratta ma'am to take it further.
Thank you, Dr. Mamta. Thank you. Thank you very much. Lovely questions. So since you have the control, Mamta, I will just request you to tell. So good morning, students. A very pleasant day to all of you. And OSCE, as Mamta has said, is an important part. So you will be given few queries or case scenarios or pictures, and some questions will follow. So now look carefully at this picture, and I will just read out the question which will be associated with it. Now, a female aged 35, I think, Mamta, I have the question. You can just keep the picture on.
Just let me know. Yes, ma'am.
I'll let you know. So it's a 35-year-old lady, para 2 L2. She attended the gynae OPD with bleeding per vaginum off and on since 1 month with blood-stained discharge. Systemic examination, abdominal fine, per speculum, you can see as is shown in the picture. Now, this will be the question, and you will probably have 2 or 3 questions attached to it. So my questions are: list 2 differential diagnoses, List 2 investigations you will advise and how will you treat this case. So now, as you can see, the answers, they will be marked, like there'll be 2 marks or 3 marks. So you listen to the question carefully. Now keep looking at the picture and I'll give you the answers. So the 2 differential diagnoses which you can write can be, you can see cervical polyp or endometrial polyp. You can also write it can be a placental polyp or inversion uterus. These are the possibilities. You have to give only 2. Don't over answer the questions. Then the 2 investigations you will advise are the ultrasound pelvis, and you will take an LVC and HPV. This is what you will answer. The third question is, how will you treat this condition? Simple: colposcopy, hysteroscopy, guided procedure, and biopsy, and proceed further. So you have to give, what moral of the story is, you have to give very targeted answers. Listen to the question and give. If they say 2 differential, give 2, because you will be marked. If you give 2 correct, you will get 2 marks. If you write 4 answers, it's not that you will get 4 marks, right? Next, Mamta.
So I will just
the picture, the questions I've answered. Next, yeah. Right. So I think Dr. Mamta has very nicely already given you this question and answer, just bears repetition. So describe the picture, number 1 question. Number 2, what solution is used for this test and how is it prepared? And what is the change in precancerous and cancerous lesion and how is it caused? So you'll probably have 1 mark for the first one, 1 mark for the second, and maybe 3 marks for the last question. So describe the picture. As you can see, it is a visual inspection with Lugol's iodine, which is showing scattered iodine negative areas on anterior and posterior lip, as you can see. The next question asked is, what is the solution? Mamta, you can, picture this now. Next one. So as you can see, the solution is Lugol's iodine, L-U-G-O-L, Lugol's iodine. The question asked is, how is it prepared? So first answer, Lugol iodine, you get 1 mark, and how prepared, you get 1 mark. So it is 5% iodine and 10% potassium iodide. You dissolve the potassium iodide in 20-30 ml of distilled water, and you add iodine slowly and heat gently with constant mixing until the iodine is dissolved in the potassium iodide. And you dilute this with 100 ml of distilled water and store in an amber colored, amber glass stoppered bottle. Third question which we asked you was, what is the change in the precancerous? And I think Dr. Mamta has already explained to you, so we will skip that answer. Basically, it's a mature epithelium with glycogen. So it is a dark mahogany brown, and non-glycogen is usually canary yellow and or depending on the various shades, depending on the amount of glycogen. Like immature cancerous lesions also do not take iodine as they lack glycogen, and they can appear as saffron yellow, what we call canary yellow. Next, please. Now, question 3 is, a patient presents with a thin white discharge. She has no itching, but discharge is copious. So what are the Amsel's criteria for diagnosis of bacterial vaginosis? And second part is, differentiate the clinical features of candidal discharge and trichomonas. Next slide, please. So the Amsel's criteria, you will probably get this for 2 marks. So at least 3 of the 4 following should be present. A thin white homogeneous discharge. Clue cells on microscopy, which are basically vaginal epithelial cells with these bacterial vaginosis bugs attached onto their margins. Third criteria, pH more than 4.5 and a fishy odor on adding alkali, which is 10% potassium hydroxide. So Amsel's criteria, you should know any 3 of the 4: clue cells, pH, and fishy odor. Thin white discharge is the clinical examination. Next, please. How do you differentiate a trichomonas from a candida? So the answer is, again, clinical features are very simple. Trichomonas, is a sexually transmitted disease, and on microscopic examination, you have the flagellate protozoa. There's a classic exostyle and cystostome, and nucleus is elongated. And it's a typical frothy greenish discharge when you put in a speculum, and patient has itching. In candidiasis, sometimes an STD, not necessarily. Here, if you add potassium hydroxide, you will find pseudo-hyphae budding yeast cells. And mind you, in trichomonas, you don't do potassium hydroxide, you just do a hanging drop, just put a drop of saline in the discharge. Whereas for candidiasis, if you are suspecting, you have to put potassium hydroxide, let it digest the cells, and then you will see. So the second is a microscopic picture. The character of discharge you have all seen. It is a cheesy, thick, curdy discharge, which is coating, sometimes forms a carpet on the cervix and vagina. And if you remove with the forceps this little discharge, you can see punctate hemorrhages. And there is profound itching complained by these patients. Right. Next question, question 4. You will be given this picture. This will be projected to you on the screen. You will look at it, and then there will be questions asked. So the questions asked are, after whom are these levels of support named? Answer you all know is the Delancey's, Dr. Delancey, who has done extensive research and MRI and gotten these pictures. Now describe the components of the 3 levels of support. Next slide. So the 3 components, there are 3 levels, level 1, level 2, level 3. The components are cardinal ligament, uterosacral, forming the level 1 support. Level 2 is by the vesicovaginal fascia and the rectovaginal fascia, which are each attached to the arcus tendinous fascia pelvis, which in turn is attached to the uterosacrals. And the third level is the perineal body, which is in turn attached to the rectovaginal fascia, and via the rectovaginal again attached to the uterosacral ligaments. So if your question was very simple, describe the components. You don't have to say what deficiency will cause cysto, recto, utero. So you just read the question and that's it. Next slide, please. So the above ultrasound picture will be shown to you. You can see a TVS and you can see the placenta and you can see the yellow arrow. Now the question which can be asked, there are various questions in this slide. The first question can be, the above condition is most common in which part of the spine? Second question can be, what are the commonest cranial ultrasound signs of this condition in the second trimester? Third question can be, which serum marker in the quad screen would be increased in this condition? And what abnormalities / conditions are associated with this anomaly? So to answer the first question, the above condition is most common is seen in the lumbosacral spine. Almost 65% of this meningomyelocele can be in the lumbosacral, sacral 24%, thoracolumbar 10%, cervical 1%. If you know that, you can write. Otherwise, the question was simply which part it is. Answer is lumbosacral. Second question was, what are the commonest cranial signs? So this is, since you know, it's Arnold-Chiari malformation. Basically, there's a caudal displacement of the brain stem, which obliterates the cisterna magna. So you have a pinching or a scalloping of the frontal bone, which causes what we call the lemon sign. And the normal cerebellum, which is 8-shaped, is, there is an absent anterior curvature of the cerebellar hemisphere. So it looks like a banana. So the answer will be lemon sign and banana sign for question number 2. Question 3 is, what is the marker? Obviously, maternal serum alpha fetoprotein more than 2.5 moms. That is the marker. And the fourth question is, what abnormalities are associated with this? So if you have a raised maternal serum alpha fetoprotein and in a neural tube defect, commonest is a neural tube defect. It can also be raised in an abdominal wall defect. It can also have a congenital nephrosis, wrong dates, even multiple gestation, placental problems like IUGR, intrauterine demise, preeclampsia. So if you see a raised alpha fetoprotein, it deserves a very good ultrasound for NTDs, abdominal wall defects, kidneys, and first rule out wrong dates and multiple gestations. Then folic acid deficiency also is associated with neural tube defects. Chromosomal anomalies, mainly trisomy 18. And then you can also have bladder bowel weakness, paralysis of lower limbs, and hydrocephalus associated. Next slide, please. So this is another scan showing a baby. This is a nuchal scan, NT scan. As you can see, the nuchal translucency is 6 millimeter in this case. So the questions which you can ask for with this picture are, what is the optimal gestational age required and the crown rump length for performing the NT scan? What should be included in an NT scan? And what happens to beta HCG and Pepe markers in trisomy 21, 18, and 13? And what are the implications and associations of an increased NT? So any of these 2 or 3 questions can be asked when this picture is shown to you. And this is how you will answer. Next slide. So the first question was, what is the optimum age? It is at 11 weeks to 13 plus 6 weeks gestation, or a CRL should be between 45 to 84 millimeter. This you have to write. And when they ask what is the optimal gestational age, these are very set criteria that you have to have 11 to 13 plus 6. Don't send a patient at 15 weeks for an NT. And CRL should be 45 to 84 mm. Then what should be included in an NT scan? When you write a prescription for an NT, write down the detailed history, mother's age, LMP, weight, BMI, and then the person who's doing the NT should include a nuchal translucency, a CRL, a BPD FLAC, a nasal bone, a ductus venosus assessment, rule out a TR. They should measure the uterine PI and the mean, the fetal heart rate, cervix, placenta, and a subjective amniotic fluid assessment. Twins, if it is a twin, and definitely a chorionicity. And it should be actually an NT. And if there is a defect, you can also use this first trimester with this reversal of the pyramid. Now they are picking up most of the problems in the first trimester. Now the third question which asked was, what happens to the beta HCG and Pepe in the trisomy 21? So I have just enumerated. If you see the free beta HCG and the Pepe, in a trisomy 21, beta is high and Pepe is low. Whereas 13 and 18, both are low. The fourth question was, what are the implications and associations? Say you have a patient and she says, like this patient comes to you. She says, doctor, now my NT is 6 mm. What is wrong with me? So what are the implications? So you can just write few marks that chromosomal anomalies, that is very high, almost 65% if NT is more than 6.5 mm. Then fetal death may occur and major congenital defects and syndromes can occur, like achondrogenesis, achondroplasia, Noonan, DeGeorge, Robin, akinesia, Prine, lots of vector abnormalities, etc. So this patient should be immediately referred to a fetal medicine specialist for further management. Next slide, please. So this is a patient who is a second gravida, first normal delivery, no abortions. She comes to you at fixed 5 weeks of amenorrhea with severe pain abdomen, and this left adnexa, as you can see, a fireball sign with the intrauterine G sac is there. Sorry, not an intrauterine. There is a gestational sac is seen and a fireball appearance, and the uterus is on the left and it is seen separately, and the report comes as left ectopic. Now, the question which can be asked pertaining to this is, when should we consider methotrexate? Mention the criteria. You can also be asked, how do you monitor or follow a patient on methotrexate? Third, what drugs to be avoided when patient is on methotrexate? How long to avoid pregnancy? And what surgery is done for ectopic pregnancy? So in a nutshell, since time is running short, I will run over. So the criteria which you should give, enumerate or write in your exam sheets are that when patient is clinically stable, beta is between 1500 to 5000. There is no fetal heart rate sounds. SAC is less than 35 mm. There is no intrauterine pregnancy. Patient is willing for follow-up, and she's not allergic to methotrexate, mind you. So that is the case, you will give the methotrexate. Now monitoring would be, you're given methotrexate, then you do the beta HCG on day 4 and day 7 after methotrexate. And now how will you interpret it? You will see if it falls to more than or equal to 15% from the first day, you can continue expectant management. But if it does not fall or increases, you discontinue the methotrexate. Third question we asked you was, what drugs or what all to be avoided? So alcohol is to be avoided and folic acid is to be avoided. That is all you will write. Now, how long to avoid pregnancy? 3 months after the last dose of methotrexate. And what surgery since it's a very generic question, you can just say a salpingostomy if contralateral tube is also abnormal and if the tube is not rusted or ruptured. And salpingectomy you can do if contralateral tube is normal or if the tube is ruptured. So next slide, please. I think we have time for just last slide. So we will quickly take it. So this will be shown to you and the questions can be: what is carbetocin? What is the difference between the half-life of oxytocin and carbetocin? You can also be asked how it works. What are the contraindications? Has WHO recommended carbetocin for prevention of PPH? And what is the dose of carbetocin and can it be diluted? And when should be given? So these are the various, I have put all the questions they can ask you. So you should know the answer. So basically, what is carbetocin? It is a synthetic analog of human oxytocin with some structural modifications. These structural modifications increase the half-life. So they prolongs the pharmacological effect. The next question was the difference is half-life 40 minutes, which is 10 times higher than oxytocin, which is roughly 4 to 6 minutes. And carbetocin also needs no repeated administration, no dose variation, and single dose is effective in controlling PPH. Next slide, how it works. It is superior with this pharmacologic this thing. So duration of action I've already told you, and basically oxytocin is used for augmenting and inducing, whereas carbetocin is not used for augmentation of labor. Next slide, please. Now it works by oxytocin receptors, stimulating the oxytocin receptors, which causes the uterus to contract. And it has oxytocin, uterotonic, and anti-hemorrhagic properties. Next slide, please. So what are the contraindications when you cannot give? Epilepsy and caution in hypertensive and eclamptic patients. And it should never be given before delivery. It can cause cardiac arrest, respiratory distress, cardiac distress in mother or baby. Next, now the question is, has the WHO recommended for prevention? As you can see, that they have very clearly said that it can be used for prevention of PPH, along with, as they have said in, if you see point 1.2, use of carbetocin 100 microgram IM IV is recommended for the prevention of PPH for all births in context where its cost is comparable to other effective uterotonics. So it is a content specific recommendation. So to answer this question, yes, it can be used for prevention of PPH, right? Like just like meso, etc., it can be used, right? Next slide, please. So has it dose is what is the dose? Single dose 100 micrograms, which is contained in 1 ml, should be administered IV as a bolus slowly over 1 minute after delivery of the child. Similarly, vaginal, same dose after delivery of the child for active management of third stage as a bolus injection over 1 minute. Next slide, please. Do we have time, Mamta? Can I take this last question on a pap smear?
Yes, ma'am, we have time. 5 minutes you can take, ma'am. We basically started also 15 minutes.
Yes. This is my last question. So this is always good. Something to do with pap smear or colposcopy or a via villi is always given in a OSCE. So I will project this pap smear. You can see the vaginal, the intermediate cells and the superficial cells. And you see these funny cells which are marked by an arrow. So you can be asked many questions for it. Mamta, you can keep this slide projected so that they can appreciate what I'm going to ask them. So you can be asked 4 questions on this. The first question can be identify and describe image at A and give the diagnosis. So you will say these are malignant squamous cells which are showing increased nuclear cytoplasmic ratio. And as you can see, it's a very coarse chromatin and isocytosis, and diagnosis is cervical cancer. The second question can be, do you need to confirm the diagnosis? Sample answer, yes. Then the third question can be, what is the recommended screening protocol for cervical cancer by pap smear? Mention 3 points. So you can project that picture now. They can see the 3 points. So I think Mamta, you can also correct me if I'm wrong, that you need to screen the protocol, start at 21 years. Next slide, next 21 years of age, and Foxy says 24 years. Mamta, you can correct me if there
is 25 years and above, yeah. But if the woman is sexually active, you have to basically screen early.
Earlier. So 21 years of age, or as Foxy says 24, 25 in sexually active women. You frequencies every 3 years, and but if you are doing HPV, then you can do co-testing HPV, then you do 5 yearly and continue till 65 years of age. And the last two questions, last question can be, name 2 other methods that can be used for screening for cervical cancer on OPD basis in the low resource areas. So if you don't have access, then you can just simply say visual inspection with acetic acid or visual inspection with Lugol's IOD. Thank you so much, Mamta. And students, if you have any queries, questions, how to answer OSCE, you can ask. You can unmute yourself and ask.
I can stop sharing now, and they can ask if they have any questions.
Yeah, we have, I think, 1 minute odd or something.
Let me go through the chat box if they have.
So I think we can conclude the session, Mamta.
Yeah.
And thank you to Dr. Chandra for contributing to this wonderful OSCE session. And thank you, organizers. Thank you very much.
Thank you so much.
So we move on to the next session for examination and the dummy pelvis, which will be taken by Dr. Aruna Nigam, ma'am. So Aruna ma'am doesn't need any introduction. She's the professor and unit head at HIMSIR, Delhi, established endoscopy unit there, have more than 200 publications in various national and international journals, and with citations more than 1,500. Editor-in-chief of Pan-Asian Journal of Obs and Gynae, national corresponding editor Jogi, author of mobile app on mechanism of labor for postgraduates and undergraduates, editor of book Management of PPH, A Practical Perspective, Preterm Labor and Recent Advances in Obs and Gynae, executive editor, Indian Journal of Medical Specialties. And she's the recipient of Ethicon Fellowship for Endoscopy, and she has been awarded MNAMS in 2015.
Okay. So this mobile app is now nowhere. I think I have sent you a previous my CV. So now I have a website where all these lectures are available. So thank you, Dr. Mala, for inviting me for this lecture. And it's very difficult to take a dummy pelvis on a webinar. To be very frank, it's really difficult because once you are there in an offline session, the dummy pelvis can be best taken there only because basic concept you have already in your minds when you have done your undergraduate, and in postgraduate there is not much a difference, but it is the way how you present, and you are always being asked regarding the different presentations. So I have kept tried to keep the pelvis with me because on first day I have seen breech presentation where they tried to play a video, but it was could not be played nicely, and there was a lot of internet problems, and there is a gap which was there, so video was not playing nicely. So I'm not playing on video. So what in my this 1 hour time, I have divided my lecture in a way so that I can cover the dummy pelvis basically along with the normal labor and occipital posterior position, because breech has already been taken, and I talked to Dr. Mala that it has been covered, so I don't need to cover. And if time permits, I have seen that shoulder dystocia has not been covered, which is generally been asked in the table viva when you are on a dummy pelvis. So that I'll try to cover in this 1 hour time. So now I'll just recapitulate the basic concept with my slideshow also. So let me share my screen. In between, anybody if wants to ask any question can ask on a chat box. So let me share the screen first. Okay, so this I will put here. Okay, so dummy pelvis I am going to take. Yeah. So objective is to tell you basically what are the questions being asked routinely in your postgraduate viva. Right. So maternal pelvis and fetal skull I am going to cover, normal labor, occipital posterior position, and if the time permits, I will take on the shoulder dystocia. So let's see the maternal pelvis, which is very important. And number foremost, I have put in few questions which are routinely being asked when the maternal pelvis is being given to you. You see, you need to know all the diameters. That is very important, and I'm not going to recapitulate much on it. Right. So give me 1 minute. I just will get one pen, so that I can tell you. I kept the pelvis and I forgot to keep a pen so that I can demonstrate few of the things to you. Right. So number 1 point is how to hold the pelvis. Whenever the question about any pelvis is being asked, you have to hold this pelvis in a right manner. That is the one thing which the examiner is going to observe, right? So you all know that the pelvis, the inlet, makes an inclination angle, which is 55 degrees. So you have to hold it like this. And how to hold it correctly, you just can show to examiner also. If there is any flat surface, what you do, you go and put your ASIS, right? Put your ASIS and the pubic tubercle so that you just go and keep it like this. So this makes that both these landmarks should come on a coronal plane. This is important for the point of view of gynecological things also, and for the obstetric also. The normal inclination of the pelvis should be kept like this, right? When the patient is lying down, it is like this. But whenever you are holding it to tell any of the diameters, you should be holding it so that your ASIS and the pubic tubercle should come in one coronal plane. So you will just put this pelvis like that so that you will come to know that this is coming in one coronal plane. So number 1 thing, which is very important whenever you are going to exam, and you should not be saying anything wrong regarding dummy pelvis. That is very important because this is the base of the obstetrics which is going to be asked to you. The second question which can be asked to you regarding the pelvic diameters, right? So inlet, cavity and outlet. So you can be asked regarding the inlet boundaries. These are the basic questions which are being asked during the undergraduate viva also, but examiner can ask to show you the landmarks because many of you don't know where is the pubic tubercle, where is the pectineal line, where is the iliopubic eminence, right? Where is the iliopectineal line? Where is these are the basic things which are being done wrong by you. So in our inlet boundaries, each and every point is very important, right? So you need to identify these landmark points there in front of the examiner whenever you are asked about the inlet boundaries. Now coming to the diameters of the pelvis. So it is not difficult to remember. There is an inlet, there is a cavity, and there is an outlet. And if I make a grid, see, if I make a grid of it, we have all the areas have got 3 diameters, anterior, posterior, right? We have oblique diameter and we have a transverse diameter, right? This is inlet, this is cavity, and this is outlet. If you see in the inlet, the anterior posterior diameter is 11, oblique diameter is 12, and the transverse is 13, right? Then you go like this. All the cavity diameters are as such 12. We don't have as such any oblique diameter in the cavity, but in outlet, again, you rotate it. So now this is AP diameter is 13, oblique is 12, and the transverse is 11. Got it? So it is not difficult to remember these diameter कि ऊपर वाला 11, 12, 13 है, नीचे वाला 13, 12, 11 है और बीच का 12, 12 in general. Right? So you need to know these diameter. And if you see, there occurs a reversal of the diameter from inlet to outlet, because at outlet, everything has to come out from the anterior posterior diameter. So it is the largest one. So it is 13 centimeter. Another question comes, which is being asked to you, is important landmarks during pelvic examination. And this is the basic mistake which is being done by most of you, how to do the pelvic assessment in a laboring patient. Very important point. And the two important point here, you need to know whenever you are doing a pelvic examination and as an obstetrician, the distance from the tip of the middle finger to this angle. This all of you should be knowing, because examiner can ask, do you know your distance from the middle finger? You might be short stature, you might be very tall. So this distance differs between the people. So you need to know the distance between the middle finger and this part, right? Another important point, you need to know the distance between the middle and the index finger, because this is the way you are going to assess the biaxial diameter. Right? So now question comes, how do you perform the pelvic examination? So very importantly, whenever this question is being asked, this is the basic thing that with all aseptic precautions, you will insert your 2 finger inside. And first part which you do is try to reach till the sacral promontory. That is why you need to know this distance and which conjugate you are going to assess by this. Anterior posterior diameter, you all say that there is one true conjugate, one diagonal conjugate, and obstetrical conjugate. Right? So everybody knows these details, but how do you assess? So routine, your fingers should not reach till sacral promontory, that is sacral promontory not reached. Then you go laterally, right? Then go laterally and assess for the ala of the sacrum, right? Sacroiliac joint, right? Then what you do? You assess the curve of the sacrum. You assess the curve of the sacrum. Routine mein, this question is very commonly asked, how many sacral vertebra you are able to feel? So only S2, 3, 4 or S3, 4, 5 are palpable. S1 is never palpable. S2 is difficult to reach. So S3, S4 you are able to feel, but rest of the sacral vertebra in a good gynecoid pelvis, you are not able to feel. Got it? Now comes how to assess the pelvic cavity. So most important 2 points are there when you are doing a pelvic examination in the pelvic cavity, that you go for this sciatic notch where 2 fingers should accommodate, and the biischial diameter which you should be palpating. And both the ischial spine should not be touched by you simultaneously. And the prominence of the ischial spine is also commented along with the side walls of the pelvis, whether they are parallel, whether they are convergent, or whether they are divergent. They should not be convergent. Got it? So this is a very important point whenever, and if the examiner you are giving good viva, they can ask you the gynecological importance of your ischial spine, because you might be knowing the ischial spine importance obstetrical. There are many points And if one of you can open your this mic and tell me what are the important points of the ischial spine. Any one of you, any one of you. Can anyone open their this mic and tell me the importance of the ischial spine? Attendees? There are many names I can say: Vaipanchi, Vinita, Simran, Soni, Sadhana, Priya, Jyoti. Yeah, someone has opened the mic. Yes, anyone? It will be good to have an interaction, because if I am going on speaking, there's no fun. You will not be able to grasp all the things. So any one of you? Or you are not there? Yeah, one attendee. Good, good, good. So who is this? Kindly switch on your mic. Yeah, Priya. Yes, Priya, please. So, somebody, ma'am, restitution takes place at bitrochanteric. Who told, this is a major mistake. You have written bitrochanteric diameter. What is bitrochanteric diameter? You should be knowing. Internal rotation occurs. Very good. Pelvic floor attachment. Can anybody? Now the question comes, what are the muscles which come under levator ani? Right? Anybody else? What have you written? So they can't speak. Okay, pelvic floor, division of common. No. Division of common iliac artery doesn't occur at the level of the ischial spine. Zero station, very good. Somebody has written nicely. This is a zero station, internal rotation, pudendal back, block, attachment of levator ani, deep transverse. Okay, so let me tell you the important things, because you have not covered the important things here. So you have told very nicely that the levator ani attachment is there. Yes, sacrospinous ligament is attached here. Pudendal block is given. Zero station is here. The level of the external os. The pelvic curve moves forward at this level. Internal rotation occurs at this level. And what else? What else? Anyone? Uterine artery crosses the ureters at this level. Okay, so these are the extra point, and you are, whenever you are doing a sacrospinous ligament fixation, you are going to palpate this spine. Okay, so these are the very important points which you have missed. Number one is station. If I talk of obstetrics, number second is pelvic curve move forwards. The level of the cervix. Uterine artery crosses the ureter. Pudendal block. Right? So these are the points should not be missed at your level. Right? Deep transverse arrest occurs. Yeah, you are right. So this is the plane of least pelvic dimension also. Right? So importance of ischial spine. Then comes the outlet. That is very important. Now I go forward. So you see, this is a ischial tuberosity, right? So whenever we are talking of outlet, two things you need to assess: transverse diameter of outlet and the subpubic angle. And how do you assess the subpubic angle? The importance of the subpubic angle, obstetrical as well as gynecological. So you put in your two routine myth. If the three fingers, your fingers are accommodating, that means your pelvis is adequate. Subpubic angle should be more than 85 degrees. Because if it is narrow, then the question comes, if it is narrow, what will happen? Right? So what will happen? This waist is false. If it is narrow, it is not going to give a space for the fetal head to accommodate. Now the fetal head will go more posteriorly, and there are more chances of third degree perineal tear. So the waist space of Morris will increase if the subpubic angle narrow, and the baby will go on the posterior side, and there will be more chances of perineal tear. Right? So now this is the subpubic angle. And then how do you assess? Once you are coming out and you are going to assess the tautness of the perineal muscles also simultaneously. Then what you have to do, you have to put your foreknuckle in between this to assess the transverse diameter of outlet. Okay, and how do you assess? You just don't keep your finger like this. You have to palpate these ischial tuberosity in a female, and then you put in your foreknuckles like this. Let me show you. Yes. You palpate this and then put in your foreknuckles. This should be accommodating four fingers easily. It is very important. Now comes the question, what is the importance of assessing the outlet? Because once you are assessing the CPD, generally you are assessing at the level of the inlet, with that the engagement is not occurring. So the pelvic outlet, because if you have allowed the labor in the very narrow outlet, this baby is again not going to come, and you are going to do a cesarean section in a second stage, and which is going to be more problematic. Right? So you need to assess the pelvis completely. Now the question comes, when to assess the pelvis? So the best answer is you should be assessing the pelvis at the start of the labor. There's no fun of assessing you. Yes, you can go for assessment at 38, 39 weeks, but it is not very beneficial. You must be assessing the pelvis after the labor starts, because that is the time when the pelvic ligaments are getting relaxed, and you can assess the engagement in a better manner, right? So now let me erase this thing. Erase all. No? So once I have finished with, and also you assess the mobility of the coccyx also. Sometimes the coccyx is jutting. Pelvic diameter assessment I have taken. Now, importance. Now, another very important question when you are telling the pelvis, and we can go regarding the importance of assessment of relationship of the fetal head and the pelvis in the abdominal and the vaginal examination, because you said that ischial spine is the level where the zero station is occurring. So then, when you are using the LCG or a partogram, how do you ascend the descent of the head? A very important question. So it is not a vaginal examination which you are doing for the plotting the chart. It is the abdominal examination which is assessing your descent of the head. Remember this point, very important. And whenever you are presenting an abdominal examination, third and the fourth pelvic rib are very important, and the importance of fourth pelvic rib is being asked, because in that only you are assessing the flexion of the head and how much head has gone inside. And this is the question being asked, how do you assess? What do you mean by 2 by 5, 3 by 5, 4 by 5? What do you mean by that? And how does it corroborate with your vaginal findings? When the head is engaged, where the vertex is felt? Can anybody write down on a question answers? Let me check. So anybody can answer me, when the head is engaged, where the vertex is being felt? We can't see your video. I'm not playing any video, madam. So Pallavi, I'm not playing any video, so there's no need, right? So now, can you answer one question of mine? If the head is engaged, where is the vertex? Any one of you, please. Anyone? Yeah, some people have written 0, 0 ischial spine, not -1, not -3, ischial spine, 0 station, right? So 3 of you have put in a right manner that when the head is 2 by 5, that means when it is called engaged, that means it is 2 by 5 palpable, and at that time vertex is at 0 station. Okay, so that is very important point. And how do you assess the abdominal examination? You can use finger breadth method, Christian method, or Nautilowitz method to assess. And when you are putting up your finger, now my next question is, when you are putting up your fingers for a finger breadth method, what are the 2 points in between which you are going to keep your fingers? Anyone? Anyone? Just write down hurriedly. Yes. Anyone answering? When you are putting up your this thing finger. What are the points in between which you put your finger to assess that how much head has gone inside? Anyone? Because this is a very important point. So someone is writing, we move forward, 0 station. No, inguinal ligament, and no, Ritu, it is not an inguinal ligament in the presenting part. So my question is right, so that you can get a concept of it. Anyone else? Do you want to try this question? Sincipit and occipit, no. So no bilateral inguinal ligament, no. Both sincipit and occipit, no. You can have only 1 point. So what else? What else? Anyone? So now some pubic symphysis, 1 point is correct. Second point, because if you want to keep your fingers, it should be between 2 fixed points. It should not be over. It is just like that you have put above the pubic symphysis to assess the head. No, it is. Now let me answer this question. It would have above pubic symphysis, yes or no? No, all answers are wrong. Right. So what you do, you palpate the sincipit and you palpate the pubic symphysis, and in between these 2 points, you are going to put your finger to assess how much head is up. So if your 3 fingers are above, that means it is 3/5. If your 2 fingers are between the sincipit and pubic symphysis, it is 2/5. If you're not palpable, it is 0/5. Remember that it is a sincipit, not occipit, because once it is 2/5, occipit is almost gone inside, right? So occipit is not coming in the role here. It is the sincipit. And how do you assess the flexion? It is between the level of the relationship between the sincipit and the occipit, which you are going to assess the flexion of the head. If the head is well flexed, that means sincipit is above and occipit is below. I hope this concept is clear, and that is the importance of the Another important, why do you want to assess? If you can see the head from the below, they can give you a situation that you have seen, you are going to put an instrument or you are going to assess the labor, your head is being felt down and you want to put in an instrument. Will you like to go for abdominal examination? So you will say, yes, I would like to go for abdominal examination. Why you would like to go for abdominal examination? Because this might be a caput. So whenever you are putting up your instrument, no part of the head should be palpable parabdominally. Remember this thing, no part. Somewhere in your book it is written, it should be less than 1/5 or something like that. No, we are putting generally the outlet forceps and your head should not be palpable above head. And if it is palpable above pubic symphysis, that means your patient is going into obstruction and it is the caput which you are feeling at +3 station. So remember this very important point. So outlet assessment, importance of subpubic angle, I have already told you. Now, pelvic axis, a very important part which is being asked regarding the anatomical and the obstetrical axis. So you need to tell what is the direction of the anatomical axis. So axis of the inlet, cavity, and the outlet makes an anatomical axis, which is downwards, backwards, then downwards, and then downwards and forwards. But obstetrical axis, I told you, it is changing at the level of the 0 station. So obstetrical axis changes at the level of ischial spine and it is downwards and backwards and then it moves forward. So this is the importance of the points regarding the maternal pelvis. Coming to the fetal skull diameters, which are generally we think that you should be knowing it, but still just to cover it, I just in a hurried way, anybody can ask you that what are the important diameters. So transverse diameter, it is a parietal diameter, you should be knowing 9.5 centimeter, and a non-compressible diameter, that is a bimastoid diameter, which is 7.5 centimeter. And why it has got importance? Because if your pelvis, if you are very good in the destructive operations, then your biischial diameter should not be less than 7.5 centimeter, because this is a not compressible transverse diameter of the head. Now coming to the anterior posterior diameter, which is very important, and I'm going to tell you, fully flexed, partially flexed, partially extended, and fully extended head. And these are the diameters: suboccipitobrachmatic, suboccipitofrontal, occipitofrontal, mentovertical, submentovertical, and submentobrachmatic. So lower one are for the face presentation. Mentovertical is for your this thing brow presentation. Occipitofrontal, suboccipitofrontal are generally for the this occipito-posterior position, and suboccipitobrachmatic is for the routine, your fully flexed head in a occipito-anterior position. You should be knowing 9.5 beard extend. I'm not going into the detail of it, but this can a very common question when if you are not telling skull diameters, you are likely to fail. Coming to the mechanism of normal labor, because this is the becoming aware whether you are going to present a breech presentation or you are going to present the occipito-posterior position. If you know the basic mechanism of labor, you can present anything. I tell you. So whenever you are presenting this mechanism of labor in a pelvis, how you have to start. So these are the points which you always have to say, that it is a longitudinal lie, fetal attitude fully flexed or extended or partially extended, whatever it is. Presentation, it is a vertex presentation, cephalic presentation. Vertex is a presenting part, denominator is a fixed bony point, which is occipit in my case, and position is left occipito anterior, transverse, posterior, whatever is being asked to you. So the definition of all this is very important, right? So I hope you should all be knowing. So whenever you keep your baby fully flexed, whether I'm holding in a occipito-posterior manner, because we don't I want to ask you a mechanism of normal labor. If I want to ask, I will ask you a breech presentation or occipito-posterior position. Otherwise, for a postgraduate, I'm not going to ask regarding the normal labor, right? So, you have to hold the baby in a nice manner with a saying that it is a longitudinal like a flick presentation, occipit is a denominator, and it is a left occipito anterior or a posterior position. Then comes how to present in general the rest of the things. So there are cardinal movements of the during the mechanism of labor. Everybody knows that there occurs an engagement, internal rotation, crowning, delivery of head, restitution, external rotation, delivery of shoulders, and transbilateral flexion. This is the common thing, and it occurs in a similar manner. And simultaneously, you have to say the flexion and the descent are the continuous process which occur throughout the labor. Then it can be asked why there occurs a flexion and why there occurs a descent. So flexion generally occurs because of the resistance offered by the pelvic floor muscles and the continuous uterine contractions and the retraction. Similar is the reason of the descent of the fetus. Why it is because of the uterine contraction and retraction, and you need to know what is retraction. Right? So I'm not going here. You should be knowing the retraction. Somebody can write down in between that what is retraction. So, and it is the straightening of the fetal ovoid which is causing the descent. The flexion. Now, the flexion, there are one or two more theories which are there regarding the flexion. That is a two-arm lever theory. Somebody can ask, but generally this question is not being asked. Right. Now comes the what is engagement. Engagement, when एक बार आपने बता दिया कि लाई क्या है, presentation क्या है, presenting what is the presenting part. Now we move forward. What is engagement and what is the engaging diameter, right? So whenever engaging diameter is being asked, this tells you the what is the attitude of your head, because in all the conditions, biparatal diameter is a fixed transverse diameter which always is there. And when it crosses the pelvic rim, it is called as engagement. But engagement is delayed if the head is partially flexed. So who is responsible for causing the engagement? It is the anterior posterior diameter. So engaging diameter anterior posterior, you need to tell that suboccipitobrachmatic or suboccipitofrontal is a engaging diameter, and head is engaging in which diameter of the pelvis, which is a routine mistake which you skip off. Right. So you need to tell the head is engaging head is engaging in one of the oblique diameter, and if it is a left occipital anterior, it is the right oblique diameter. Now again, the principle is there. Some principles are there for the mechanism of labor, that whatever diameter the head is engaging, the shoulders will be engaging in the opposite diameter. Remember that. Similar way, if you are presenting a breech presentation, the bitokentic diameter, bisacromial diameter engages in one diameter and the head engages in the another opposite oblique diameter. Please remember this principle of the dummy pelvis, right? So engagement, once the maximum transverse diameter, head is engaging in a right oblique diameter, left occipital transverse, or this position is a commonest position. Then as soon as the head occipit touches the pelvic floor, it moves anteriorly by 1/8 of the circle, right? So 1/8 of the circle se kya matlab hua? Why it has moved? Why there occurs an internal rotation? It is the slope of the pelvic floor. It is the direction of the levator and eye muscle fibers, which are directed downwards, backward, medially. Remember that, downwards, backward, medially, and then the head is moving forward, right? And there is an anteriorly deficient wall. Okay, long anterior posterior diameter and a good uterine contractions. These are the causes of the internal rotation. So it moves anteriorly. So remember that whatever is touching the pelvic floor, it will move anteriorly. Then the occiput hinges behind the pubic symphysis, and the delivery of the head is occurring by the process of the extension. Remember, by extension. Then the restitution occur in the opposite diameter. And this opposite diameter relieves the neck torsion, and at this point, your shoulders are lying in the opposite oblique diameter. That means they are now engaging in a left oblique diameter, and then there occurs an external rotation in a similar direction of the restitution, so that whatever has to come out, it has to come in the anterior posterior diameter. Remember that, right? So to bring these shoulders in anterior posterior direction, now this anterior shoulder hinges behind the pubic symphysis, posterior shoulder sweeps around the perineum, and the delivery of the baby occurs. You should be knowing the components of the AMTSL, and you should be, as a postgraduate, should be knowing what are the changes which are there by WHO recommendation on AMTSL. Okay, I'm going on telling you few of the questions which will be asked once you contemplate the delivery. So this finishes the normal labor. Coming to this, I have covered. So delivery of shoulders here, this I covered. Now coming to the occipito-posterior position, I told you, if you will be asked regarding the occipito-posterior position, or you will be asked regarding the breech presentation, which is a common thing. So let me check any questions are there. Please show subpubic angle once. Capit kya ho gaya, biparatal diameter kya ho gaya malum. Okay, this is subpubic angle. This is subpubic angle. You can put your finger like this also, or you can put your finger like this also. So now coming to the occipito-posterior position. अब occipito-posterior position आपको, you are not an undergraduate कि आपसे just पूछे जरा इतना ही बता दो कि बस occipito-posterior position में what happens. No, I'm not concerned with that. If I'm asking my postgraduates this thing. So in occipito-posterior position, I'll ask, how do you identify on an abdominal examination that this is a occipito-posterior position, and I can easily tell this thing. So anybody of you, if you want to write down few of the findings of the occipito-posterior position, which can be identified just by abdominal examination. And also write down the vaginal findings also. These are the very important points, because in this condition, the head is deflex. That is why it is. So किस type की pelvis में ये common होगा? Where there is a high inclination. High inclination मतलब ये ऊपर हो गया. ठीक है, जब inclination और sacralization of the lumbar vertebra हो गया. Right? If there is an anterior placenta, देखो, there is a dictum. I told you there are many dictums in the labor that fetus faces its placenta, right? So if the placenta is anterior, expect that the baby it might be in an occipito-posterior position. Second point, why it is occipito-anterior position is common. एक दूसरे से spine क्या है? The maternal spine and the fetal spine will fight with each other. So it rotates. Anterior placenta as well as maternal, it can't remain like this. That is why it is the occipito-posterior position. Now, what abdominal findings? Because the long birth canal, anthropoid pelvis, deflexed head. So these are the, so what your abdominal findings, there will be, somebody has written something, platyploid. No, platyploid pelvis is not there. Pallavi. Okay, so now in abdominal examination, you get a suprapubic flattening. I don't know how many of you have observed suprapubic flattening. Number 1 point. Number 2, this is a abdominal exam. Very good, Rashmi. FHS will be in flanks and suprapubic flattening. These are the 2 points we tell to undergraduate. But what as a postgraduate you are going to tell me? It is a deflexed head. So since you will be finding sincipit and occipit, it might be at similar levels. There is a delayed engagement. So head might be palatable. Head will be, most of the times it is 3/5 or 4/5. Delayed engagement will be there, right? And then what will be the vaginal findings down there? Long bag of membrane. Effacement will be delayed. Dilatation will be delayed. There will be early rupture of membrane. There are chances of corporate error because head is not fixing over it. Can anybody tell me what is the difference between the fixed and the engaged head? Fixed and the engaged head. That is very important point. Just go on writing on the chat box. Okay. So, coming back to, so I told you, these are the things which I want from a postgraduate when they are telling me the abdominal examination and a vaginal things. Now, with there are good uterine contractions, baby size is average, this will turn into a favorable position. And what those favorable position can be, what can be the outcome of labor in a occipito-posterior position? What can be the occipito-posterior outcome? So there can be 3 outcomes in the occipito-posterior position. Rotation occurs. कहाँ से आ गया? No, Pallavi. Engaged head means head is not palpable abdominally is an absolutely wrong answer. Okay, fixed head means head entered the pelvis, that is right, but you are not able to ballot. But then what is engaged head? There are 2 different. The fixed head can be engaged if that much part of the diameter have gone inside. So it's not necessary that fixed head is engaged head. So this head can be engaged even if it has entered 1/5. So 2/5 because you are not able to ballot it. Okay, but engaged head means that head has gone 3/5 inside. 2/5 palpable vertex is felt at the level of 0 station, and when the maximum transverse diameter has crossed the pelvic plane, that is called engagement. So engaged head is always a fixed, but fixed head is not always engaged. That is the point which you need to remember. Now coming to, right. So now coming to the occipito-posterior position. So occipito-posterior, right occipito-posterior is generally a common position. And then that case, you have to tell longitudinal lie, attitude is flexed, head may be deflexed. So the engaging diameter is suboccipito frontal or mainly the occipitofrontal, which is 11 centimeter. Got it? What is the time? Okay, I have 15 minutes left. Right. So now it engages, I told you, you have to tell the pelvic diameter also, right? So pelvic, which pelvic diameter? It is engaging in left, in a right oblique. If it is a right occipito-posterior position, it will be engaging in a right oblique diameter. Right. So when this is there, it is engaging with a good uterine contraction. There can be unfavorable and favorable. Favorable, बच्चा छोटा है, contraction good है, liker good है. it will rotate anteriorly by 3/8 of the circle. And you will say that the torsion neck cannot sustain 3/8 torsion. So what will happen? What will happen? The neck will rotate by 2/8 of the circle. So it will sustain only 1/8 of the torsion, and the delivery will be contemplated in a similar manner as it is occurring in a normal labor. But what is happening when there is occurring a only short rotation, that is 1/8 rotation? तो क्या हो जाएगा? कहाँ पहुंच जाएगा head? Can anybody tell me? कहाँ पहुंच जाएगा? So if it is occipito-posterior, short anterior rotation, it will come into a transverse position. Is it a deep transverse arrest? No, there is a definite definition for a deep transverse arrest, that the sagittal suture is lying in the transverse diameter, as well the vertex is at the level of the zero station, and the head is cervix is fully dilated, and there occurs no progress of labor for half an hour. Then it is called as deep transverse arrest. So remember the definition. केवल ये अभी यहाँ रह गया rotate करके, that doesn't mean it is going into deep transverse और अच्छे contraction है, घूम जाएगा, but generally this lands up into a deep transverse arrest. Or it can remain here also. If the occiput and the sinciput touches simultaneously, it will not move anywhere, and it will be an oblique occipito-posterior position. Or it can move posteriorly, making it a direct occipito-posterior position, right? So when the sinciput touches the pelvic floor, it moves posteriorly by 1/8 of the circle. And in this condition, the delivery is occurring in a manner of face to pubes delivery. Now, face to pubes delivery, how it is occurring, you have to see. So once with a good uterine contraction, the sinciput touches the pelvic floor and it moves posteriorly by 1/8 of the circle, lying behind the sacrum. Now the nose, it is the nose hinges behind the pubic symphysis, and the delivery of the head is occurring by the process of the flexion, bringing brow, vertex, and occiput. And then the face is delivered by the process of the extension. So in face to pubes delivery, both mechanisms are working together to deliver the head. That is first the flexion and then the extension. Otherwise, in normal cases, it is the extension which delivers the head. So now once the head is delivered, so remember that this was the occipito-posterior position in the posterior part, and this has moved on this side. Once this has moved on this side, so your shoulders, where were your shoulders? Shoulder were on opposite. So right oblique diameter was an engaging diameter, and shoulders are on a left oblique diameter. So once this comes out, the restitution occur in the opposite direction of the internal rotation. So it is occurring in this. ऐसे था, ऐसे move करा. Now to bring the shoulders in anterior posterior diameter, external rotation will occur in this manner, so that it comes in the anterior posterior diameter, and rest of the body will be delivered in a similar manner. So this is a face to pubes delivery. But there are two other methods which are given in your book, that if it is a deep transverse arrest, you can go for a manual rotation, you can go for a forceps rotation, forceps extraction, you can go for a vacuum extraction. But very practical point, in cases of a deep transverse arrest, we are going for a cesarean section. Be it very clear and answer this to examiner. If your patient, it has moved anteriorly by 1/8 of the circle, then you will like to take, and labor is not progressing. In a case of a deep transverse arrest, I will like to go for a cesarean section. Because now the reason is also there, because we are not putting nowadays forceps, especially in the north, we are not putting a high forceps or a mid-cavity forceps. We are generally putting up the forceps. This is an outlet forceps. When the head is more than +2 station, it is at +3 station. Even a vacuum we are applying at more than +2 station. So we are not going for that. But still, someone can ask you that what are those methods of manual rotation? So there is a whole hand method and a half hand method. ठीक है, तो ये कब करने हैं? When the baby is of average size, patient is getting a uterine contraction and the liquor is adequate and the pelvis is adequate. So baby adequate, pelvis adequate, contraction adequate. This is the time period when you are going for a full hand method and a half hand method. So basic concept is, अब यहाँ पे तो सर अटका हुआ है ना, sir is अटका, so you cannot rotate anything. If it is a right occipital posterior position, you will use a right hand. If it is a left occipital, you will use the opposite hand. Now, what you have to do, if you have to tell, otherwise nobody will ask, but still to complete my lesson, just to tell you, you have to, you can see my hand, you have to disimpact. You have seen this disimpact, right? Once you have disimpacted the head, now you have to rotate. So once you are rotating it, let me show you. So this is a head. You have held it like this. I have rotated it so that I can show you on a right hand. Okay, so this is a left occipital posterior position. I'm using right hand. My fingers are on the posterior parietal bone and a thumb here. So I have disimpacted the head and rotated it, so as to bring it in an anterior posterior diameter, and slight overcorrection is being done. Simultaneously, we are moving the body also in a similar direction. Otherwise, वापस torsion हो जाएगा. वापस वो अपनी जगह पहुंच जाएगा, तो बॉडी भी आपको एक हाथ से मूव करनी है. सो फर्स्ट disimpact, rotate, other hand rotating the body, and then what you do, you apply a forceps, right? So what you have to do, you have then put in your left plate first. Now here question comes that if it is a right occipital posterior position, you are rotating it. This is the only condition where the forceps plate, right plate is applied first. Remember this thing? That always the left blade is applied first, and in a right occipital posterior position, in this condition, we apply the right plate first. Getting my point? So in this manner, you apply the forceps after the rotation, and then you contemplate the delivery. Now, the question comes of the half hand method. See, these methods are very difficult to do, but let me complete the topic. So what you have to do, you have taken, अब इसमें क्या है, उसमें तो आपने अपने दोनों हाथ यूज किए थे, ठीक है, राइट के लिए लेफ्ट, लेफ्ट के लिए राइट यूज किया. नाउ इसमें you have 4 fingers. मेरा हाथ दिख रहा है? Yes, very nicely my hand can see. So we have to use your right finger. अब ये इस साइड है, मान लो ये लेफ्ट occipital posterior. We have to rotate this with this hand, give a pressure on this side and rotate it. Similar manner, if it is a right occipital posterior, we have to go posterior and rotate it in this manner. But ऐसा होता नहीं है, कुछ delivery होती नहीं है इन सब methods से nowadays, and you have to go for a cesarean section, right? So let me see, anything else is left. Vacuum extraction, manual rotation. Okay, so this finishes with your this thing. I'm not going for a face presentations and all, because those are the things not asked. So it is the normal and the occipital posterior position, which is generally being asked. And do I have a time? I will just enumerate regarding the shoulder dystocia, Dr. Mamta or somebody else from the organizer. Anyone from the organizer? Do I have a time? Or you can ask me questions. So otherwise, I will take some amount of shoulder dystocia if people want it. Any questions, please? Always right hand is used, whether it is a ROP or a LOP, if you are using a half hand method. See, the Astha breach has already been taken by someone from, I think Dr. Garima has taken. Oh. Okay. Any other question? If are there, I'll take. Otherwise, I'll just enumerate those shoulder dystocia. Anuva, are you? I have time or no? You are muted, Anuva.
Ma'am, you have 6 minutes. 6 more minutes.
6 more minutes. मेरा time शुरू होता है अब. या खत्म होता है अब. Okay, let me see. Okay, so shoulder dystocia is a one thing which go and read shoulder dystocia. That is very important. Whenever the routine axial traction fails to deliver the body, 4 minutes at a time period in which you have to deliver, and these are the drills which you generally perform. And we want you, actually in exams you can get a question also, and you can be asked regarding the basic maneuver. That is a primary maneuver. There are primary maneuvers, secondary maneuvers. If you want to go into the detail, you can go to my website. Full all videos are there. You can go and take. But remember, these are the primary and the secondary maneuver. So McRabbit's maneuver and Rubin's one. This you should be knowing and able to tell to the examiner. And the latest one is a posterior arm sling traction, which is very important method. And one conference I just was seeing on labor, they have much elaborated upon it. So this is also a good method to deliver the shoulders in cases of shoulder dystocia. This I have explained on my lectures. So McRabbit's maneuver, अब आपने diagnose कर लिया भैया आ नहीं रहा एक्सियल, तो खींचातानी नहीं करनी, because this is a bone to bone dystocia, right? So bone to bone dystocia में आपको थोड़ा अपना दिमाग लगाना पड़ेगा. You don't have to fight with the baby. Don't pull on the baby. Immediately आपकी patient head raise होता है, उसको straighten करिए, leg flex करिए, abduct करिए, and simultaneously perform a Rubin's one maneuver. And in 56% of the cases, the first primary maneuvers, that is the McRabbit's and the Rubin one, baby generally delivers. So you put in your suprapubic pressure, और suprapubic pressure ऐसे नहीं ऐसे दे रहे, you need to put in a full, जैसे आप CPR करते हो ना, in that way, because that shoulder you have to dip down in the pelvis, right? So McRabbit maneuver, you have to flex the limbs and abduct, flex and abduct. Patient should be straightened, flexed, abduct, and suprapubic pressure. And preferably the suprapubic pressure should be given from the side where the back is, because then it will help in the pressure over the shoulders in a right direction. Otherwise, आप opposite side में कर रहे हो, तो आपको जब भी flexion करना है, आपको ये suprapubic pressure देना है, तो back की side से देना है, right? उससे नहीं देना है. So that is, and then you need to know Rubin's 2, Woodcock screw, reverse Woodcock screw, posterior arm delivery, very important. Yeah, so I don't have time, so I'm not going. This helper and alarmer should be knowing. So I'll just, so anybody, if you want to click on a photograph, you can click, because if the question comes, you need to tell in this manner. PPH drill and the shoulder dystocia drill, the steps should be clear to all of you, right? So this finishes with the lecture, and all this mechanism of labor is available on my website. You can go through, and many other lectures later on also will be very helpful for you, all of you, to go through these educational lectures, which will help you in the postgraduate exam as well as theory, or whenever you are performing a surgery, right? So thank you. I thank Dr. Mala for inviting me for this interesting talk. I hope all of you are clear and you will pass with the flying colors in your exams. Best wishes to all of you.
Thank you so much, ma'am. It was wonderful you teaching labor like this. Thank you so much, ma'am.
Let me stop sharing, then thank me. Okay, now you can thank me. I have stopped sharing.
Thank you, ma'am. It was a wonderful lecture. I also had some doubts in my mind. I also had some clearance on my concepts also.
Thank you. Thank you. Thank you so much, Anuma. Okay, you can go ahead.
Yes, so we now go ahead with our next lecture on HSD, which will be taken by our own Dr. Ruma. Ma'am, Ruma ma'am, I think. Yeah. Dr. Ruma, as we all know, she is consultant in IVF unit in Sir Ganga Hospital. She has special interests in low-cost physiological stimulation for IVF and unexplained infertility. And she's our teaching faculty and guide in NB fellowship in reproductive medicine. She's a teaching faculty in Amity IFS Fellowship in Reproductive Medicine also. She's a reviewer of the Journal of Human Reproductive Sciences, and she has got 6 papers in PubMed, index journals, and 5 in non-index journals. So I request Ruma ma'am to please take our HSD session.
Thank you, Anava. So that's an old CV. Things have changed since I think I last submitted that. Many more papers on PubMed, but thank you so much for that introduction. So HSG is not a very vast topic, but this is something that, can you see my screen?
We can see your screen, ma'am.
Okay, yeah, okay, all right. So, but it's something that you all are required to know about and will probably also be performing it at some time in future. So more than, I mean, for exam's sake, of course, that remains. There is also a purpose in knowing the do's and don'ts regarding stereosalpingography, and this is what we are going to discuss through this topic. So now we use more and more fluoroscopy, which is a continuous imaging system, or a continuous radiological imaging system to view the organ of interest. So the current day HSG is basically a fluoroscopic examination of the uterus and fallopian tubes, which is used to investigate infertility and would be in the past used for recurrent spontaneous abortions. We no longer perform HSGs only with the view to investigate the uterine cavity in cases of RPL. We would do other things like a 3D ultrasound, or if you had doubts about her endometrium, do a plain 2D scan in her midcycle. HSGs in the current day and age is used mainly for the purpose of investigating infertility. Within that, there will be categories, and I'll be talking about that in the next few slides. So what you have here is, I'm sure you've all seen this. This is the whole table and a setup wherein the woman lies on the table like this. There is this spot, focal spot, which emits radiation, and it penetrates through the tissues in the pelvis, and it will cast an image on this receiver plate, which will then transmit it onto a monitor where you can see it as a live image. Now, the indications we have already said are infertility, and the purpose here is to look at the uterus, its morphology, tubal patency, and pathology. You could investigate prior to performing a tubal recanalization to know if there is any residual tubal length, proximal tubal length, for your surgery to be successful. And success is incumbent on a proximal tubal length of at least 3 to 4 centimeters left, so that when you recannulate or recanalize these tubes, the diameter between the distal end and the proximal end remains the same. Post-surgically, again, of course, you would want to assess it some months later if she has been unable to conceive. And like I already said, recurrent spontaneous abortions, we don't use it anymore, but it used to be used for ruling out congenital uterine defects or for ruling out synechia post DNCs after spontaneous abortions. So there are contraindications, and very quickly they are pregnancy, vaginal bleeding, pelvic infection, and if there is a known allergy to radiopaque dye. Now, usually women will not know that. So we will see that we have to be prepared with what is known as an emergency trolley for in all women who are undergoing HSGs using radiopaque dyes. There are relative contraindications too, like a recent uterine surgery. There has been, although such situations will not really arise, where let's say someone has had a myomectomy just a month ago and you have had to do an HSG very quickly. So that would be a relative contraindication. Adnexal masses or hydrosalpinx are definitely, you would want to avoid doing an HSG in these cases. And in such a case, if you wanted to assess tubal patency, the method of choice would be laparoscopy, where you can also perform correction simultaneously. There are certain prerequisites. There's a right time when you do it, and this is the proliferative phase in a woman, largely considered to be between day 5 and 9. So comfortably you are away from the last day of periods, and you are away from a point where she would have ovulated. So your lower limit is just after periods have ended, and your upper limit is at least 2 to 3 days prior to ovulation. So what are you trying to do? When the endometrium is thin, like it would be in days 5 to 9, it would improve visualization. And of course, you have avoided the possibility of pregnancy and unknown pregnancy as well. So, so apart from ensuring, so whenever such a woman has come to you and you've been asked to perform an HSG, you have to look at these 4 things, which is what we do at Ganga Hospital, is whether she's in the proliferative phase, whether she's indication and contraindication compliant. I showed you a chart of indications and a slide of contraindications, whether some form of antibiotic cover has been given. And I've put a star there because it remains controversial whether you need to load her with antibiotics prior or post. We'll see these looking at studies on how much antibiotics help before or not before the procedure. And antispasmodics, once again, I've put a star there, and we will be looking at pain relief measures in HSG and what evidence says. Now, you have checked that these 4 things are there. She's got the duration in which she has appeared is right. She has a true indication for undergoing HSG. She has no contraindication. And then you start looking at your trolley. In the trolley, you divide it into the HSG trolley and the drugs trolley. HSG trolley should have means to expose the cervix. Now, usually you would want to use the SIMS because you can best use the tenaculum with it. Your Casco's speculum is not very it does not give you that kind of space which a SIM speculum and a tenaculum can do. You need something to push the dye in, and that is known as HSG cannula, and these are of different types. The next slide deals with the type. You need a syringe in which you would load the radiopaque dye to push that dye in through this cannula. So that's a 20 ml syringe, and then you would need means to clean the cervix, like sponge holding forceps, cotton swabs, gauze pieces, Bovidon iodine solution, and of course you have to be using sterile gloves and sterile drapes while you do all this. The drugs trolley will contain contrast material, and this again we have a separate slide on. We will study what are the different kinds of contrast material that exist and which ones are commonly in use, what are the advantages and disadvantages of each, and those are the questions you are asked. The drugs trolley should have some means to relieve her pain. It could be an antispasmodic, it could be lignocaine jelly, it could be lignocaine injection, it could be lignocaine surface topical spray. So any one of these is fine. Then, of course, your emergency drugs like hydrocortisone, Abel, adrenaline, laryngoscope, endotracheal tube, oxygen mask, all of this. You can't do HSG without that setup being there and an anesthetist being available. In case of an emergency, you should have all of these ready in your HSG room. Coming to the cannula types, there are 2 types broadly. One is metallic and the other is non-metallic. So whenever you are given an instrument to describe, you could, and let's say you were given the first one, you could say it's a metallic HSG cannula. So does it have a tip or not? So if it has a tip like this, like how it looks, Rubin's cannula it becomes, and this is one of the first designs of HSG cannula that was available. So you can see that upon the wedge in the middle, and I just point out to it, this is the wedge. The purpose of the wedge is to, of course, wedge the cervix so that there is no backspill from the uterine cavity outside. If there is backspill, what will happen? Because the inner ostia or the uterotubal ostia form a specific point of resistance for the dye to pass through. If there isn't enough pressure in the uterine cavity, the dye will not go inside the tubes, and it will give you an impression of a false cornual block. So a good mechanism to block the cervix at its outlet is needed, and which is why all cannula come with this wedge. So this kind of model is a Rubens model. When it comes in a metallic sort of material, then it's a Rubens cannula. The same one has been copied, and where non-metallic material have been used, like polypropylene. We'll be looking at it shortly. And this is the other basic type, which is known as the Leach-Wilkinson's cannula, right? So Leach-Wilkinson's cannula has the wedge, and that wedge has serrations, and the serrations are actually screwed into the cervix, which could be painful, but it creates a kind of fluid-tight, watertight seal, which gives good results. So this is more in use, and Leach-Wilkinson is what most centers would be using. These are the same kind of designs that we talked about, but in non-metallic material. The material used here is, so some centers may still be using them. And these are, so one example is Margolins. You needn't remember the name Margolins or Spachmans, but you could at least describe it as a metallic HSG cannula with a tip, or a non-metallic HSG cannula with or without a tip. The tip, what does it do? It helps to overcome a stenotic cervix internal loss. So it just improves maneuverability within while you are doing the procedure. Apart from this, and this is of course something that we have been using for 10 years in difficult cases, where and they cause least pain because there's no metal screwing in through the cervix, which causes a lot of pain. So these are balloon tipped catheters, and the first one that you see is the commonest design, and this is what is available in most centers. It has a tip here which rests on the internal os. All this part lies in the endocervix. This is your wedge, which lies at the ectocervix, and it blocks any additional retrograde spill. And this is present it is nicely kind of placed at the internal os, and it is pulled down. It is filled with the fluid of about 2 ml or 3 ml. And then you push in the dye from here. The dye goes in through the tube, and just give me a second. I think I've managed to. Okay, yeah, the dye goes in through this plastic cannula and exits here through the holes here, enters into the uterine cavity. Because of a perfect seal that has been created at 2 levels, the dye then goes into the tubes, and if they are patent, it will demonstrate patency. So you could also have double tipped balloon cannulas sometimes on the table. If the center is very advanced, it might be using it. So these are used for sometimes for firm placement at tubal ostia for fallopian tubal catheterization. So this one goes at so this is inside the fallopian tube, the proximal end of the fallopian tube. This is at the internal os, and you push in the dye through here so that it is going directly into the fallopian tube in cases of where you find corneal block. And this is 5 to 6 French Foley's catheter also can be used if you don't find single balloon catheters like this or cannula like these. Now, which one is better? Clearly, the balloon cannula causes less pain. And during the procedure and after the procedure, there have been studies, and it's moderate quality evidence, which suggests that pain might be lower. So one could move from a metal cannula to a balloon cannula in future. Now, there are 2 kinds of contrast media. This you already know, oil-based media and water-based media. Oil-based media was what we started doing HSGs with. So our seniors would have started using oil-based media way back in 1950s and 60s and 70s. And through 3 decades, oil-based media was used. The content in it was lipiodol. This was iodine combined organically with fatty acids of poppy seed oil, which was used. And it was believed for the longest time, without any concrete evidence, that oil-based media leads to better visualization, better post-procedural fertility, higher incidence. However, those two benefits had to be compared and contrasted with and had to be thought in perspective when one faced more allergic reactions, embolism, and oil granulomas. Those were the three reasons why people moved from oil-based media to water-based media in the 1970s and 80s. Now, water-based media are benzoic acid derivatives, and they have iodine. All of these water-based media have iodine. So it's iodine, which is radiopaque. That is the one that is making your dye visible. So in oil-based media, you have poppy seed oil. In water-based media, you have benzoic acid derivatives. Now, you don't need all of this, but what you need to know is that within water-based media, you can have a hyperosmolar water-based media or a low osmolar water-based media. Hyperosmolar are the ones where their osmolarity, because the number of particles that are suspended in the fluid are more than what is physiologically present in our tissues and in our systems. So in our systems, the osmolarity is around 280 to 300 milliosmoles. When you have something to the range of 1500 milliosmoles, it becomes very hyperosmolar. What do hyperosmolar things do? They can cause irritation of the mucosa, they can cause greater pain, and they can cause extraction of water from tissues, causing dehydration. Examples of hyperosmolar water-based media are ditriazoate, urographene, still very commonly used, iodamide, iothelmate, so that's Conray, but ditriazoate is very commonly used by urogynecologists, gynecologists, and urologists. So this was replaced, and this is an improvement by a low osmolar water-based media. The low osmolar has osmolarity close to 320. So it is still not isoosmolar, but it is low osmolar compared to the previous preparations. And you have two examples here, ioxolate and iopramide, ultravist. Now, most centers or some centers would have moved to ultravist as their primary radiopaque contrast media used in HSG. And this is what we use at the center where I work, iopramide. Now, this is how the bottles look, and it's maybe available, so kept on the table, and you may be asked which is which, and if there are any advantages or disadvantages to each. So this you can immediately tell, this is an oil-based media, and oil-based media, which is, we will look at evidence shortly on which one is better, or are they equal in terms of post-procedural fertility, in terms of pain caused, in terms of visualization, how the images look, how clear they look. We will be looking at it. But this is what the thing will look. You'll be able to read, and you should be able to tell all that is being discussed here. Ditriazoate meglumine is a hyperosmolar water-based radiopaque contrast media. And this is iopramide that I talked about. It already has 370 written on it. This is the osmolarity value for this. So it is a low osmolar water-based contrast media. Now, which one is better? Are there enough trials? So this is the first one that actually came out after so many years of use, after 50 years of use of oil-based media and water-based media for hysterosalpingography in infertile women. New England Journal of Medicine 2017 finally published this trial. It was well powered. It had 554 infertile women who underwent HSG in the oil group using the oil media, and 554 using the water media. And they were looking at the post-procedural fertility. Like, that was one common notion, that it improves with oil group. There was no evidence to prove that in the last 2 decades. But this one, for the first time, actually said that there is an improved chance of post-procedural fertility if an oil-based media is used by 1.37 times risk ratio. Ongoing pregnancy, and all these figures are better. Clinical pregnancy, miscarriage rates remain the same, ectopic pregnancy rates remain the same, but live birth rates are higher because ongoing pregnancy rates are higher. Any adverse effects? Well, they looked at pain scores, and pain scores were more or less the same, and that is mentioned at the bottom. Was there a lot of time interval in terms of when pregnancies took place? And that seems to be similar at 39.9 weeks. That would be about 8 to 9 months after the procedure. That is their median value. By then, so in 2018, within a year, there had been enough number of trials, 6 trials, 2562 patients, to put into a meta-analysis, which said that there is moderate quality evidence to suggest that oil-based media would lead to a higher ongoing pregnancy rate. So they also looked at granuloma events, and they also looked at embolism events, and they did not find any in the 545 women in the oil-based media group. So whatever was being proposed in the 50s and 60s and 70s about oil-based media, one thing was true, that it does lead to a higher incidence of clinical pregnancies, but its incidence of granuloma and embolism is so low that if you thought it was significant, you'd need much higher numbers to prove that. But in this trial, they did not find any significance. So how do we prepare the woman? We ask her to void. We explain the procedure to her. We take consent after the procedure has been explained. The trolley is checked, the drugs trolley, the HSG trolley. She's laid in lithotomy position. She's draped first and prepped later. This is the order we follow in order to keep her comfortable, in order to reduce her fear and the discomfort associated with HSG. We drape her first so that she, exposure itself is a big case for anxiety. And appropriate size cannula is chosen and filled with dye using 20 ml syringe. Air bubbles are removed. Cervix is exposed using speculum, SIMS here. Local anesthesia is given with xylocaine. Like I said already, it could be a spray, it could be an injection. And cervix is there then, after you've given this anesthesia, held with Valsalem after injecting with local, and then screw in the dye-filled cannula. So here I'm talking about the Leach-Wilkinson's cannula into the cervix to make sure that the seal is effective. How do you do it? That a backward tuck should not dislodge it. That's the level of placement. And you have now, once you have placed your cannula, you have positioned the cannula and attached the syringe with the dye to the back. Now you straighten and reposition the patient into a dorsal position from lithotomy. You initially push 1 to 2 ml. So check with the radiologist if he or she is ready yet or not. They have positioned the plates on top of the abdomen. And now you push 1 to 2 ml to delineate the cavity, take a spot film, push another 1 to 2 ml to see passage through tubes, take another spot film, push slowly till bilateral spill is seen, and the total dye that is required by this time should not be more than 5 to 10 ml. If you need more, there is a backward spill. Relook at where your cannula is. Do you need to kind of move it a little left or right? And once you have seen the spill, you remove your instruments and take one delayed film after 2 to 5 minutes. It's not mandatory, but sometimes it will give you additional information about, if you had doubts about a localized spill and you remove the instrument, you found the dye going all over, it means that there are no adhesions. So this is the first film, which is what the uterus would look like. Here, of course, the cannula used is not the Leach-Wilkinson's. Here, the cannula used is a balloon cannula. And you can see that the cavity is outlined in the first film. In the second film, you can see the dye going into the tubes and outlining the tubes. In the third film, it has reached the distal end of the tube. And in the fourth film, you can see spill, which is, you can see at this level, this is the spill. So once this is done, you check on the patient if she's fine. There could be a vasovagal because of the pain. Even though you have used your pain reliever, there could still be vaso. So you have someone checking on her pulse while you're doing this. But soon after, you check with her, talk to her, inform her of the results. you may want to continue the antibiotic course if she has been on it. Pain relief measures are SOS, but you do write it on her prescription that if you have pain, you could take this medicine. And of course, you give her emergency numbers on where to contact if there are issues. Now, we perform 5 to 6 HSGs per day in the center where I work. I have to tell you that we have not had any episodes of vasovagal attacks or anything that has required to be for the anesthetist to be called in for a resuscitation. So if the HSG is done well, you would not need, I mean, you of course need to have that backup. But I mean, there is very little reason to fear an HSG. So what are the complications? Of course, there is procedural pain. How we try to, there are non-pharmacological measures as well. And we have discussed some of these in the past. I've said talking to the patient at every step, informing her of what you're doing, making her comfortable during the procedure it goes a long way in reducing her anxiety, and more anxiety equals more pain. So less anxiety will help in this case. Use of balloon catheters over metallic catheters and use of intracervical xylocaine infiltration helps reduce the pain as well. What about vasovagal reaction? It is secondary to pain. It's a rare complication, and we've already talked about how atropine and emergency tray should be ready. Dye allergy is again very rare. Frankly, I haven't seen any in the last 15 years that I've been here. And yet all of your backup needs to be at hand. Vaginal bleeding rarely, unless, I mean, the whole procedure has been very traumatic. If you have had to cannulate a stenotic cervix, sometimes there will be cervical bleeding, sometimes there will be vaginal bleeding, but generally a procedure which is done gently, you know what size speculum to use, you know what size based on her parity, based on an examination, a vaginal examination that you have done before inserting the speculum. Things tend to be very pleasant. So secondary infection 0.1 to 0.5%, that's the rate. And this happens especially in women with silent PIDs. Pre and post procedural antibiotics may reduce the incidence further. And that's the sixth complication, which is inadvertent radiation to unknown pregnancy. So one question that you are asked is, which test is better amongst different methods that are available? There's HSG, there is SSG, there is laparoscopy. Which one would you prefer? First, you need to know about how effective is HSG in diagnosing tubal block. So if you took laparoscopy as the gold standard, and so what will you find is that when HSG is suggesting a tubal obstruction, only 38%, which is 1 out of 3 women, will actually have an obstruction. Okay, so it is not a great indicator of tubal occlusion. We have to understand this, that you can give her the benefit of doubt if you think other causes may be responsible for infertility, like anovulation in PCOS women. I'll come to that. I'll just give you an example, but this is something you need to remember. Second is that when HSG suggests tubal patency, which is that it is saying tubes are patent, I will have very little reason to doubt that this is wrong. So when it is saying it is open, I will believe that it is open, right? Because that is what the studies are saying. So the common kind of terms that are used to check the effectiveness of a test are what? They are sensitivity and specificity, right? So when the outcome is tubal block, the sensitivity of HSG or its ability to pick up all true cases of block are, what is it, low or high? Is there anyone else? Okay, I don't know if there will be. So it can pick up, its sensitivity for tubal patency is very high. It is at almost 80 to 90%. That is that if the tubes are patent, it will say all patent tubes will be demonstrated as patent, most patent tubes. or am I? No, I think I'm being incorrect here. So HSG, we'll come to sensitivity and specificity in the next slide. I'm not going to confuse you there, but these two slides, these two statements hold. That is, HSG suggests tubal obstruction. It is not a very reliable indicator of tubal occlusion, but when it suggests patency, it is a reliable indicator of tubal patency. So HSG versus laparoscopy are two most widely used methods to test tubal pathology, both invasive procedures, and HSG is less so, which is why HSG remains the first line of investigation in the absence of contraindication, right? We already saw what the contraindications were: active bleeding, or known pelvic masses or pathology, or known PID. You don't want to do HSG in those cases. In these cases, you prefer a laparoscopy. So detection of tubal pathologies is better with laparoscopy. Detection and treatment of pathology missed by HSG, however, does not increase the live birth rate. So what it is saying is that laparoscopy may pick up additionally tubal adhesions, peritubal adhesions, maybe grade 1 or 2 endometriosis, maybe a little bit of what we call stenosis of the distal end of tube, but you pick it up, it is not going to change your live birth rate just by doing a laparoscopy, which is why the advice remains that you perform HSG as a first measure when you want to assess tubal patency in the absence of contraindications. So we have already seen this. This is the other test which is available, hysterosalpingo contrast sonography. Contrast media is used here, air or saline, and that gives a good contrast to outline the cavity. Gel foam is also used. Air saline contrast media is called HycoC, and foam contrast media is called HyFoC, hydroxyethyl cellulose and glycerol. And when you are injecting these contrast media, you have the choice of doing what is known as a 2D sonography or a 3D sonography, or a 3D sonography with image or noise reduction. The kind of image quality in each of these three can be very different. So this is when you are using foam, and it goes in, and this is not just foam usage, this is also noise reduction. So it's a 3D image which has blanked out or blacked out all other areas in the pelvis, and this is how it would look. It is quite similar to what an HSG produces, right? So, but when you have to produce an image like this, where everything is outlined in one image, you need a lot of technical expertise when using SSG, sonosalpingography, or these ultrasound-based patency tests. You need a highly skilled radiologist who is trained in doing 3D scans. You need those machines to do it, which is why it is not always possible to do this high level of tubal patency tests. One would still go back to HSG, which is capable of producing all these outlines in one go. And that is the kind of image clarity that HSG is able to give, which ultrasound-based tubal patency tests are unable to. Okay. Now, this is mean required contrast 9.4 and 11.5 ml. Reported pain during procedure, 56 and 72% would report pain. Reported pain 24 hours after procedure, more or less the same. And pain less than equal to usual menses. This is what 100% women are saying in HycoC, that the pain was less than menses. And 85% of the women in the HSG group are saying pain is less than the usual menses. So a HycoC has good statistical comparability and diagnostic concordance with HSG. HycoC is a suitable alternative, but one has to understand that in terms of efficacy, in terms of what it is meant to do, which is give you an answer to patency or block, it is equally effective to HSG. but it requires expertise and skill and more investment. Let us not forget that. So HSG versus laparoscopy. This is LSC's laparoscopy. What is laparoscopy doing additionally? We've already seen it is visualizing pelvic pathology, possible concomitant therapeutic, surgical correction or removal of pelvic pathology. However, it's an invasive procedure with increased morbidity and mortality, requires general anesthesia, longer post-procedure pain and recovery, and the costs can be as much as 15 to 20 times that of HSG. Last slide on, we keep arguing about, some centers will still do HSGs under general anesthesia. We haven't started that at all. Maybe occasional patients would have opted for a laparoscopy instead of HSG because they wanted no pain or zero pain. But I would say that if 5 to 6 HSGs are done in a day, and that comes to around 120 HSGs per month and about 1,500 HSGs per year, the number of women who get this done under local anesthesia or using an antispasmodic are quite a few, and they're able to comfortably do it. So there still might be some dichotomy on whether you give a lot of pain relief and what kind of pain relief is best. So that is what we are trying to look at here. Oral opioids versus placebo. So opioids are not really effective versus when you gave nothing. Intravenous opioids during the procedure compared to no treatment, it might reduce the pain by a mean of 3.53 points. If you were scoring it between 0 and 10, then the pain score will come down by 3.5 points. Non-opioid oral and analgesics like NSAIDs, no effect, and that is all that I will say. But topical anesthesia versus placebo reduces the pain during the procedure, but not after. So during the procedure, you can use lignocaine. But after the procedure, if you wanted to reduce pain, you would want to give. These are the different kinds of blocks: topical anesthesia, locally injected anesthesia, lignocaine, and topical anesthetics. So if you were giving paracervical block, it has the most efficacy versus topical anesthesia. Okay. So now we come to radiographs. This looks like, this is something, an image like this would be projected, right? So you would see that you would have to say that this is the radiograph of showing a contrast radiograph showing the outlining the uterus with a HSG cannula in situ, and it shows a regular uterine cavity and dye just beginning to enter through the cornea into the tubes. The second image shows outlines the fallopian tubes on both sides. They appear to be normal in caliber, and course is something that it appears a little convoluted here, but I wouldn't associate it with any pathology. I'd probably link it to her clinical history. This appears to be normal course. So caliber and course. And the fourth image has begun to, this third is showing us spill on this side, not so much on the right. And at the end of the procedure, the right side spill appears to be localized, but the left side spill appears to be free. So it is based on her clinical history. I will decide whether I need a laparoscopy, whether I need to investigate this further through any other tests, or whether, and if it's a long duration infertility, whether I want to offer her IVF straight away. For short duration infertility with a picture like this, 2 to 3, maybe you could give her, depending upon if she's just 1 year post trying, you could probably post an HSG because it is believed and assumed that some fertility would go up. You can ask her to try naturally in vivo or some before, and if 3 months or 4 months post HSG things have not worked, then a laparoscopy, looking at it and looking at any possible pathologies and its correction might help. But for long duration infertility, older women, a picture like this would suggest I'm not going to wait too long, probably 3 months of natural trying. If things have not worked, I would go straight in for IVF, not for a laparoscopic surgery. Now, this is an image showing, you can see something which it will look dark and very well outlined. So you will have to distinguish between whether this is an air bubble, because that is also what it can look like, or a synechia. Those are the two possible options. So in this, there is an oval filling defect. And I would also want to look at other films to see if the tubes are blocked. If the tubes were blocked, the suspicion of synechia becomes stronger, because both will have the same etiology: blocked tube, synechia, infection, PID, that kind of thing. So this here is an image showing an extremely, if I was looking from sort of below, then I would call it concave, an extremely concave fundal contour. And you can see what could this be? Because it is symmetrically concave, the first one is that this is an arcuate uterus. The second possibility I would also want to keep in mind is whether there is a space-occupying lesion lying here. Space-occupying lesion could be a fibroid. And what I would do next is check with her on her history, whether she has menorrhagia or not. And of course, look at her ultrasounds. That would best be able to tell me if she has any pathology there. So what was found, and the answer here was that this was a depression on the uterine fundus, a finding that may represent a short septum or an arcuate deformity. And if you were to go by the classification Conuta and the MRI characteristics, you would be able to tell whether this is a septum or an arcuate. There are different sort of dimensions that are used from the top of the fundus to the maximum dip that it is going at. So 1.5 centimeter and under are considered arcuate, and more than 1.5 centimeters. So it's basically a line that you draw from here to here and measure this. 1.5 centimeter and more are considered septum. Now, what is this? This would be very classic, and you might have one such image. You can see that the uterine cavity is divided into two. The lower part, the cervix, appears to be one, not into two parts. And what is the next thing I look at is how widely placed the two horns of the uterus are. If they are, so the differential diagnosis here could be one, a septum, and two is a biconnuate unicollis uterus. So if I had to differentiate between the two, I would of course rely on a 3D scan or an MRI. But before that, there are some pointers from the HSG itself that should be able to tell you. So a narrow angle between these two horns is also suggestive of a septum more than a biconnuate uterus. Okay. Now this here is very clearly, you can see how widely the angle is divided. There are two horns of the uterus. There is one cervix, but how widely placed this is, it is unlikely to be a septum when it is this widely placed. Both the tubes are outlined. And so this here is a biconnuate uterus with unicollis biconnuate uterus. The one at the bottom has two cervices. So this is this is another picture of another patient. So these are four different stages of the biconnuate uterus with various degrees of duplication of the cervix in different patients. AFS class 4, American Fertility Society. There's absolutely no duplication of the cervix here. This is partial. This is complete. And here you can see perhaps there is a septum in the vagina as well, all the way up to the ectocervix. So this is a picture showing, and this is a very common picture that you will come across. It is uterus, and you can see dye not entering into the tubes. So you would probably label it as what would you label it as? Bilateral connual block, right? So, however, I mean, if you were slightly in the know, what else would you look at? whether this block, and we have already discussed this, is because the pressure in the uterine cavity was less and so the dye did not go through. Remember, the uterotubal junction at this point and this point is very, very narrow. And for dye, which is actually flowing in through this wide area, for it to flow into, something as narrow as 1 millimeter, it will need a lot of pressure. So if there isn't enough pressure generated in the cavity, dye will also not enter. What will I look at is how much spillage has happened, retrograde spillage. And in this case, I can see that a lot of spillage has happened into the vagina. I would want to recorrect my cannula. I would want to reset it and then maybe calm the patient down, give her an antispasmodic, and 3 or 5 minutes later, push in the dye again to see if the blocked cornea open up, right? So we already saw that when you see a block on HSG, it is not always indicative of a true block. In fact, 2 out of 3 blocks will turn out to be false indicators, right? That they would actually have been open. And what's happening here? This is again an image that we see commonly. Can anyone see the tubes being outlined, or so what has happened here is basically that the dye in the uterus was at a pressure which was above the pressure of the vessels in this case. So why do you think it has entered the vessel? So this is intravasation. I can't see the tubes in this, and you can very beautifully see the outline of the pelvic vasculature, uterine and pelvic vasculature in this image. And why do you think it has entered into the vasculature? So I already said that the pressure in the cavity must have been more than the vasculature itself. And this will happen in a case of endometritis, wherein the vessels are dilated. Because they are dilated, the pressure within them is low, and it can allow even the slight bit of pressure from there to enter. So I would keep endometritis in mind. Of course, a poorly done, a badly done HSG could also be the reason, but endometritis is what I would keep in mind in such a case. Right. So I think we should end here. Do we have time? This was a clear image. This is, what do we see here? So if you can see, the cannula has gone all the way into the uterus, which looks like, it's as narrow as the cannula itself. And you can see tube on one side, okay? So this is attached to just one tube. We don't see the other half of the cavity. So this is a uniconnuate uterus with ipsilateral patent tube. I don't know if the other side uterus is there or not. So in such a case, especially you'll have to rule out a uterine didelphys, that you have seen one side of the cervix and cannulated it, you haven't seen the other side. So you relook at the cervix once more. If there is a second half, there is a lateral, a right-sided cervix present somewhere, which you've somehow missed. So you look at it and then you can. So this is what we did in this case. And we found that there was the other cervix as well. And it was actually a biconnuate, bicollis. So it was a didelphys. And when you cannulate both sides, you would know that both sides are present and the tubes are patent. And here you can see, this is one common pathology. You can see the tubes are dilated. They are not normal in caliber. There is no spillage of dye. There is also sort of segmentation of tube at various points, and there is hydrosalpinx bilateral. The uterus appears normal. There no synechia seen in this image. So terminal block. This is mid-segment block, and it has ended so abruptly that even though there is spillage here in the vagina, I wouldn't doubt what this is saying. This has block come and stopped right here. And this is an abrupt kind of ending of that tubal outline. So this was a radiograph taken post-laparoscopic tubal recanalization showing failure. And we'll just quickly end here. Yeah, just last one. You might be asked how much radiation exposure is the woman having under fluoroscopic control, because you do it over a period of 2 to 5 minutes, sometimes as long as 9 to 10 minutes also. So with procedure lasting approximately 2 minutes and 6 radiographic stills, you are exposing her to 3 to 5 millisieverts. And this is approximately equal to what we are exposed to. This is the background radiation exposure that we would have in a period of 1.5 years. Okay. So any questions, I'm happy to answer. Anuba, you could take on, but I do see, ma'am, can we do hysteroscopy but not HSG in suspected case of FGTB? Why is it so? Okay, I can answer that. So if you, and how exactly are you suspecting female genital tuberculosis? If you are suspecting it based on, let's say, a thin endometrium, there will be different ways that you can suspect it. One would be that there is history of exposure to the tubercular bacilli, either in childhood or to a family member, and there is something present in the pelvis as well, like adnexal masses, or the endometrium, which you should be assessed in the mid-cycle for thickness and vascularity. That doesn't appear right. And it's either very thin, or she has complaints of menorrhagia, abnormal uterine bleeding, or the commonest one, which would be scanty periods. In these cases, if I'm suspecting a pathology, my first investigation would not be an HSG, it would be a hysteroscopy coupled with a laparoscopy. I wouldn't miss out on a laparoscopy. Remember that genital tuberculosis starts from the tubes. Okay, those are the organs that are affected in 100% of the cases of female genital tuberculosis. And from there, it is a retrograde spread into the uterus, then to the cervix, and then downward. So it is not from partner to partner. It's not through sexual contact. Okay, like how chlamydia is. TB will be spread through lymphatics or through hematogenous spread from another primary source like the lungs, or a urological site, but it will never spread from cervix upwards, which is why if I'm suspecting female genital tuberculosis, I would not just want to do a hysteroscopy, I would also want to couple it with a laparoscopy. So laparoscopy is going to of course, look at any pathology, any adhesions, any granulomas, tubercles, and if none are there, I would also be able to assess my tubes in the same setting. And hysteroscopy is done to be able to sample the endometrium. Although we understand that in terms of frequency of distribution, which organ is affected the most, 100% it is the tubes, 60% cases it is also the uterus, and in terms of cervix and elsewhere. So if I'm sampling endometrium from the uterus, I may be missing out, let's say, pathology if it was lying in the fallopian tubes. With blocked tubes, I can take a sample of the areas which are hard, which are indurated, which have granulomas, and tubercles, which have tubercles present on them. But if the tubes are patent, I don't want to touch them. My biopsy is going to destroy those tubes. So herein, I, of course, then rely on the endometrium, which is a self-regenerating system. So biopsying the endometrium does not hurt the woman. Biopsying patent tubes if you wanted to rule out tuberculosis, will definitely hurt the woman. So you don't want to touch the tubes if they are patent, but you definitely want to look at peritubal adhesions, any other pathology, by doing a laparoscopy in this case. Any other questions, Anuba, or should we stop?
Yes, ma'am. We have a common question. How can we differentiate between arcuate and septate or biconvate?
Okay, see, because this is not a part of this, but I would just recommend that you read what is known as the Cornuta classification. There is the ESGE classification as well, which gives you radiological features on MRI and 3D ultrasound to be able to distinguish between these entities, arcuate, septate, and a normal uterus. Okay, so there are three things that you look at: the outer outline of the fundus, then you look at how much it is dipping, which is the inner outline, and then there is a line from cornea 1 to cornea 2, and then you draw your lengths how much is the length between the intercornual distance, intercornual line to the top of the fundus and intercornual line to the bottom dip. And the bottom dip is one common entity. If it is more than 1.5 centimeters and the top is between 0 and 1.5, we call it a septate uterus. Okay, so both of these have to be present. I'll need separate kind of slides to show this to you, but it is very nicely given in the classification system. So please go back and read it. It's very easy to do it. Any other?
I think that was the question, ma'am. Last question.
Can we differentiate between septate and arcuate? Actually, we have already.
Yeah, this was the common question.
Yeah. So septate and arcuate is how much the top outline is dipping inside. So basically, you're drawing a line between the two cornua, intercornual line, and the outer outline of the fundus. Outer outline of the fundus could be at 0 centimeters, which is exactly there. It could be 1 to 2 centimeters above, or it could be dipping below as well. So how much, it is these three entities that you need in order to be able to differentiate between septate and arcuate. Do go back and read this. Okay, right. So should we end this here?
Any other questions anybody has? We have got 5 minutes.
Any question on sensitivity or specificity? I'm happy to answer. Of HSG. So you can write in the chat box if I'm looking at, you know the concept of sensitivity and specificity. Some of you might, right? So see if you can answer this. If my outcome is tubal block, is the HSG more sensitive or more specific in diagnosing tubal block? Anyone can answer this. Dr. Pallavi has said sensitive. It is more sensitive in diagnosing tubal blocks. What does that mean? That of all cases of true blocks, it is able to pick up most of them, and that's true. That's true. So Dr. Pallavi has got it correct. It's more sensitive. That's correct. So if it is more sensitive, what is the positivity rate? It's the false positivity rate for blocks. So when the HSG is saying that the tubes are blocked, does it have a high false positivity rate or a true or a low false positivity rate? And somebody has already answered, Dr. Pallavi again, it has a high false positivity rate. That's true. So it is more sensitive in picking up tubal blocks, but it has a, when it says things it's blocked, the chance that it is falsely positive is high. Okay, good. So we can end this here.
Thank you, ma'am. Thank you for the lovely session. Any other questions anybody has? Still, we have, I guess, 3 minutes, 3 more minutes.
Okay, so somebody has said why HSG shouldn't be done in a case of TB. We have already answered this, I think.
Yeah, we have already, you have already answered, ma'am.
So let's say case of tuberculosis that you have proven, genital TB that you have proven through a tissue diagnosis in the past, and you have given her adequate treatment, and there are no pelvic masses, and you want to assess, so that question that has been put on the chat box is very non-specific. What kind of TB are we talking about? Past history of pulmonary COX? I can do it if I feel that there is nothing in the pelvis. There are no pelvic masses and her mid-cycle endometrium is fine and there are no other menstrual complaints. I can do HSG. That shouldn't be a problem. But in women who had, let's say, genital TB in the past, and based on a tissue diagnosis would mean histopathology, it would mean culture, it would mean your AFB staining, one of these three. PCR only if you have a strong suspicion. And PCR, again, a cartridge-based PCR, not your homegrown PCRs, because they have a high false positivity. So if there has been a tissue-based diagnosis in the past for genital TB, and you have treated it adequately, her symptoms have resolved, and there are no pelvic masses anymore, and her endometrial thickness is fine, maybe you can then do an HSG, if that was the question. Right? Any suspicion for an active TB at this point, untreated TB, you don't want to do an HSG, you want to do a laparoscopy. Okay. Are there any more? I think we are done here. So I shall log out.
Thank you so much, ma'am, for the lovely session.
Thank you.
I think it will help PGs and OSCEs also.
Okay.
Okay, thank you, ma'am. Thank you so much. So we now move to the next session on endoscopic instruments by our by our own Dr. Kanika Jain, ma'am, who has done fellowships in endoscopic and robotic surgeries, a certified robotic surgeon from EEC Paris, and is a senior consultant gynec endoscopic and robotic surgeon in our minimal access gynecological unit in Ganga Hospital. She's the ex-chairman of Endoscopy Committee 2021-23, ex-vice president AOGD 2021, member in endoscopy.
Thanks, Anuva. That's okay.
Okay.
Let's not waste time. I have, as it is, very less time for the topic that I've been given.
Okay, ma'am.
So, shall I start?
Yes, ma'am. We can start.
So, a very good afternoon to everybody. And let me just settle down. So, I have to share my slides.
You can press on the share screen option.
How do I minimize this? This whole bracket is coming.
If you share the screen, then you can minimize in the upper left corner also.
Okay. So is my screen visible now?
Yes, ma'am. It's visible now. Slideshow, I think.
Yeah, that is what I was looking for.
Yes, ma'am. A bit lower in the right corner, lower.
Yeah. It was covered actually by this. So.
Yes, ma'am.
Okay. So are my slides moving?
Yes, ma'am. Moving just the slideshow.
Yeah. Can you see the slideshow?
Yes, ma'am. The slideshow is there, but just turn the next slide so that we can see the next slide. If it's
Are you seeing the next slide?
Yes, ma'am.
Okay, fine. So, and am I audible?
Yes, ma'am. Clearly audible.
Okay, thank you, Anuva. So let's start now. So the time allotted to me is short. So I'll just go through these and I'll try and show as many instruments as possible to the students so that they get a brief understanding. The main concept in this is that they should be able to answer in the table viva, because most of the laparoscopic instruments would be asked in the table viva. So this is just a brief. I'm trying to show you the patient positioning, right? So here, if you see, the patient has been put in the modified David Lloyd's position. Sorry for that. This is the modified Allen setup. This is what I was actually trying to show. So these are the modifications that we have adopted in Ganga. And I think I'll escape the slideshow and I'll show you. Otherwise my slides are not. I'm not able to control the video play. Just a second. So here, these are the modified Allen stirrups. The patient has been put in the dorsal position with slight abduction and flexion at the hip joint, and the knees are almost straight. And these are the gel paddings that we put. Then the floatrons are connected. The cautery pad is connected on the calf muscle, and we tie them. And these are the hands which are tucked in by the side, so that with the extension tube, so that the surgeon and the assistant get ample space to stand. This is the warmers that we apply, so that the body remains warm, because of the fluid. Sometimes the patient can go into hypothermia. And as you can see, the legs are being sort of tied with the bandages. So I'll show another video. Now those were the modified Allen stirrups. These are the proper Allen stirrups. So if you can see here, this is a modification that we've invented. The gloves have been filled with water and tied so that they act as gel pads for the fingers also. Now the arms are being tucked up by the side with extension tubings for us to be able to stand here. So we get more space rather than having the arms by the side and obstructing our the surgeon's way. They come in the way. So basically these are put and then the arms are tucked in. So I'll show you the video now. Just a second. So can you see the video playing now, Anuva?
Yes, ma'am. We can see the video playing.
So now we are tucking in the hands, the arms by the side. And as you can see, there are the thermals, the warmer attached. And the patient has been put in the Lloyd Davis position. And these are the Allen stirrups, the proper ones. So these can be maneuvered through the surgeon. As you can see, I can maneuver them myself. Even if I'm washed up, after the leggings are put, the sterile leggings, the drapings, we can maneuver the stirrups. So this is the advantage of these stirrups. These are the floatrons which are connected to the legs, which are the DVT pumps to maintain circulation. And this is the warmer. So these are the modified Allen stirrups that we use, which are modifications. So they are definitely much cheaper. These are the proper Allen stirrups, which have these maneuvering handles for the surgeons. And they have these gel pads to prevent any nerve compression for the patient. These are the monitors that we use for the blood pressure and other things that anesthesia side. And these are the instruments that we use in the OT, the basic monitors. So this is for the ultracision. So this is Ethicon, the harmonic that we use, the minimum setting and the maximum setting. I think is the video audio audible?
No, ma'am. The video audio of the video is not there.
It's not audible. Okay, so I'll start singing. So that was the harmonic that we use. This is the instrument I will show you. We can explain that in detail. Is it seen? Anuva, can you see this?
Yes, ma'am. Yes, ma'am. We can see.
This is the harmonic, what we commonly call, which is actually the ultracision using the ultrasonic energy. So that was its cable, and this is the Carl Stone's stores. This is the insufflator that we have. So here the first is showing the pressure, the intra-abdominal pressure. This shows the inflation rate, the rate at which the gas is going, CO2, and this is the amount of gas that has been used. So, so this is on, and we can increase the pressure as we enter. The first intra-abdominal pressure should be between 20 to 25 millimeters of mercury. So the setting has been done at that. And this is the operating pressure between 12 to 14 millimeters of mercury. This is the flow rate. This is the total gas which has gone in. And this is the outlet through which the gas is coming out. Ideally, it should be warmed up and warm gas should be given. But here, just a simple thing that is going. This is the recording which is being done for the surgeon. Now, this is the camera, and this is the camera, the light cable which is coming out. And so the camera is the 3-chip camera that we have, which has the 3 basic colors. I'll tell you in detail. This is the hysteromat, which we use for hysteroscopy as well as in the laparoscopy, we use it for the irrigation, so that the water comes through this. So basically, once it is on, the fluid goes through this and it connected to the pipe. This they are trying to show how it is put on. You have to press the pedal, then put the switch, but let the lights flicker and come to a halt. Then you press the on button. Once they start flickering, then you release the foot pedal from the hysteromat. And that is when the flow starts. Right? And we normally use warm saline for irrigation. So we put the big 3 liters bottle of the saline into a warmer, and that warm saline is used for irrigation because the cold should not be used. Now, these are our monitors, the HD monitors. And there should be a separate monitor for the patient, for the doctor, surgeon, and as well as the assistant. This is the force triad. Now, I'll just explain. So this is basically showing, this is force triad has 3 things for the basic monopolar. This is for the bipolar, and this is for the advanced bipolar devices. So here, monopolar can be set at cutting or coagulation. So this is a pure cutting or a blend, which is used for cutting. And the coagulation can be at the fulguration mode or the spraying mode. So here we are using the coagulation at present. The cutting, when we use, it can be increased further. This is for the bipolar. Again, the settings can be changed. Usually it should be set at the lowest possible setting at which you are comfortable. So normally around 20, 25, but sometimes you have to go to a higher level also. This, what they're saying is this bipolar thing can be used for a monopolar as well if we connect it to the upper knee. And this is for the advanced bipolar devices. Right, so I have to just rush through this. Now, these are the instruments that we must know about. So this is the Veery's needle, this is the reusable one, and these are the disposable ones. All of them, they have a rider inside. So it has a stillet, which is a blunt end, which is totally atraumatic. As you can see the tip, it is rounded in front. And with an eye, with this eye, this hole that you can see here, it is to facilitate the flow of gas. And then there is a sharp end, which comes out, the stillet goes in the moment it touches some tough structure. Right, the normal diameter is 1.2 to 1.8, approximately, you can say 2 millimeters. So we just need to give a small stab and it goes in. And it has to be held in a dart-shaped manner. So this is now a video showing how we should go in. So we would hold it in a dart-shaped manner and gently, normally this is going supraumbilical, so we'll feel 3 clicks. And the moment we are in, the green ball comes out with the disposable needle. We first aspirate, then push in some saline, then put some drops of saline, they go in with negative suction, and then gas is connected. So as you can see, the needle is not being moved at all. And the pressure we realize is under 10 millimeters of mercury. So that means we are into the intra-abdominal cavity, and then gently we leave the needle first and the abdominal wall after that. It cannot be vice versa. We cannot leave the abdominal wall and then leave the needle, because then the needle would partially come out and there'll be extra peritoneal pneumo created. So this is the technique. Now we have the trocars. Once we are insufflated to approximately 20 to 25 millimeters of mercury for the first trocar to put in, then we insert the trocar. These are the sharp-edged steel, non-optical and reusable trocars, right? Usually these are not used these days. Commonly what we use are the disposable ones. And these are the optical trocars. If you can see, their tip is transparent. So we can put in the camera, the laparoscope, and lock them and then screw. See what we are piercing. So I'll just show you what I have here. So these are the optical trocars. Anuva, please keep telling me if I'm not visible.
Ma'am, the students can just click on the screen, your screen, and then they can maximize the picture, what you're showing.
So this is the disposable trocar, if you the cannula, and this is the trocar. So you put it in, and once you put in the scope through this, you can, this is easily, at present it's very loose. Once you put in the scope, it can be tightened and locked. So the scope and the trocar would be locked in place. This is for the gas inlet and outlet. And as you can see, the tip is transparent, so you can see the layers being pierced, right? So these are the optical trocars, and this is the non-optical but disposable trocar. You can also we have here. This is CONMED. So these basic instruments, I think everybody should know about. This is it. If it's a 10 mm, then it has a reducer with it, so that the 5 mm instruments can also go through. So this has been locked now. Again, we can release the gas by pressing this here. So once we want to deflate, we can just release it here from here, and the gas would be released. And this is, of course, the connection for the gas. So you can see this is disposable, but this is not optical, not transparent, but it has a very sharp cutting edge here. So this portion goes in. This is the safety measure, like with the Veris needle. This goes in and the sharp end comes out, which is very good for cutting through the layers if you want to. So, but nowadays we use the silence tip or the cone tip ones, so that the layers are not cut, they are just separated and go in. Like if these are the layers, the tip just goes in, and then rest of the layers are just separated. The moment we take out the trocar, they go back. Whereas with the sharp cutting edges, they cut through the tissues and go in. So that's not really preferable. This is the Hassan's trocar, which is used for the Hassan's technique of the open laparoscopic technique of insertion of the first trocar. In cases of previous surgeries and all, sometimes we do prefer it this way. So basically what we do is we make an incision. This is approximately 15 to 16 millimeters incision that we have to give. So this is a big one. And we tease through the layers, hold the rectus sheath, cut it, hold the peritoneum, cut it, and then put in the trocar. And then this trocar has these holes by the side. They have flanges, and they have the holes by the side through which a stitch is passed through the rectus sheath, and they are tied up so that the trocar does not move from its place, and then gas is insufflated. These are the scopes with the light cables shown, and we have the 0 degree or the 30 degree, even the 45 degrees are sometimes available scopes. You can see there is an inclination here. There is it's not like the cut end is not straight, it's slight. So that is the angle, 30 degrees, which allows us to see the various positions. Like if the cable is turned to the right, we would be able to see more on the left side of the left wall of the abdomen. So that is it. So it's very convenient, but it has to be the assistant has to be trained in this. It takes some time to learn where the cable has to be moved in order to see which side of wall. And otherwise 0 degree is there, which is like all angles are equal. So there is no it's got no relation with the position of the cable or the scope. Now, this is the 3-chip camera that I was talking about. Basically, it has a triple chip, which is the basic colors, red, blue, and green. And it is 1080 pixels resolution. And it has a gold lens, a prism assembly, and 3 sensors for the primary colors. And this is what we use for the scopes. Now this I'm showing, and normally we these days do only 5, we use the 5 cameras for all the surgeries. And this I'm showing the secondary port placement. So if you see, the incision should always be given in the direction of the Langer's lines so that the approximation is good for surgery and the pain is less, scar is less. Now we go in perpendicularly with the trocar. I'll just show you. So this is the trocar. It has to be held like this. It has to be resting on the palm. And then this finger should guide us so that there is no jerky movement. And even if there is, it doesn't just go in. It has to be acting like a guide. So we hold it this way and we gently screw in. Now the direction is very important, because if we are not doing it in the proper direction, see, if this is the abdominal wall, it has to be perpendicular. If we are going lateral, then the abdominal wall would be like this. It has to be like this. We cannot make a generalized statement. The abdomen is not flat, especially after inpatient. So for the primary port, we can go this way. But for the lateral ports, if the abdominal wall is tilted, we have to still go perpendicular to the abdominal wall, not perpendicular to the plane, perpendicular to the abdominal wall, so that there is no tunneling. And the moment we pierce the peritoneum, then we can tilt the trocar towards the pelvis, because then there would be no change of direction of piercing in the abdominal wall. That is very important, because if it goes like this, perpendicular, it can be moved in any direction. It's very convenient and it's very less painful, less straining for the surgeon as well as the patient. See, if it goes this way, this is like tunneling. It is going piercing through the abdominal wall. Only the tip is inside the abdominal wall. The rest is all inside the, the tip is inside the cavity. The rest is all inside the abdominal wall. So then just imagine maneuvering this. Our shoulders will be strained as well as there will be bruising on the patient. So to avoid that, it should be absolutely perpendicular, so it is freely mobile in all directions. So this is what I'm trying to show in this video. Just see. The moment the peritoneum is pierced, we direct it towards the pelvis as a safety measure so that the abdominal organs are safe. Now this is the next secondary port being placed. Again under vision, again just perpendicular to the abdominal wall. And the moment it's pierced, it goes in towards the direction of the pelvis. So if you see, there is no tunneling in these cases. Now, in cases of previous pelvic surgeries or previous abdominal surgery, there are multiple scars on the abdomen. So we have to find a safe point. So the safe entry points normally, which have been seen through studies, are the Palmer's point, which is the commonest used, which is 3 centimeters below the left subcostal border in the mid-clavicular line. Now we have to ensure that the Ryle's tube aspiration has been done. We must check with the anesthetist at this point, because in case not, and the stomach is full, then we may just enter into the stomach. So that aspiration must be ensured. Then we have the giant point, which is the left paraumbilical. It is in the left paraumbilical region at the level of the umbilicus in a straight line drawn from 2.5 centimeters medial to the anterior superior iliac spine and then vertically upwards. This point has an advantage that this port can be easily used for pelvic surgeries. Palmer's can be used to insufflate and as a primary port entry, but sometimes it's difficult to use it, especially for lower pelvic surgery, especially if you're stitching the word post TLH. Then we need to have either long instruments or it becomes very difficult. So this port usually is not used after the primary port insertion for pelvic surgeries unless the uterus is very big. And it can be definitely used for the upper abdominal surgeries. Then we have the Li Huang points. This is basically between the xiphisternum and the umbilicus. there is the falciform ligament there, which is normally cut through also, but doesn't really matter. So this is a safe entry point. Then we have the intra-umbilical port, which is not to be used in previous surgeries, but it is a, for the virgin abdomen, it's very convenient because the abdominal wall is the thinnest here. All the layers are fused. So, and it is relatively avascular. So, and cosmetically also much better. So it's very easy to create pneumo through this point. Now here I'm trying to show the optical trocar entry. So as you can see, this is the optical trocar. As I showed you, this is locked when the scope, once the scope is inserted. And then we just screw it in perpendicular to the abdominal wall. And as we go in, you can see the layers being pierced. And the moment we are in here, so we withdraw the scope, withdraw the trocar, and then we assemble the pneumo, the insufflator, but we do not connect it. We do not see, I have not opened this valve. We do not connect it till we are 100% sure that we are in. So despite going through an optical trocar, this is a safety measure one should always adopt. However experienced you are, we should never get casual about this. These are certain rules that need to be followed. That's why I'm telling you. So this is the uterine elevator that we commonly use with the colpotomizer cup. The cervical cup can be of varying sizes depending on the size of the cervix. And this is a screw to adjust the uterocervical length at which it can be fixed. So this is a video. I'm trying to show the how we insert the elevator and the cup. So I'm just applying jelly on this. Reason being, I don't want to traumatize the vagina. So with the jelly as a lubricant, we just insert it. I fixed the elevator at the uterocervical length. And now I would insert it into the cervix. And once it is done, then we would gradually remove the sem speculum while still holding the Alice forceps and just kind of push in the elevator. Right. So now the sems would be removed. And then push in the elevator. And after that, once we remove the Alice also, I'll do some ironing around the cup. Why? Because I don't want any extra hold of the vagina to go in. And secondly, I want the cup should be snugly fit in over the cervix, so that it's exactly the cervico-vaginal junction at which we are doing the colpotomy and nothing else. So this ironing part is very, very important. So these are the common instruments used. This is the bowel grasper, which we call the crochet. This is an atraumatic grasper, small one. This is a flat atraumatic grasper. This is a traumatic or a grasper with teeth. So it has two on one side, one on one side, like we use the Alice in the open surgeries, kind of, just to hold on to the tough structures. And this is the Maryland dissector with a curved tip, fine tip. And these are the parts of the instrument. Basically, this is the main instrument with the various attachments, as in the tooth forceps and the non-tooth forceps. This is the sheath, which is insulated. So we have to, at the beginning of the surgery, we have to check the trolley. Although the sisters do it, we should also check there should be no breach in the insulation of the instrument. And this is an outlet to allow for any secretions or collections of fluid, etc., plus the pneumo or the smoke that comes out. We can evacuate through this also. And these are the handles. This is the handle with a lock, and this is without a lock. So this is a lock for usually used for attaching to the tooth grasper, so that some tissues can be held and left to the assistant to retract. And once they are locked, it won't open. the jaws won't open. And this is the attachment for the monopolar lead. So any instrument can have a lead for the monopolar attachment, and it is then converted into a monopolar cutting instrument. So there is a handle with an electrosurgical lead and a rotator. This knob, I'll show you. This is a disposable one, but yet, if you can see, it has these sedation jaws here, and so it is a traumatic grasper, and it can be locked through this, and this is disposable, of course. This is the lead for the monopolar, and this is the rotating knob. So it can be rotated in any direction. If you can see, it can be rotated in any direction. So we don't have to rotate our hands. We just hold the instrument and rotate the knob. Now, another part that I want to tell is that we should never hold the instrument in a scissor holding manner. This will damage our thenar and hypothenar eminences, and we will not be able to operate for long. So it has to be comfortably held like this. It should be just resting on the palm and hold it this way during surgery. Whenever you want to open or close it and do any manipulation, you can always insinuate your ring finger and gently open and close. So it is to be held very gently, no tough holding, no force to be applied. Only instrument where we need to really apply force and do some manipulation is the needle holder. So if you see, the needle holder doesn't have that scissor kind of a grasp. It has a very tough hold here, and so it is being held this way. Anuva, am I visible?
Yes, ma'am, visible, ma'am.
So this is the lock for this to release once we lock the instrument, hold the needle, lock the instrument, and we want to release. So this is the knob, and it will open automatically. Right. So this is to hold tough structure like the needle. We have to manipulate, we have to suture. So we need to maneuver it this way. And imagine if you're maneuvering it in a scissor hold manner this way and applying so much of force, you won't be able to do the next surgery. So, so these are the types of handles and instruments. These are the various tips of the instrument that normally we have in the OT trolley. So this is the Maryland dissector I showed. These are the curved scissors. We can have the various type of, we can have the tough scissors also. Sometimes we have the parrot beak scissors, which are made of steel. They are something like this, something like the needle holder. So to cut the tough structures, these are the tooth grasping forceps. Rather than having these sharp teeth, we can have just gentle graspers, which is the Alice kind of forceps. These are fenestrated. Usually these curved fenestrators are for the holding of the tubular structures like ureter or fallopian tubes. And this is another kind of a tough tissue holdings forceps. These are the bowel graspers. This is the flat bowel grasper, and I showed the crochet earlier. Then this is the Babcock's. Then this is the crochet. So, and then these are the tenaculums usually used in myomectomies or in big uteruses to hold the uterus. Then this is the hooked scissor as the parrot beak I was talking about. This is strong atraumatic graspers, and this is the ovum forceps, what we call the ureteric graspers, oviduct kind of graspers. So these are the disposable scissors I was talking about. Yeah. So these are the disposable scissors. If you attach the monopolar lead here, so with the rotating grasper and the monopolar lead attached, it can be used to cut as an electric monopolar cutting. It can be used as a cutting blade rather than a cold knife or a cold silver. So these are the 10 millimeter traumatic graspers, which usually are used with along with morcellators or to hold on to the uterus during myomectomy. And this is the myoma screw that you can see if you zoom it. Yeah, here it is shown. This is the myoma screw, the laparoscopic myoma screw. These are the two types of suction, irrigation suction instruments. I think I have one here. So obviously I've got the discarded instruments. You cannot see the knob here, but the knob can be twisted anteriorly and posteriorly according to the direction. One can be for suction, one can be for irrigation. And as you can see, this is just not one single hole, because then if it holds on to some structure, a lot of negative suction is created. So it has small holes by the side as well, so that the suction is limited. And if it grabs the omentum or any other genital, like the femoral and the genital structure, they can be released very easily. So, and it is not very sharp at the end, because sometimes we even do some dissection with this. So these are the other one, the trumpet forms, in which one is for the suction, one is for irrigation. These are the needle holders I just showed you. Yeah, another thing I just forgot to tell you about needle holders. This is a right-sided needle holder for a right-handed person. If the curve is towards the left, that's a left-sided needle holder for the left-handed person. And if there is no curve, it's straight, then it's a straight needle holder, neutral. So this is just a small cliplet I'm trying to show how we do the endosuturing. So if you see the needle holder, this is a very small vascular bundle. Normally they are big ones. So see the right hand, it's a right-handed needle holder because I'm a right-handed person. So that is what I'm using. So once you go through the vascular bundle, whenever you hold it, once the needle is being held, as in open surgeries, 2/3, 1/3 of the needle holder and 2/3, 1/3 of the needle, and tightly lock it so that this becomes stable. And then with a gentle movement of the hand, it rotates. And that is how the vascular bundle is fought. And then a surgeon's knot is taken, the double throw at the first time. Now, see, the importance of the direction of the knot is very, very important. I was wrong at that point. So the direction is corrected. And then the second single throw. Now the smaller thread is on the lower side in the first knot, so it has to go up in the second knot. And that's how the surgeon's knot is tied. Now these are the specimen retrieval bags, which we call the endo bag. So basically it has a firm rim, a ring inside, and then it is a plastic bag to hold the specimen. Once the specimen, it comes in a rolled up manner, and that is how it is inserted inside the abdomen through the trocar. So once we unroll it inside, the specimen is put in, and then we hold it from here and pull it out. So this is firm, it won't break, and once it's out, it is partially out of the abdominal wall. We just unroll it and then take out the specimen piecemeal. So this is usually for cysts, for dermoids, whichever thing we don't want a spillage inside is taken out in endobags. Sometimes we even put in the uterus or the ovarian cyst or the adnexa or even the myomas. And if there is a colpotomy incision being made, we take out its mouth through the colpotomy incision and the specimen is taken when we do not want any spillage inside. This is the morcellator, and this has a blunt trocar because we are already in through the normal trocar, and then this is inserted, and this is the cannula, which has a sharp end, and this is the blade which goes in once the trocar is out. The blade is screwed in, which is very, very sharp. So what we have to do, we have to be careful about is that this bevel has to always face upwards. If it's facing downwards, there is an injury, there is a chance of injury to the omentum or the bottom. So this has to be taken care of. These are the washers attached. So now this is the morcellator bag, in which we there are two ends. One is for the camera and the insufflator, and the other is for the specimen. So this is the morcellator bag, which is available for in-bag power morcellation. These are the smoke evacuators. Yeah. So these are the smoke evacuators, the smoke filters, which we use during surgery. So this is attached to one of the secondary ports so that the gas is absorbed, and basically the smoke is, sorry, not gas, the smoke is absorbed. So otherwise there is the vision goes, the camera gets foggy. Now these are the post-closure needles. So basically it has a sharp end and a hook which goes in, puts in the thread, and through the other hole we pull out the thread through this. Another one we have is the Unimax. I don't think that's I've shown here. And this is the stapler to close the skin incisions. The small incisions are there. We just apply the stapler, and one staple is good enough for a 5 mm cut. So this is a video showing the staple application. See, I'm using the tooth forceps as a hook, and since the incisions are given in the direction of the Langer's lines, there is no need to apply even a second staple. One is good enough. And the third one is a intraumbilical. So this is also just elevated, and one staple is put. Sometimes for the intraumbilical incisions, even if you leave it as it is, then also it works. So just one staple and that's it. So you can see there's no further ooze, nothing. You don't need to apply treatment. So this is a latest instrument, ProxySure, for laparoscopic endosuturing. It is good. It is definitely very convenient for those who are not very well versed with the endosuturing part. But I must say one should never venture into laparoscopy without proper learning of the endosuturing. There is no shortcut to it. So this is another one, Overstitch, again an instrument for laparoscopic endosuturing. And a third one that I just got, this is normally not available these days because it was made of catgut. This is an endo. This is for laparoscopic suturing, but not endosuturing, endosuturing. So basically the already pre-tied knots are there. This is for structures like appendix or maybe tubal ligation. You just catch hold of the glue, put it in, and pull out the thread and press the knot with this. So the suturing is done. Now coming to the Energies devices. Anuva, do I have the time? Anuva?
I think the session is.
So you can just stop me whenever you want to. I'll just briefly talk on the devices.
Okay.
Right, just stop me whenever you want. So these are the type of energy devices we use. We have in electrosurgical energy devices, which is monopolar and bipolar, the ultrasonic energy devices, and the laser. So a basic monopolar and bipolar should always be there in the trolley of any laparoscopic surgeon because they are always required, especially for sealing of the smaller vessels, the capillary bleeds and all. Then we have ultrasonic energy, and then we have the advanced bipolar devices as well as the laser. So what is electrosurgery? Is application of alternating current to the biological tissues to achieve effects like cutting, coagulation, desiccation, pulverization. Right. So the to and fro movement of the electrons, with this movement, the kinetic energy is converted into thermal energy. That is the basic principle which we must know. And why do we need electrosurgical or energy devices? Basically for hemostasis. The main crux is we need it for hemostasis. So these are the basic devices, the monopolar hook. In this, you can see the entire instrument is insulated except for just the tip and the bend of the hook, which is very important. And this is the bipolar device with the connection for the bipolar cautery. This is the rotating knob, and this is like a Maryland forceps. So this is called Roby forceps. Why? Because rotating and bipolar. And this is the monopolar needle, which is normally used for PCOD drilling, and it comes out and juts in depending on the handle that we press. So normally, why don't we get electrocuted during surgery? This is a very common question asked. One must know that normally electrocution happens below 100 kilohertz. So whatever electrosurgical devices we are using, they operate or they generate frequencies more than 200 kilohertz. So we do not get electrocuted, right? Then this is the basics about cutting cautery, coagulation, cutting, pulverization, desiccation, vaporization. You can go through them, read it. This is just a theory thing. I won't go through it. This, the basic one must understand. Basically, in the monopolar electrosurgical unit, what happens is current flows from the generator to the patient back through the cautery pad that we applied into the generator. So this is how the circuit is completed. So our body is completing the circuit. This is very important for everybody to know that our body is completing the circuit. So that is why the earthing pad or the cautery pad is very important, because that is what is causing the earthing of this connection, of this cable connection. Without earthing, there can be currents, there can be shocks to the patient, burns or something. So, and this cautery pad needs to be applied to a very well vascularized muscular area. Why? Because that area would be a good conductor of electricity. If it is applied over the buttocks, which has fat, or to the bone, these areas are not good conductors, or they are rather insulators. So what will happen is current would get accumulated in those areas. As a result, there'll be a lot of cautery burns. So that needs to be avoided. Now, this is just a small video showing the monopolar cutting that I'm using to cut over the colpotomizer cup. This is the colpotomy being done. So if you can see, I'm cutting with the angle of the hook. I'm not cutting with the tip, because if you cut through the tip, if there is with a sudden release of tissue, your instrument may just go haywire, and with the force, it may just hit any of the vital structures. So if we press through the angle, we are under control. So it has to be done through the angle, through the bend, not through the tip. So advantages, I think you all can read. I don't need to mention. This is the bipolar. Now with the bipolar, what happens is the current goes in through the instrument, comes out through the instrument only. I'll just show you how. I don't have the bipolar here, but I can show you with any instrument. See, if let's assume this is the bipolar or bipolar. So the current comes out through this, and the moment we close the jaws, it goes in through the other. So with the two blades, it comes out through one blade, goes through the other, and back. So there is no way it is going through the body of the patient. And this is how a bipolar coagulation is done. Just a small snippet showing how we use the bipolar. That's it. The moment we approximate and put the cautery pedal, and it has to be done in spurts. We cannot just keep pressing the cautery pedal. It has to be done for short spurts. These are the uterines which have been ligated. So I'm just, as a safety measure, cauterizing it. Rather, I wanted to demonstrate, so I'm cauterizing. But they have already ligated. Now, what precautions to be used? So I can just tell them. Basically, grounding pad, as I said, it should be well vascularized area, and it should be a big pad. The cautery pad should be big. It should not be small, because if it's small, higher current goes through. So it should be wide. And inspect the insulation of all the instruments. It should be the lowest power setting should be used, as I said. The contact mode of coagulation current should be used for desiccation. It should be brief intermittent activation, not a controlled continuous prolonged. Stop the coagulation at the end of the visible vapor phase. We should not just keep on coagulating. Then what will happen is there'll be charring. And once you see, if this is the tissue held, and this is charred, and below it are the vessels going. The moment you try to remove the tip, the char gets stuck to this instrument tip, and it will come off. So the fresh spurt of bleeding would start. You cannot just keep doing it and doing it. So charring should be avoided. It should be just in brief spurts. The moment you see the vapor phase is gone, stop. And do not activate in close proximity to another instrument. That's very, very important. No two instruments should be touching each other. No instrument should be in contact with the bowel. No energy source should be in contact with the bowel. It's not necessary that the tip or the lever is in contact. Even this part should never be in contact with it. Then first you identify the source of bleeding. There should never be a blind cautery who may hurt or injure any of the vital structures. If you see that the tissues are getting stuck to the instrument because of some char with it, or some tissue left behind, it should always be clean. Now, what is the purpose of the advanced bipolar devices? The advanced bipolar devices, they have. So this is the advanced bipolar device, which is LigaSure. So what happens is the principle is compression, pressure, that is, and temperature and time. The more we compress, right, the more effect it will have. And basically what happens is there is denaturation of collagen and elastin. So this is very important. Once we lock it, we've held some vessel, some rough structure, whatever we wanted to hold on to. Like, see, just imagine this is a structure, the pedicle we want to coagulate. We'll lock it. We'll put the switch on. I mean, we activate the instrument. And once it's done, this has automatic sensors with the nanotechnology. It will automatically stop. And this also has a rotating knob with it. So once it stops, then we can just cut with the blade. So there is a system of having a blade inside which comes out and cuts the structure. So there's no need for us to coagulate with the bipolar, then take it out, then put in the scissors and cut. So, and that another disadvantage is we may cut extra. The non-coagulated tip also may be cut, so that can cause bleeding. So this is the advantage of these advanced bipolar devices. But the disadvantage is they cannot seal the capillary leaks. Why? Because the capillaries do not have collagen and elastin. They have elastin a little bit, but not too much.
Ma'am, can we start the next session? We are running behind actually.
Yeah, sure. I think I'm almost done. Just this ultrasonic is left. Just one part. This has an active blade, which has the piezoelectric crystal. This is the one which rotates at 55,000 revolutions per second. And this is the passive blade or the inert blade, which has the insulation. So this controls the temperature, the high temperature to touch the vital structures. So this is the protected layer. This has minimum and maximum modes. This maximum is for cutting, minimum is for coagulation. And that's it. Thank you.
Thank you so much, ma'am. Thank you for the amazing session on laparoscopic instruments. We'll run to the next session, that is on Forceps and Vacuum, which will be taken by Dr. Sunita Malik, ESIS Hospital, Faridabad professor, former professor and unit head, Obs and Gynae, Safdarjung Hospital. I'll request ma'am to take the session.
Thank you, Anima. I'll just start my video also and I think, can you see my video?
Yes, ma'am. Yes, ma'am. We can see the slideshow.
Okay. So I'll just put it in. Yeah. So my topic today is assisted vaginal delivery, also called operative vaginal delivery. We have two components of it, forceps and vacuum or ventus, that's what we call it. The use of forceps or a suction device to help guide the fetal head out of the birth canal. So two types I've already told you. So out of this, when should the assisted vaginal births take place? It could be non-rotational or rotational. Then we have this low pelvic and lift out vaginal births, which have a low probability of failure and most can be conducted safely in a birth room. It has a higher risk of failure and should be considered a trial be attempted in a place where immediate recourse to cesarean birth can be undertaken. So we have to do these procedures not isolated in the labor room. We should have an arrangement for cesarean section in case it fails. So what do we have is the pair of instruments that is forceps, which is designed to extract the fetal head. So the little bit just Chamberlain was the one family which invented it and kept it a secret for 100 years, before it came into the market. So after that, in 1747, we had this pelvic curve. Then we came with the locks, English lock, the axis traction devices, and the two specialized forces for rotation. This is the original Smelly's forceps applied for occipito-posterior position. Now, parts of forceps. Coming on to that, this is the blade. It could be fenestrated to facilitate a good grip of the fetal head. It could be solid, like Tucker-McLean, or it could be pseudo-fenestrated, where it is both, is there some depression is there in that. Toe of the blade, or it's also called the tip of the blade. Then the heel, where the end is attached to the shanks. That's the heel. Then there's a pelvic curve. So there's a, students know what they tell us. This is the cephalic curve. This is the pelvic curve. No, the pelvic curve is this one, you know, because this is the one which is going inside the pelvis. These inside out is the same curve. That's the cephalic curve. So no confusion should be there. That's the one where the students make a mistake. Then there is a shank between the heel and the lock. It increases the length of the instruments and facilitates the locking of the blade outside the vulva. This is the lock on the shank at its junction with the handle, and then the handles. So this is what is there. The tip, the cephalic curve, the heel, the shank, and the lock, and the finger guide, which is there in the Simpsons, and the handle. Okay. The types of locks. We have French, English, German, sliding lock. So all these locks could be there. French, English, German, pivot, and the sliding lock. Basic categories of forceps are classic forceps. We used to have long curve and the short curve. Then we have rotational forceps, Kilent, the specialized pipers for breech and buttons. These are the special ones. Basically, the classic ones are based on Simpson and Wrigley forceps. Most of the labor rooms have this Wrigley forceps, outlet forceps, that is their low forceps. They're typically used when the rotation is not required. Now, coming on to the shanks, it could be a parallel shank, or it could be overlapping when they are together. Overlapping shanks are there in Tucker-McLean and Elliott's. Parallel are in Das, Wrigley, Simpson, and Delhi. This is parallel shank. And see, in this, there is overlapping. We can't see, we don't have a space in between the shanks. Here also. Okay. The short curve forceps generally are outlet forceps. They are lighter as compared to the long curve forceps. They've got a marked cephalic curve, but slight pelvic curve. While the long curve have a marked pelvic curve, where they are generally used for mid cavity, which we hardly use these days. And there's the rotational forceps, which is got hardly any pelvic curve. This facilitates the rotation of head without moving the angle through a wide arc. It is used for mid pelvic rotation, like in in transverse arrest, and for correction of asynclitism. And it has got a sliding lock. This is the sliding lock. The sliding lock permits the placement. So once we apply at any level to accommodate the asynclitic head, then we move this instrument up and down so that the asynclitism is corrected, and it has got overlapping shanks also. Piper forceps is used for aftercoming head of breech. It has got a cephalic curve, reverse pelvic curve, long shanks, and an English lock. Button is not used these days. Previously, it was used for transverse arrest. So this is the button and the pelvis. And then, since we are not using the mid and high forceps, we used to have those Millen-Murray and Hank Denon forceps along with the axis traction devices. Just for your information, that these could also be there. So this is the axis traction device. It is either attached to the blades or the little lower down. Now, coming on to the new ACOG classification, which has come in 2020, outlet forceps is the one when the skull has reached the pelvic floor Scalp is visible without separating the vulva. Sagittal suture is in the AP diameter or in the left or right occipital anterior and posterior position, but this rotation should not be more than 45 degrees. So it has to be less than 45 degrees, then only we call it outlet. Low forceps leading point of the skull is 2 centimeters or between or below the ischial spine, but not on the pelvic floor. Sagittal suture is in the AP diameter or in the left or right occipital anterior or posterior position. Mid is the leading point is less than +2, 0 to +1 centimeters, but there is 1/5 palpable per abdomen. Rotation is not considered. High forceps is excluded in the latest classification. What are the functions of forceps? It is a traction force, rotation, protective cage, delivery of aftercoming head, vectors in cesarean section. When there's a deep head is deep into the pelvis, then it can help in taking out breaking the vacuum between the tissues and then taking out the head. Indications, no indication absolute, and clinical judgment is of course required. It could be maternal, fetal, or combined. Maternal is inadequate expulsive forceps. She's exhausted. It's a prolonged second stage of labor, or to cut short second stage of labor, like in medical disorders, previous cesarean section, or cerebrovascular disease. Fetal could be non-reassuring fetal heart rate in second stage, very low birth weight baby, preterm baby, suspicion of fetal compromise, or aftercoming head of breech. This we should know where not to apply. See, absolute are before full dilatation of the cervix. You know, earlier it was there that vacuum can be applied in less dilatation. No, it's now no longer applicable. Both vacuum as well as the forceps have to be applied once there is full dilatation. So otherwise there are more trauma to the fetus, more trauma to the cervix. So please don't apply vacuum in 8 centimeter, 7 centimeter. Vacuum extractor especially is contraindicated with the face presentation. Relative are fetal bleeding disorder, like alloimmune thrombocytopenia, and that's for vacuum. A predisposition to fracture, for example, osteogenesis imperfecta, if you know it beforehand, then forceps is to be avoided. Blood-borne viral infection in the mother are not an absolute contraindication to assisted vaginal birth. We have to see what was whether we to prioritize whether we need it or not. Now, what are the prerequisites for these deliveries? This is the must: experienced operator, adequate maternal analgesia, neonatologist should be around, backup plan if the procedure fails, facilities for cesarean section, willingness to abandon procedure when difficulty faces. That's the most important. Don't go on and cause trauma. What we need is informed consent, fetal heart should be engaged. Please don't apply any instrumental delivery if the head is palpable per abdomen. So first thing to be seen is whether the head is palpable or not. Cervix should be fully dilated, membrane should be absent, fetal position exactly known, because we have to have less than 45 degree of rotation, and it should be either AP sagittal suture, preferably it should be in the AP diameter. CPD to be ruled out, and pelvis should be adequate. All instrumental deliveries have to be documented, with starting from consent, the indication, the type of instrument which you are planning to use, and the resulting maternal and fetal complication or injuries. Everything should be written. Anesthesia could be pudendal block or labioperineal infiltration for outlet forceps. Anything beyond outlet, we need a pudendal block, like in aftercoming breech also. Regional or general anesthesia for low and mid forceps. Empty the bladder, do the examination to assess the state of cervix, the membranes, the presentation, position, final assessment of pelvis. Episiotomy should be done during traction when the perineum bulges, preferably. So many times we have seen the episiotomy given beforehand and the forceps or the vacuum fails, and then we go for cesarean section. So she keeps on bleeding from episiotomy also. So we have to stitch both the parts. Please, it's better to do it once it has come down and perineum has started bulging. Types of application, cephalic application is the one when the blades are applied along the sides of the head, on both sides of the head. Grasping the biparietal diameter in between the widest parts of the blade, and the long axis of the blade should be corresponding to the occipito-mental plane. This is the one from the occiput to the mental. I'll just show you the picture. And the pelvic application is we don't see the head, we go according to the pelvic wall, ignoring the position of the head if the head is not, even if the head is not rotated. So serious compression effect on the cranium can occur, so it should be avoided. See, this is the one I was talking to you. The correct application, starting from parietal bones to the mentum, with the sagittal suture in the midline. This is the correct cephalic position. Now, for low forceps, we need to identify the blades first. So what we do is we keep it in front of us, lock of the blade, then we have to give traction and the removal. So this is which one we have to see which one is the left and which one is the right. The one which is facing towards the maternal left side is the left, the other one is right. The forceps should be, so first we select the left blade. The forceps should be placed in front of the pelvis with the tip pointing upwards and pelvic curve forwards. This is what it is, so like this. And parallel to the opposite inguinal ligament. On the, since I'm holding the left blade, so this thing is parallel to the right inguinal ligament. So this is how I hold it. So then I put, of course, after proper analgesia, we put in a little on the right in the side, and gradually we just rotate it and bring it little down. So that's the movement, you know. Put it in the left position, just here, and then take it up. The blade should be taken up, and once that is there, then draw and lower the handle, and the assistant holds it. And then the other blade is also applied. Same way, holding it. The hand should be behind in the perineum. Along your finger and along your finger, you're putting it in. Take it up and then bring the handle and lock it. This is wrong application. This is the pelvic application. And you see, you won't be able to lock it once you have done this. So if you don't see the position and you've put it like it's a sagittal suture is in AP diameter, then there is a problem. So check for, how do we check for correct forceps application? Sagittal suture should be in the midline of the shank. Shanks run oblique to it. Application is towards bromastoid orientation. That's if operator is unable to place more than a fingertip between the fenestration of the blade and the fetal head on either side. So this is what it is. Yeah. We should be able to put in the finger there. Posterior fontanelle should not be more than 1 finger breadth above the plane of the shank of the forceps. So once if we have this occiput, we see, we feel for it, and then it should not be more than 1 finger above the plane of the forceps. If it is not so, and if you try to pull out, then the chances are that deflection of the head will occur. So positioning of the finger, compression force, the least desirable aspect is kept minimum by applying traction with middle finger between the, this is what, the middle finger in between, and the ring and the thumb, index fingers on the finger, on the guard. So this is how we have to pull it out. Traction can be applied in sitting and standing position. In fact, we are standing position if you are not able to pull out, but thing is, you should not be pulling with the force applied at elbow. This part should not be there. It should be only the wrist movement. It should be there. So traction is applied at the wrist. So like this. No, not like that. So that's too much. It causes more trauma. So this is the final steps. Put the forceps, rotate it, bring the handle down, the other forceps, then try to lock it. Put this finger here and the two other fingers on the sides. And once the head is come out, then take it up and remove the forceps. Direction of the pull. In low forceps operation, we need to pull it out depending upon the station of the head. The direction is downwards and backward until the head comes to the perineum, then horizontal, straight up till the head is almost crowned. Direction of pull is gradually changed to upward and forward towards the mother's abdomen to deliver the head by extension finally. So this way it goes like this. This is what it is. First downwards and backward. Once it has come lower down, then it goes straight out. And once it has come to the perineum, then we go up to mimic the extension movement of the fetal head. In outlet forces, only two fingers are to be introduced. Traction is applied straight horizontal, upwards and forwards. And removal of the blades, since we put in the right blade last, we remove also that first. So it's not that we applied left blade first, we will remove the left blade first, because the right one is above. If you see this law, the right one is above. So first we take out this one and then the left blade. So that's to be seen. Mid forceps, if you're experienced enough, like you've got one who's done it before, most of the times, it is not being done these days. Our obstetrician in present generation, they are not doing it. So basically its indication is in following manual rotation. There's the Sagittarius suture is more than 45 degree rotated, and then we rotate it manually, and then long curved. We need a long curve. This rotation is generally at the mid pelvis level. So many times I have seen the forceps being applied and written in the file as outlet forceps, but actually it's low or low mid forceps. So, so then the chances of trauma are also more. GA is preferable. Introduction is after prior correction of malrotation. It could be without access traction device or with access traction device. So once the traction is to be given, it is always first downwards and backwards, then horizontal, upwards and forward. With access traction, the traction rod goes parallel to the shank. So that automatically will take it below and then up and up. Key length rotational forceps, again, if one is trained, we have seen our seniors doing it. So we have this wandering method, which is used in occipital transfers or deep transfers. This thing. First, what we do is instead of having left and right blade in key length, we keep it like this so that, because the cephalic presentation, instead of left and right, we have anterior and the posterior blade. First, interior blade is to be applied, but for that, we need to, in wandering, we need it little towards the face, rotate it along the face and bring it anterior, and the posterior blade goes behind the head. Then we correct the asynclitism and then try to rotate the head along with the rotation of the shoulders by the assistant. So that is the basic principle. You should just know it. But these days, hardly it is being done, and we are, since the cesarean section has become safer, so that's what it is being done. Directors, when the head is low and associated with anterior asynclitism, then anterior can be placed between the parietal bone and the symphysis pubis, and the posterior in the hollow of the sacrum. Why do we want to wandering method? Because there's more space in the hollow of the sacrum. We put it there and then bring it anterior. So that's the wandering method. This is what the procedure is. I don't think I should be telling about this. You can read about it. The rotation application of the blades is to be checked again. The forceps handles are depressed, the handle tips are brought into alignment to correct the asymptotism. This is very important. I hope you know the asymptotism. When the sagittal, this transverse arrest, the sagittal suture may not be in the midline. It could be little posterior or interior. So that's asymptotism. So once we applied this forceps, we correct this and then rotate it. This is the method of application. This is the classical method. We put anterior blade up and then rotate it. This is the wandering method. And once we have corrected it, then we rotate it and take out the head.
That's good.
So basically, if we have slight left or right occiput oblique, the blades are lined up and applied according to the oblique orientation of the head. So what we do is we again we do pelvic present this thing. So we don't go like this according to the pelvis. We go like this. Little if it is less than 45 degree, we'll do little this, little according to the position of the head. So the sagittal suture should be in the midline. That's very important. And gentle and gradual rotation through 45 degrees towards the midline is performed without traction by slightly elevating the handles and rotating it through an arc. Once the rotation is complete, blades are again checked to ensure that they are not slipped off, and then we give the traction. Coming on to occipito-posterior position, blades are to be applied as usual, but they should be equidistant from sinciput and occiput. Again, the application is the same from mentum to the parietal, to occipito-posterior position. The pelvic curve is above. So same way we apply it. So traction horizontal till the root of, first we do bring it out till the root of the nose is under the symphysis pubis. So that's what it is. So this is the occipito-posterior position. So till this part comes under the symphysis pubis, this one. Then we go up towards the perineum, and finally, once the headers come at the perineum, little out, then we go down. So that's the position, and this is very important. Otherwise, there are more chances of having complete perineal tears and the injury to the mother. This is if the disengagement of the head occurs, it can lead to cord prolapse. These are the maneuvers. Canzoni Smelly maneuver with classic forceps. We are not doing it. So I will just stop it. This is about the occipito-posterior position, made first outwards. This is what it is, outward and posterior till the area between the bregma and the nasion lies under the pubic arch, and then up, and then finally down. So that is how we do in occipito-posterior position. Face presentation, blades are to be again applied along the occipitomental diameter. Traction is applied downward till the chin appears under the symphysis pubis, and then upwards, delivering the nose, the eyes, brow, and occiput. So this is what it is. Bring it down, and then up. After the chin has appeared below the symphysis pubis, then we go up, because the face is delivered by flexion. After coming head, Piper forceps, specially designed for this. Forceps to be applied when the occiput lies against the back of the symphysis pubis. And mind you, this after coming of head is never outlet forceps. It's a low, mid, or mid forceps. So but it's a long blade with no pelvic curve. So that's what the specialty of Piper forceps. Blades are to be applied from below after raising the leg, but don't raise the baby too much. So this is what it is. So don't raise it too much. Then there'll be a transaction injury to the neck. So little above the horizontal, that's important. Traction to be maintained in an arc which follows the axis of the birth canal. This is what it is. Baby's little up. We apply it from below, left and the right plate. And then we take out the baby by flexion up and along with the trunk of the baby which somebody else is holding. Okay. Advantage of this is that delivery can be controlled by giving pull directly on the head and the force is not transmitted through the neck, which we may do wrongly in a assisted breech delivery. Flexion is better maintained, but the head should be delivered slowly over 1 minute to reduce compression, decompression forces so that the intracranial bleeding does not occur. So what are the difficulties in forceps application? Difficulty could be in application if you didn't see the dilatation of the cervix, which you didn't see the engagement of the head. That's what I said. First, do per abdomen before doing any instrumental delivery. Then there could be difficulty in locking. Either the application is an unrotated head or the blade is not inserted properly. One is more inside than the other one, so then that can happen. Or we didn't depress the handles against the perineum before locking, or the cord has entangled, then locking will not be there. And please don't do any traction if locking is not proper. Difficulty in traction is undiagnosed occipito-posterior position. You didn't see the occiput and the sinciput, see the pinna and then finally decide. And you are pulling like in the occipito-anterior position, then there is a problem. Or faulty cephalic application. Suture was a little oblique and your application was not right. Wrong direction of traction, first down, up. But if we just start pulling it like this, then it would rather get stuck. Or there is undiagnosed mid-pelvic contraction or a constriction ring. So then there is a problem. Slipping of blades, blades are not introduced far enough, or again, occipito-posterior position not diagnosed, and we have applied it as occipito-anterior. Maternal and fetal complication injuries, we know vaginal, cervical, extension of episiotomy, complete perineal tear, injury to the femoral or the lumbosacral areas, PPH and purpural sepsis if we are not careful. Remote as painful perineal scar, dyspareunia, low backache, stress urinary incontinence, anal sphincter dysfunction, these could be there. Fetal is asphyxia, facial bruising, intracranial hemorrhage, cephalhematoma, facial palsy, and skull fracture. If you are using undue force or too much of compression is being done, you would not put your finger in between the shanks so that then it can happen. Remote is cerebral or spastic palsy. There are 2-3 terms which you should know. Prophylactic forceps, it is used, same refer to outlet forceps only to shorten the second stage of labor. So we generally, it's an outlet forceps. And we don't want her to go on eclampsia or medical diseases, previous cesarean section, post-maturity, low birth weight, deep epidural anesthesia. We want to cut short the second stage. That's prophylactic forceps. Trial of forceps is a tentative attempt of forceps delivery in case of suspected mild mid-pelvic contraction with the preamble declaration of abandoning it in favor of cesarean section if moderate traction fails to overcome the resistance. You have applied the forceps, you give some traction, it doesn't move at all, you leave it there only, don't go on. It's performed in operation theater, keeping everything ready for cesarean section. Failed forceps, when a vigorous but unsuccessful attempt is made with the forceps, anticipating a successful forceps delivery. Mostly it is due to lack of obstetric skill or poor clinical judgment. Factors responsible are CPD, incomplete dilatation, malposition. This is the most important, which I have seen our residents, they don't look at the sagittal suture, they don't look at the occiput, sinciput, and they apply it. So then pelvic, it becomes more of a pelvic application rather than a cephalic application. Oblique head pada hua hai, or they try to pull it out. Constriction ring, big baby, mid cavity delivery. Forceps is considered failed if there is no advance with each pull, undelivered after 3 pulls with no descent, And if it fails, we need to do a cesarean section. And then there is a problem, the cesarean section, the head is low down because of your pulse. Patwardhan bhi aana chahiye sasa. There are higher chances of failure when maternal BMI is more than 30. Short maternal stature, estimated weight of greater than 4 kg, or a clinically big baby, head circumference above the 95th percentile, occipito-posterior position, and if head is palpable 1/5, then there are more chances of having failure, mid-pelvic birth. When should it be discontinued? I've already said the forceps when should be discontinued if we cannot apply it easily, handles are not locking, there's no descent, and no rotational forceps birth if rotation is not easily achieved with gentle pressure by an experienced obstetrician. How many? Not more than 3 at all. And prolonged application of instrument greater than 12 minutes. Don't go on and on. So that's should be considered as failed forceps. Okay, coming on to the vacuum or the ventouse, that's what we call it. It's a device designed to assist delivery by creating a vacuum between it and the fetal scalp. The pulling force is dragging the cranium, while in forceps, the pulling force is directly transmitted to the base of the skull. So that's the difference. Vacuum just pulls on the cranium, while this is goes against the skull and then pulls out the whole of the head. That's why less chances of fetal injury in forceps. History, I just don't want to go into this. What are the types of vacuum cup? It could be rigid cup or it could be a soft cup. Rigid, the original one, metal, Malmstrom, and bird modification, funnel shape, Kobayashi, bell is Michivac, and mushroom is M cup, also known as M cup, soft ones, this elastic ones. That's what we have. This one, you know, this is Kobayashi. Malmstrom introduced it in 1954, metal cup with then curved rounded margin, stainless steel, original 60 millimeter outer diameter. We have now 3 types of cups, 60, 50, and 40. It combines the vacuum port and the traction in the center. Limitation are low risk of pop-offs. So this was the Malmstrom, where the suction and it was in the center. The bird modification was they separated the vacuum port from the traction apparatus. See, this is the vacuum port and this is the traction. So this is the bird modification, and now further modifications have been done. This port has been placed laterally also. So this is what it facilitates the placement of flexion point in a deflexed head. So the suction and traction same. Then the suction and traction separated in bird modification, and further modification is this one, lateral. Soft cup, like this one, we have. This is funnel shaped cup. Prototype is Kobayashi's elastic cup, introduced in 1970. Diameter it's got a fixed diameter of 65 millimeter. No stignon required. We don't wait for the pressure for 8 minutes like we do in the metal cup. And then it has got a release, valve to reduce the vacuum pressure in between the contraction. This is the one we can release it also a little bit. Increased failure rate when used in occipito-posterior position and occipito-transverse position. So higher failure, 25% with this than the metal cup. But then nowadays we don't use vacuum. Even the indication of forceps of vacuum become almost the same. That is, the rotation should not be more than 45 degrees. So avoid doing that. So it's not meant for rotation. This is a bell-shaped Michivac cup, easier placement, less genital tract trauma, less pop-off, slight, but there are more chances of sphelhematoma as compared to Kobayashi cup. Mushroom cup, another one. We have now handheld pumps also available along with that. This is disposable, semi-rigid, better efficacy, less trauma. This is a hybrid of plastic device and a stainless steel Malmstrom cups. So rigid cups had a higher success rate. Chignon formation is required, more time consuming. So if there's a fetal distress, it's better if we have time, then only we should be applying it. More scalp trauma and maternal injuries, more suitable for occipital-posterior transverse position, easy to use. Indication and contraindication is, again, to cut short the second stage in medical disorders, inadequate effort, exhaustion, prolonged second stage. Contraindication is, don't apply it in breech or face presentation, non-vertex presentation, premature babies, suspected macrosomia, fetal coagulation defect, delivery which requires rotation, which I have been telling you again and again, and excessive traction, incomplete cervical dilatation and scalp trauma already there. It should be avoided below 32 weeks of gestation, with caution between 32 and 36 because of chances of epithelioma, intracranial hemorrhage, subgaleal hemorrhage, and neonatal jaundice. See, it is not contraindicated when we have done fetal blood sampling procedure. Earlier they used to say, no, you've done scalp vein sampling, don't do it. But now it is said that can be used, or it can also be used after applying the scalp electrolyte. So this is what is the algorithm for this thing. We need to have anesthesia or analgesia. Bladder should be empty. A, B, C, D, E, F. Cervix must be fully dilated. Think of the position of the head. And always look for a big baby. You know, then even if you have taken out the head, the shoulder dystocia may occur. Equipment should be ready. Extraction should be ready. Place cup in a proper position in relation to fontanelle on flexion point. I'm coming to that flexion point where to apply. So once it has been applied, check all around. That's very important. The vagina should not be there. If dilatation is not full, then cervix may be caught in this, then there's more chances of avulsion of the cervix or the vagina. So then start, once that is there, the chignon is formed. Try to pull it along with the maternal contraction and halt the contraction between the halt the traction between the contraction, halt the procedure if cup disengages 3 times. If no progress in 3 pulls, halt the procedure again after 20 minutes of use. So be prepared to do a cesarean section. This is H. I is incision, evaluate for episiotomy when head is crowning, which may not be necessary also. J is remove the vacuum cup when the jaw is reachable. So that's when once we have taken out the baby, the jaw is reached, remove it. So this is A, B, C, D to A to Z for vacuum. Flexion point. This is a flexion point, you know. You have to apply it on the fetal head. Posterior, once you have applied rightly, the posterior fontanella should be 3 centimeters above from the midpoint of this cup, and the interior should be 6 centimeters. So this is very important. This is important because when we are pulling it, it will keep the vertex in flex position. So what will happen if we apply on one side, asyncretism, we apply it interiorly, the deflection of head or asyncretism as well as deflection, both will occur. So it has to be here. 3 centimeters for posterior fontanella and 6 centimeters for anterior fontanella. So this is very important. You should identify the sinciput and the occiput and apply it in the midline. That's this thing. Otherwise, chances of failure and pop-off are there. Okay. Preliminaries, clean the part, drape the patient, empty bladder, repeat paravaginum examination for dilatation, check all the connections and the vacuum on a gloved hand, adequate analgesia, apply it on the flexion point. Index finger is run around the periphery of the cup to check any maternal tissue entrapment. It is always done after placement of cup and before application of vacuum. After application of vacuum, we create the vacuum to about 0.2 kg per square centimeter, increase to 0.8, 600 millimeter mercury. Rigid cup is in increments, 0.2 kg per centimeter every 2 minutes. So total 8 to 10 minutes are needed. For soft cup, within 1 minute, we can raise to this level. So traction is applied in the perpendicular direction by right hand during the uterine contraction, and the thumb of the left hand is placed on the surface of the cup. So like this is the one we are giving traction, and this is against the surface of the cup for counter traction, and forefinger against the skull. So this is what we do when we trying to pull it. Okay. And direction of pull should follow the curve of the caress of the maternal pelvis. That's very important. So this way, like in forceps, in conjunction with uterine contraction and maternal efforts. This is what I was telling you, the counter traction, finger and the thumb here, and the traction along the forceps, whatever type of cup you are using accordingly on the handle. So we have a descent phase in this and the outlet phase. When the head is delivered, release the vacuum, remove the cup, complete the birth of the baby. It should be carried out within 20 minutes from the initial application of the cup. If we take more time, then more chances of fetal injury. Okay, so this is what it is. Abandon the procedure in 3 pop-offs, more than 20 minutes. Scalp trauma observed after any pop-off. No descent after application and traction. Neonatal complication, injury to the scalp, caput succedaneum, fell hematoma, subclavial hemorrhage. So that was there. This is just to differentiate afterwards whether it's a fell hematoma or subclavial hemorrhage. So this signon is going to be formed along the suture line, resolve within 24 hours. But subperiosteal collection does not cross the suture line. In vacuum, it is more, and resolved only after a few weeks. In this, it is subaponeurotic and periosteal, white space, life-threatening, cross suture line, and swelling changes with position of head. Observed within 12 hours, may progress in next 48 to 72 hours. This is what it is. The subgaleal hematoma and the cephalic hematoma. Okay. This should be seen, and that's why neonatology immediately they see for this. Others are retinal hemorrhage, facial palsy, brachial plexus injury, skull fracture, neurological complication, intracranial hemorrhage, and spinal cord injuries. What is better for this? Success of forceps, if really indicated, is more than with the vacuum extractor, but forceps is more likely to be associated with perineal tears. Maternally, this episiotomy in vacuum 50 to 60%, but with forceps we need in 90%. Significant vulvovaginal tear, sphincter injuries, PPH, bowel incontinence. So that's what lacerations could be in both, but more in vacuum. The fetal injuries are more in the vacuum as compared to the forceps. Perinatal outcome, they're again same, hematomas and hemorrhages are more in vacuum. With forceps, we have injuries and the fractures and the nerve palsy, very rare death. So little bit auto rotation is better. It's not a space occupying device. Traction force is less, comfortable and lower rate of maternal trauma. Analgesia need is less pelvic floor injuries. Postpartum also discomfort is less, easy to learn. More effective for forceps, more effective and moderate traction is required. Quick in cases of fetal distress, safe for any gestational age, for aftercoming head, less neonatal problems, high rate of success. So this is the same which I was talking to you. Measures to be taken for both: informed consent, show empathy, and available for discussion with attendants. Documentation of presence of pediatrician. Then document efforts to look for injuries to mother, for the proper management of third stage of labor. Send group for cross-match for high-risk cases. Document OT and anesthetist was kept ready for cesarean section. Document if there is any refusal for cesarean section. Thank you very much. If there are any questions, I can answer that. I think I'll stop sharing. Yeah. I have finished it in time. So I've covered up Dr. Kanika's time.
There are a few questions, ma'am.
Okay.
One is, ma'am, in case of malpositions, we prefer cephalic or pelvic application of forceps.
So we don't apply pelvic application in rotation, malposition, and then, but malposition, I've already told these days the indication is only up to 45 degree of oblique diameter, not more than 45 degree. We don't do it for transverse and all. So less than 45 degree. So we apply according to the cephalic presentation, and then we try to rotate it with the contraction. So that's what it is.
One more question, ma'am. How good is the Kiwi cup?
I'm sorry?
How good is Kiwi cup? The vacuum one.
Oh, actually, but these are all modifications and for the, you know, portability. So I haven't applied, I mean, I haven't used it personally, but they say, yes, it is good. And one thing is key, it should be, indication should be proper. You applied it nicely and then pull it out. Don't go on and on. So personal, I don't have any experience with Kiwi cup. We have this metallic cup and this one, Kobayashi cup in our labor room, which most of the labor rooms have. So these are good. In fact, this elastic cup, the soft one, is used more than even the metallic cups these days.